PPT share screen.
Oh, very good morning, everyone. We will start. A very good morning, everyone. We will start a session in few minutes. Welcome you all to the 6th International Conference on Dentistry and Oral Health, organized by BioLeaks and in collaboration with our esteemed scientific partner, Apatento, Asia Pacific Association for Dental and Oral Health, and our academic partner, Tagore Dental College, Chennai. I'm sure you had a great day yesterday with us and hope to see you the same enthusiasm from all the presenters and attendees today. I would like to welcome all our honorable dignitaries and eminent keynote speakers. Dr. H. Esther Nalini, Professor and Head, Department of Periodontics, KSR Institute of Dental Science and Research, India. Dr. Himanshu Srivatsava, Vice Principal, Associate Professor, Department of Oral and Maxillofacial Pathology and Microbiology, Aditya Dental College and Hospital, B, Maharashtra, India. Dr. Narsimhan, Professor, Department of Prosthodontics, Tagore Dental College, India. Sheetal S. Chowdhury, Professor, Department of Oral and Maxillofacial Pathology, Yarla Dental College and Hospitals, India. And our session chairs of our day for main hall, Dr. Om Nijandan Kumar, Associate Professor, Conservative Dentistry and Endodontics, Adi Parashakti Dental College and Hospital, and Dr. Vaishnavi, Reader and Head, IC, Public Health Dentistry, Tagore Dental College, India. For Hall 1, Dr. Karpagavalli Shanmugasundaram, Professor and Head, Oral Medicine and Radiology, Seema Dental College and Hospital, India. And Dr. Ramya R., Professor, Department of Orthodontics and Dentofacial Orthopedics, Adi Parashakti Dental College and Hospital, India. And for Hall 2, Dr. A. Selva Balaji, Reader, Department of Pediatric and Preventive Dentistry, Adi Parashakti Dental College and Hospital, India. And Dr. Preeti Archana, Senior Lecturer, Department of Pediatric and Preventive Dentistry, Adi Parashakti Dental College and Hospital, Malava, Utturu, India. I welcome all once again to the 6th International Conference on Dentistry and Oral Health. I hope you all will have a great day with us today. I would like to welcome our keynote speaker of today. Now, I would like to welcome our keynote speaker, Dr. H. Esther Nalini, Professor and Head, Department of Periodontics, KSR Institute of Dental Science and Research, India. Ma'am, over to you, please. Esther, ma'am.
Yeah, good morning. Actually, I have some problem with my video.
Okay.
But are my slides visible?
Yes, ma'am, your slides are visible.
Yeah. So am I audible?
Yes, ma'am.
Sorry for the delay.
Not an issue, ma'am.
My network here, so I had to do a little bit of arrangement. So good morning, everyone. And thank you for this opportunity, and thanks for your patience in waiting for me to start. So my topic today is biopolymers applications in. So we all know polymers, right? Polymers are monomers combined. And we have these biopolymers, which are specially macromolecules, which are mainly proteins, the nucleic acids, and the polysaccharides, which are formed by the living organisms. So it can be a plant source or an animal source or a bacterial source. So this is the
Your presentation.
gloss. Some interruption was there. Shall I continue?
Yes, ma'am, please continue.
So we have a lot of different types of polymers. We know monomers. By polymerization become polymers, and these polymers again classified into biopolymers. So the biopolymers are those which are occurring and produced by the green plants, animals, microbes, and fungi during their life cycle. Now these are natural when they are produced by the organism's living cells, and they are produce it through abiotic chemical routes. So today I'm going to concentrate on the natural biopolymers. So of these we have the proteins, which are collagen, silk, fibrin, and you have the polysaccharides, which include chitin and gum, starch, and all of these things. So when we see what these are individually, we all know collagen is very abundant in all animal forms. And so it is a good protein with a lot of great physical properties as well as biocompatibility and all the advantages for it to be used as a biopolymer. Then we also have gelatin, which is hydrolyzed collagen with similar properties and biocompatibility, which allows its use in our medical field. And we have this chitosan, which is a protein, which is a polysaccharide from the crustacean shells. And this chitosan is biocompatible as well as has some antibacterial properties with a few mechanical properties and biocompatibility, which facilitates its use in our field. And we know about the other ones like our starch, which is abundantly available, cellulose, which is again very abundantly available polymers, which are being used as biopolymers. So this is just an idea to get about chitosan. So this is from the crustaceans, the shell of the crustaceans, and the composition is seen here. So we can see that are found, and this bundle of chitin protein powders and chitin, and this chitin on deacetylation is converted into chitosan, which has a wide use as a biopolymer. Now this is and we have so many which is from the bomboids mori cocoons, and this through various processing finally we can get the silk fibrin, which can be used in multiple forms as sponges or films or modified by electrospinning into various structures and hydrogels, which can be used as scaffolds as well. This is just to get an idea about the polymers, biopolymers. Now, what is going to be the difference between your natural biopolymers and the synthetic polymers? When we talk about natural biopolymers, they have a well-defined structure, a very compact structure, and they have primary, secondary, and tertiary arrangement of the monomers in a form that you have a protein folding with, and we call it monodisparity because we have the same monomer dispersed into the entire polymer. When it comes to synthetic, the structure is more simple and more random, and we find polydisparity in case of dispersity in case of the synthetic polymers. So we are going to look at the natural biopolymers. The advantages of these natural biopolymers. Now we all talk about sustainability. What's sustainability? We consume in a way that our consumption is not going to affect the needs of the future generation. So biopolymers are sustainable products which are very effective. And apart from that sustainability aspect, in case of living, we also have to look at the other properties. It's compostable, it's biodegradable, it's biocompatible. It has its own antimicrobial properties. It's non-carcinogenic because there's no immunogenic reaction when it's placed inside our body. And it's cost effective and environmental friendly as well. Now, how are these forms? When it comes to our periodontal aspect, it's most commonly used in case of fibers, nanofibers, or films, and hydrogels. Hydrogel is a polymeric form which has an affinity for water and gets swollen up, and that can play a role as a drug reservoir as well as a scaffold. Now, there are various these biopolymers can be manufactured. So we have stereolithography, fused deposition modeling, we have selective laser sintering and 3D printing as well. So these are different ways in which these biopolymers can be converted into when we see there are certain types. So you get, in case of 3D printing, you get a highly compatible structure suited to our need. So these are advantages of 3D printing as well. Now, when we look at the different things, the polymerization technique where we have the UV laser, which is used to cut and cure the polymer in the required manner. So we have the liquid polymer building which contains the polymer, and you have the building platform. So your UV laser shapes and cuts and cures the polymer scaffold in the way we want it. So that we have the fused deposition method also, where we have the polymer in layers. This is a kind of a 3D printing technique. Selective laser sintering, again, the laser is used to sinter the polymer, the into structure that we require, and it's done on a platform, and it's also an additive technique. 3D printing again is an additive technique where you have a schematic 3D scaffold, and the polymer is converted into the required scaffold. Now we have thermally induced phase separation technique as well. Sorry. So here and converting it into a film, and when it cools, it becomes a it solidifies and you get the film. Now here a gas forming is a technique where you have gas forming which compresses the polymer into a solid disc, and it's left in the carbon dioxide chamber for several days, and during this period the gas infiltrates the polymer, creating pores. Now the advantages so emulsion freeze drying system, here freeze drying is used to create porous scaffolds. The structure that you require, and within the well-defined structure, the freezing, the solution, your polymer solution is kept, and then the solution is frozen. So during this process, later on, so when you have sublimation under vacuum condition, the ice crystals that were formed during the freezing is directly converted into vapor. So you finally land up getting a porous. Emulsification technique can also be used by adding immiscible phases such as any other organic solvent into it to form a stable emulsion. So that's the thing we see in the first picture of the freeze drying process of forming thermoplastic polymers by dipping this mold into a solution of polymer, and you draw off the solvent. So this is a solvent casting technique and particulate leaching techniques. Spin coating technique is another method. It looks similar to the solution casting to a certain extent. Here, what do we do? Instead of directly casting the film onto a substrate, you mix the polymer and the inorganic salt solution, and you cast it on a substrate. Then you spin the substrate, and it's placed on a substrate is placed on a spin coater and then spun. So in the whole process, the film thickness is controlled by adjusting the solution as well as the solution, the rate of dispersion of the solution as well as the rotation speed. So scaffold fabrication techniques, we saw so many techniques. Of these, your 3D printing is of great advantage because we get 3D shapes with good resolution, the adequate and the required pore size, and also which directly into the defect. Additionally, we can incorporate cells also directly into the scaffold material. When we see the other technique, adverse effect, spin coating confirms that you get a uniform fill, and electrospinning is a very good thing where you just use a very simple instrument and the entire process is very simple and it's useful coating. But the disadvantages, solvents are used, so that can have a toxic effect. Now we need to sometimes modify these biopolymers because the biopolymers as such have good that are required to be used. But as such, the resorbability of the polymers is not under a control. So in those cases, then the need why we place it either for drug delivery or for the purpose of space maintenance might be compromised. Mechanical as well as the retainability properties, the polymers are modified. Like you add certain other monomers to it in order to make it a little more stabler and more mechanically strong for the purpose to suit the purpose of use. So there are many approaches to the polymers. Like this is, for example, how collagen can be cross-linked to generate hydrogels. So you'll end up having better properties with case of hydrogels. Now, cross-linked with glutaraldehyde, or it can be even a thing with oligourethane polymer, PEGTA. So this finally gives you a cross-linked collagen hydrogel with very good properties. Apart from the biocompatibility, you get good mechanical properties as well as good sustainability for a longer period of time at the site of use. Now, production of collagen hydrogels also is possible and it can be functionalized with natural polymers. Now, how is it done? Collagen could be combined with another biopolymer. It could be chitosan, it could be cellulose, alginate, fibrin, or cyclodextrin. So you can get a composite biopolymer as well. Apart from this, you can add inorganic phases as well. Inorganic phases can be your anything. It could be a glass, it could be certain metallic nanoparticles like silicon, silver, which could have certain biologic activities, like your antibacterial activity as well can be added on. You can even add nanotubes and graphenes to give it more strength when you use it as a scaffold. So these are modifications that are done in order to enhance the activity of collagen as a biopolymer. Now, the drawback of these biopolymers is these are prepared, right? When they are prepared, they might land up having different characteristics. Physicochemical characterization as well as the biological characterization, meaning you're trying to find out the character or the nature of the biopolymer. Now, this can be done by various methods, like we can assess the we can assess the morphology of the polymer. You can use for which you can use optical microscopy or laser scanning confocal microscopy, scanning electron microscope. You can use atomic force microscopy to find out the morphology. And functional groups that are present in the biopolymer can be used by Fourier transform infrared and FMTR. And then you can use the energy dispersive X-ray spectroscopy to find out the elemental analysis. So there are other physical properties you would want to know: the melting point, the boiling point, its density, its tensile strength, its compressive strength is also can be assessed. So X-ray diffraction can be used to assess the crystalline nature. So all these things can be done to identify and needs to be done to identify the biopolymers when it's put to use, because we are going to customize and prepare it. So we need to ensure that all the required properties are there. So when it comes to biological characterization, we need to definitely assess the antimicrobial property, the cytotoxicity, its anti-fungal and bacterial properties as well. So that's very important. Main thing is our cytotoxicity. So when we come to applications, when it, we have proteins as well as we have fat. And we use different thin film, it can be form of fibers, in the form of scaffolds. As we saw, multiple techniques can be used to prepare biopolymers. Now, in dentistry, if we see in periodontics specifically, biopolymers have been used for local drug delivery. They've been used as membranes for guided tissue and guided bone regeneration, as well as scaffolds for regenerative therapy. So these are very commonly used. Commonly used ones are hyaluronic acid, chitosan has been very widely used, carboxymethyl cellulose is used. So these have played a very good role as drug carriers. And we also have scaffolds as composite and hybrid biopolymers have been used as scaffolds. Now, the peptide-based drug delivery vehicles could be ultra-small peptides. They can be alpha or beta scaffolds. And we also have elastin-like polypeptides, cyclic peptides. All these can be used as drug delivery vehicles. Now, in case of polysaccharides, hyaluronic acid, dextran, chitosan, alginate, plant and bacterial cellulose, so carboxymethyl cellulose, all these can act as carriers of our drugs. So especially we talk about periodontology, we are into this concept of local drug delivery. We want to avoid systemic toxicity and to get a greater concentration of the drug at the required site. So this has led to the development of local drug delivery systems, and using a biopolymer would give us a very highly compatible material, which would also be resorbable and act as a drug carrier and provide sustainable and controlled release of drugs at the site. So film-based, a lot of drug delivery systems are currently available and are under study. So there are certain local drug delivery systems available. The chitosan and alginate microparticle-based carriers have been used for delivering doxycycline and ornidazole. And then we also have chitosan, a hybrid, a composite of chitosan, polyvinyl alcohol, and HA fibers for the delivery of NSAIDs, which have been used. And also anti-inflammatory drugs and antibiotics have been delivered to the pocket through thermosensitive hydrogels, which are based on chitosan and complexes. And then we also have the biodegradable chitosan film, which has been used to deliver tetracaine, lidocaine, and benzocaine. So here are some of the natural biopolymers which have been used and the process that's been used to develop them. And they have been used to deliver drugs into the periodontal pocket. So chitosan, starch, carboxymethyl cellulose is very common. Apart from that, even passion fruit peel, cellulose extracted from passion fruit peel has been used, silk fibroin and collagen gelatin all have been used as biopolymers for the delivery of drugs into the periodontal area. So these are some of the hybrid composite membranes that have been developed and have been studied, and extensive study is further required. So we can see a lot of cellulose-based biopolymers as composites with other things, like you have the microcrystalline cellulose, you have the cellulose in which is modified as hydroxypropyl methyl cellulose. So many modifications. Even graphene oxide has been added to the bacterial cellulose, and these are composite biopolymers. We also have hydroxyl ethyl starch with so many modifications and sources as well. So we have those which have been taken from potato, tapioca, jackfruit. So different sources of starch have been used, as well as alginate in combination. Alginate is from the brown seaweed algae, right? So alginate also has been used as a composite membrane along with calcium phosphate, and it's loaded with a lot of things. Hybrid polymers have been tried and used. Even microbeads of this have been used to act as drug carriers. Now, in case of chitosan is alone used as a drug carrier as well as a composite with alginate, a composite with the other biopolymers like even a hyaluronic acid. Now, alginate has been used along with tamarind gum as well, gum extraction from other sources, and hyaluronic acid in combination has also been used. So these are different combinations of biopolymers which have been used for drug delivery. So these are some of the herbal loaded local drug delivery systems that have been studied. So a lot of carboxymethyl cellulose and chitosan based and hydrogel based carriers have been used to deliver these herbal products as nano herbs to the periodontal pocket. So green tea, tea tree oil, curcumin, oak, coriander, babul, all these agents like aloe vera, so many of them have been used. Even curcumin and neem chips have been developed with a carboxymethyl cellulose base. So these are all things under study. The only factor that we need to consider is standardization of the preparation so that we get a good sustained release of the uh, herbal product into the pocket in a required quantity. So that's the factor that needs to be considered when it comes to developing biopolymers for local drug delivery. So now when it comes to guided regenerative therapy, we all know membranes are used for guided tissue regeneration as well as guided bone regeneration. So these membranes play a lot of role. One is they need to, yes, be biocompatible and non-toxic, and they need to be biodegradable so that you can avoid a second stage surgery. So all our polymers fit into these properties. But additionally, it needs, all these biopolymers need to have a cell occlusive effect. So that's an important factor required for these membranes, as well as should have some amount of bioactivity. So if we see chitosan, it has antibacterial activity. Now, if bioactivity is not there, we might have to add certain bioactive molecules like growth factors and antibacterial factors should be addable to these membranes. Now, they have found that these biopolymers are good carriers of these bioactive molecules as well as can play a role in space maintenance. But yes, they would require some modification because they have a biodegradability. Now, we need these membranes to stay in the body for a few weeks. So, in order, either they are modified or certain hybrid biopolymers have been used for guided regenerative therapy, be it GTR or GBR. So, some of the things that have been studied are collagen, and hyaluronic acid and chitosan. So these have they are biocompatible, they are biodegradable, but we need them to be bioactive and promote wound healing. The only disadvantage of these membranes has been that they have a rapid progressive rate and poor mechanical strength. So these are some modifications of these membranes that have been done to enhance the basic properties. Like chitosan is already antibacterial, but in order to improve its mechanical as well as antibacterial property and its bioactive properties, silver nanoparticles can be incorporated into the chitosan membrane. As we see here, chitosan with silver nanoparticles have been added and it's electron spun. So you get the required membrane form. So the polymer is electron spun, electrospinning with electrospun along with the silver nanoparticles. So thereby this can later on used as a membrane for space maintenance as well as having certain bioactive characteristics like antibacterial activity. So antibiotic loaded, again, that was using silver nanoparticles. Now specifically antibiotics could be loaded to these membranes. So in the whole process, it keeps the bacteria and other infective agents from the site during healing. So it's going to enhance healing. So collagen and collagen chitosan combination membranes have been used to deliver a few of these antimicrobial agents like amoxicillin and metronidazole into the site of healing during regenerative procedures. So here are a list of few studies that have been done where these membranes have been, electrospun membranes have been used to, have been loaded with these antibiotics and used to improve the healing at the site of regeneration. So now when we come to scaffolds, so membranes, yes, they play a role in creating and maintaining a space, but we need a scaffold. Now, the routinely used scaffolds are your bone grafts. But when it comes to tissue engineering, the process of tissue engineering, scaffolds are created customized. So these scaffolds have a very good important role of maintaining the space as well as allowing and facilitating the migration of cells for the formation of new tissues as well as vascularization of the area. Now, the scaffolds most commonly are the hydrogels. So these hydrogels, as we saw, polymers can be converted into hydrogels, and these can be used as a medium, not just as a scaffold, as well as to not just a silent scaffold. It's also going to act as a carrier of bioactives, okay, transfer growth factors, bone morphogenetic proteins, and so many other stem cells, and everything can be transferred to the area. So thin 3D scaffolds also can be developed. So this will help in maintaining the space at the site, and it can be engineered specifically for the defect area. And in case of 3D printed scaffolds, we know that the defect area is assessed, and 3D printing technique, additive technique, is used to create a scaffold to fit in and correctly at the 3D architecture, exactly suiting the extracellular matrix that is required to be regenerated in vivo. So here are some of the nano hydrogels that have been used in craniomaxillofacial regeneration: gelatin, chitin, chitosan, chitin and dextran hybrids, hyaluronic acid as lone one, or chitosan and hyaluronic acid combinations, collagen and anginate combinations have been, nano hydrogels have been used for regeneration in the maxillofacial area. Now, hybrid particles, biopolymers, hybrid particles, which are multiphasic scaffolds, have also been used in periodontal tissue regeneration. So these are combinations like your hyaluronic acid and gelatin, which have the basic property of biocompatibility, and they're hydrophilic. In case of nano hydroxyapatite polymer, combinations have also been used for as hybrid particles and multiphasic scaffolds for periodontal tissue regeneration. Now here is a biomimetic collagen. This is a hybrid of collagen with hydroxyapatite. Now hydroxyapatite nanocrystals are synthesized, and the collagen molecule in the fibrillar state. These two together are effectively hybridized together. So you get an inorganic and an organic hybridization process happening separately at the same time. So you finally land up having a collagen fibril incorporated with hydroxyapatite. So this is a hybrid scaffold that's been developed. Now here's another hybrid thing of gelatin nanoporous macroporous hydrogels. So gelatin is there, yes, we know. Hydrolyzed collagen gives you gelatin, and then to its immogolite clay was used at the nucleation sites. They were used, linked into it. Then gelatin was cross-linked, and in the whole process, immogolite got incorporated and resulted in the formation of a macropores. So, and this immogolite in the hydrogel will promote the formation of hydroxyapatite. So it's a macroporous gelatin immogolite hydrogel, which enhances the hydroxyapatite formation. Now we also have other biopolymer hybrids like your chitosan, which could be combined with hydroxyapatite suspension. So you get a cross-linked hydrogel of chitosan and hydroxyapatite. So these are also being used as scaffolds, hybrid scaffolds. Now this is another hybrid scaffold of collagen fibers containing calcium phosphate. So it's in the structure resembles similar to the basic constituent of like the structure of the bone. So the advantage is the assembly of the proteins, protein fibrils. So you see that the calcium phosphate gets incorporated into the protein fiber, just similar to what's happening in the bone. So this is an advantage of these hybrid biopolymers. Now, I would like to conclude saying that use of biopolymers is a growing reality, and it is the need of the hour, because we always talk about sustainability, leaving the earth usable for the next generation. because the other polymers generated use your fossil fuels, and the whole process will end up polluting the environment as well. And we know that's going to affect the future generations. And though this is in the initial stages, and some of these biopolymers have found clinical applicability, we do require further clinical investigations of novel biopolymer materials, as well as the way they are developed, processed in different mechanisms they can be used and applied for our dental therapy. So I would like to conclude by saying all of us need to look into research of developing a lot of biopolymers for our therapeutic use in dentistry. Thank you.
Thank you, ma'am. Now the floor is open for questions. If any of the participant is having any questions, please do ask. I guess there are no questions, ma'am. Thank you for your informative session.
Thank you so much.
Now I would like to welcome our keynote speaker, Dr. Narasimhan, Professor, Department of Prosthodontics, Tagore Dental College, Chennai. Sir, over to you, please.
So, good morning to all. As my screen is visible, madam?
Yes, sir, it's visible, sir.
Yeah, thank you. Thank you. First of all, I would like to thank for inviting me to this keynote lecture. I'm happy to be here, and especially thank to Dr. Priyanka for this wonderful coordination of this conference. And thank you again. So here I am to talk about the provisional restoration in implant dentistry. So here, as we all know this, we expect to do a implant restoration, which would be, we need it in this ideal way. So we all expect this kind of a restoration. But sometimes what happens when we have the situations like this, so when we go and do the restoration, so it might land up like this. So this is the situation where we have a little bit difficulty in communication with the lab and a patient as well as the dentist. So all these factors, like the drawbacks, can be, I would say, like it can be eliminated with the help of provisional restorations. So coming to the provisional restorations, usually this provisional restorations used to enhance the aesthetics and provide stabilization of the soft tissue, and it gives a function as for a limited period of time. And even we can evaluate the position contours of the definitive restoration, and it preserves the soft tissue morphology. So that is the key factor here. And even it gives the best communication to the lab as well as the patient, the dentist. Like it is like a 3D guide. So there are a lot of provisional restorations are available, like removable, fixed. In a fixed, you got a tooth supported or an implant supported. But since the hope here is just would like to share only implant supported provisional restoration, that is for a single tooth. Just I'm going to here share it. So in this scenario, first I would like to show a case where there is no provisional is used, but it is a straightforward case where we can see a lot of space between the central incisor and the lateral incisor. So here, what we see is we just open the flap and make osteotomy and place an implant. It's just a straightforward case. And then after 3 months, we place a healing cap and then we restore it. So it is just a straightforward case. In this, all the factors where the placement as well as the soft tissue profile, when everything is fine, so we didn't come across any situation like aesthetic issues didn't come. But coming to this case, there is a patient is having a missing of premolar. So what we do here, there is a loss of papilla. So here we have to have a reconstruction of a papilla as well. So that can be only done by a provisional restoration. That too, we have to do it in the immediate loading situation. So we can see here as a straightforward case, like we give an LA, open the flap, place, and with the help of a stent, we place an implant. And after that, usually what we do, we close it and wait for it to heal, then go for a restoration. But in this case, since the stability is more, you can see here, this is the stability, like ISQ values. To find out the ISQ values, this is the smart peg, where you can see the, with the help of this Austel mentor, like a stability identifying a machine, where you can know the exact value of a stability of implant. When the stability is above 65 ISQ values, where we can go for immediate loading, that it mentioned. So once the stability is achieved, so what we do, we go for a provisional. So this provisional, we can see it gives a wonderful blueprint for a definitive restoration. And then as well as we can see in the buccal area, how nicely this supports the soft tissue. So the soft tissue is well supported, as well as it supports the interdental papilla also. So with this guide, so we go for a final restoration. So coming to the next case. So this is an immediate implant placement as well as immediate loading with the help of a provisional restoration. So here there is a second premolar, which is a root canal treated, and then the restoration is they used a post, and the post and the root canal treated, both the things is failed. So the next option is to extract the tooth and go for a bridge or an implant placement. Since the patient is opted for an implant placement, as implant supported restoration, so we carefully remove the broken post and the restoration as well as the tooth. So the socket is debrided, and then the implant is placed as well as the abutment also. So what we do here is, if we go for a two-stage surgery, where there will be a lot of compromise situation where there is a resorption of a bone as well as the restriction of the soft tissue. So once we do immediate loading with the help of a provisional restoration, we preserve both, mainly the soft tissue. So after provisional restoration, we'll be able to see here there is a good support of a soft tissue. So in the buccal side, we can see here the architecture, gingival architecture is maintained. So that's what here we have to achieve. And then the next case report is the immediate implant placement and then immediate loading. So this is the mandibular anterior region where a central incisor is missing. So here, what we do is, we open the flap and then we place an implant as well as the abutment. Here, what we use is a provisional abutment. It's called a peak abutment. So we place it and use a provisional. So this provisional helps to form a nice gingival scaffold. So you can see here a good amount of internal papilla as well as a soft tissue architecture is maintained. So with this, so we'll proceed for a definitive restoration. So the next case is what we have seen so far is immediately we have given a provisional, so that that provisionals help to form a soft tissue in the shape of a provisional restoration. But sometimes we have a situation, we place an implant and then put a healing cap. So this healing cap, while we remove and see the healing cap, it will be a rounded form. The tissue will be like matured or healed in the shape of a rounded form. But what we are going to restore is a lateral incisor that is not in a rounded form, almost in a triangular form. So for that purpose, first we have to make this soft tissue in a triangular form. So to make that, what we have to do is we have to place a provisional restoration. So we can see here there is a lot of internal space. So by doing a provisional restoration, we get to know that. So this will be the shape and final form of a definitive restoration. So if we, without giving a provisional, if we go for a ceramic crown, what will happen? This is the what the final result is going to end up. Since we do a provisional restoration, we come to know that there will be a space between this. So how we overcome with this? So we cannot fill the space. Either we have to go for a papilla build-up, like we can go for a free gingival graft to fill that space. But there is some amount of a bone must be there to preserve that papilla. But here what we do is there is no bone. It is a flat surface. Bone is formed in a flat surface. It's not a architecture shape. So what we do, we slightly do enameloplasty of a central incisor as well as the canine to make this triangle shape disappear. So what we do a slight enameloplasty and make this provisional to fit exactly in the space. So once we have achieved this, we wait for at least a month of time to see whether this kind of a restoration stays well in this area. If there is any recession or any kind of enlargement during a function. So once we are satisfied with this and okay, then what we do is we go for a final or a definitive restoration. So we can see here there is a nice triangle form or oval form of a soft tissue formation comparatively like previously of a round tissue formation. So this give you a good idea or amount of a soft tissue profile. So with this we make a definitive crown, and then we go for a cement retained crown for better aesthetics. So even this is duplicated in the model also. So after with the help of a abutment positioner, we place this in a patient mouth and then we check for a soft tissue profile. So once we have achieved this, what we do before luting is we take an impression of a tissue surface of a crown. So this what we do because we go for a cement retained crown. So once the cement return crown we do, the excess cement goes below the gingival margin. So sometimes it will be very difficult for us to remove this luting cement. So what we have to do is, we take a impression of the tissue site, and then we make a luting in this. So like this, we mix the luting cement and place it inside. So all the excess cement is being driven off now itself, and only the required amount of a luting cement will be there in the crown. So once this is done, immediately before it sets, place in the patient mouth. So what we got in the provisional restoration, the same thing is achieved in the definitive restoration. So that is the idea of going for a provisional restoration for a single tooth restoration, that too for an anterior regions. So coming to the, even this can be achieved in posterior areas also. Even posterior areas where we don't need much of a aesthetic point of view, but function as well as the hygiene point of view, what we do is we select the case and then do a wax up to place a implant in ideal position. Once the wax up is being done, and then we make a guide based on that wax up, and open a flap, place an implant, and then immediately we make the impression. This is the immediate loading. Immediately we make the impression, prepare the abutment, and make a screw retained crown. So this is a non-functional abutment crown. So once we make this crown, and then we seat it in a patient mode. So when we do this immediately, what happens? The soft tissue is getting healed around this provisional restoration. So it forms a nice gingival cup. So once we get this, the same thing is transferred as a definitive restoration. So now this is the definitive crown. So you'll be able to appreciate that there is a nice gingival architecture without any space in the internal area. So in this, we achieve a good gingival architecture, as well as it is better for a hygiene also. There won't be any space in the internal area. So I would say the provisional restoration alone doesn't give you all this gingival architecture as well as the closure of internal space, but provided other factors and the periodontal factors where we get a good amount of gingival tissue thickness, that is a profile, as well as the bone morphology. But when all these factors are favorable, we use a provisional as an added factor to achieve the results. So coming to the anterior emergence profile creation, this is another one case. So here we can see this implant is placed like how we have seen the lateral incisor, the previous cases, but it is placed slightly close to the lateral incisor, and then the healing cap is there. So what we do here is to make this soft tissue in a triangle form. We go for a peak abutment or even a costable abutment can be used as a provisional abutment. And then with this, we go for a relining. Just we use a denture tooth for better aesthetics. We just grind it inside and do a relining with a flowable composite. And we can see there is a right side a small picture showing a remove the relined crown. So once the crown is made, and then we have to finish the gingival margins and put a screw retained crown so that we can able to remove it and do the modifications. So once we do this crown, So we have to transfer all these details to the definitive crown. So what we do, we can see here there is nice formation of a gingival architecture, but the tissue has to mature still. We get the triangle shape. After this, we form or else we reproduce the gingival architecture for the definitive crown. So once we do this, we take a putty index and then use with the help of a flowable composite, we capture this soft tissue profile. Once we do this, this was placed in the patient mouth, and then this is transferred as an impression. So we get the exact details what we had in the provisional restoration. So, and then this has to be verified, like JIC verification. This has to be verified even in the patient mouth. So this is with the help of a IOP. So just for us to know, there is a small comparison between a modified or capturing a soft tissue profile with the help of a modified impression post and regular impression post. This modified impression post supports the soft tissue as well as it records all the details. But our regular impression post doesn't support any soft tissue, just it records its own impression post. That is the difference. So this is the definitive crown which is made from the impression, and then we do a restoration. So this is one kind of a restoration. So coming to the last case. So this is also an anterior region. The same technique we have made this. So we can see here there is the soft tissue is compromised. When there was a placement, lot of laceration was happened in the labial aspect of a soft tissue. So in order to support those soft tissue as well as to gain a good emergence profile, we decided to go for an immediate provisional crown. So once this situation is there, we given a provisional crown immediately. So when the soft tissue is supported enough with the help of a provisional restoration, the healing will be better. Or else what will happen? The soft tissue will shrink and will go flat in the internal area. But when we give adequate support, it grows and fills the space between the internal space. So now we can see here, once we remove the provisional restoration, the collapse of a soft tissue. But if we take the impression with this situation, there could be a compromised situation where there will be a space between the internal area. So what we are trying to do is, we take the same kind of a soft tissue profile, that is a modified impression post technique. So we can very well appreciate it. It's collapsing since it is a immature soft tissue. It's still in the healing stage. So we take the putty index of a profile, soft tissue profile, with the help of a provisional restoration. And then we connect the impression post, and then we fill the space between the impression post and the putty index. And then this is being used to make an impression. So with this modified impression post, the soft tissue is well supported. So there won't be any collapse of a soft tissue. And then we can very well see that there is a triangle formation of a soft tissue which is captured exactly from the patient mouth. And then we go for a definite restoration. It's just a metal ceramic restoration, cement retained. and then we place with the abutment finder or abutment positioner, and then we place in the patient. Now we are able to see there is a good form of a soft tissue is forming, and also we have given enough support with the help of a provisional restoration. Here we give a provisional restoration. That provisional restoration supports the soft tissue from the day one. So what happens? So the healing will be followed the same way. So there won't be any much of a modification. So this is an initial stage. So after a month of time, we can see here there is a good formation of a soft tissue around the definitive restoration. So this is the final result. So with this, I would say that in the realm of implant dentistry, the significance of provisional restoration as a cruel tool for gingival architecture restoration cannot be overstated. Though its role in providing entering function, aesthetics, and facilitating the development of optimal soft tissue contours, provisional restorations play a vital role in achieving successful outcomes in implant therapy. So, with this, I would like to conclude my session. Thank you all, and thank you for your patient listen. Thank you all.
Thank you, sir. Thank you so much for your informative session. If any of the participants is having any question here, kindly to ask. The floor is open for questions. I request any of the participant is having any of the questions, please to ask. I guess there are no questions, sir. Thank you.
Thank you, madam.
Now I would like to welcome our keynote speaker, Sheetal S. Chowdhury, Professor, Department of Oral and Maxillofacial Pathology, Yarala Dental College and Hospital, India. Ma'am, over to you, please.
Yeah, thank you, Josha ma'am. I hope I'm audible and my screen is also visible.
Yes, ma'am. Yes.
Yeah, thank you so much. So, a very good morning and warm regards to all the respected dignitaries, clinicians, researchers, and dear student delegates. First of all, I actually would like to congratulate the team BioLeague and the team of Asia Pacific Association of Dental and Oral Health for organizing sixth international conference on dentistry and oral health. This conference has actually provided the platform for the dental researchers, professionals, and clinicians where they can share their research and thoughts. I thank the organization for providing this platform and giving me this opportunity. The theme of this year's conference is exploring the global innovations in dentistry from research to practice. So, when we talk about innovations, particularly in cancer research, what was once thought to be impossible is now a reality, thanks to a number of technological innovations that have led to major breakthroughs in the way we find, visualize, understand, and treat cancer. It's an ongoing area of clinical research to develop better and more accurate diagnostic and screening techniques, be it artificial intelligence mammograms, liquid biopsy for breast cancer, robotic endoscopy for lung cancer, genomic cancer screening in embryos, at-home urine tests for prostate cancer, to name a major few breakthroughs. Cancer genetics and genetic testing has revolutionized cancer diagnosis, prevention, and treatment. A greater understanding of the immune system, genetics, and cancer pathology has actually opened the doors to an ever increasing range of cancer treatments and diagnostic tools. The 2000s has also marked the emergence of targeted therapies where drugs can find and kill cancer cells by homing in on specific molecular changes seen primarily in those cancer cells, thus making the treatment more effective and with less side effects. Similarly, a new personalized and more effective medicine, which we call it as precision medicine, has also actually revolutionized the treatment field in clinical oncology. In fact, all these innovations are actually based on problems which the clinicians had faced when they were diagnosing and treating cancer, which has led to these advancements, which in turn enhanced the clinical practice and led to better patient diagnosis and management. And that is what we want in cancer area. Now, when we talk about head and neck cancer, particularly oral cancer, yes, we have been trying to change the way we screen, diagnose, and treat oral cancer and pre-cancer, but we know that there is lot more needs to be done. And I think for this we need to have a more problem based approach, in the sense what problem we face in our clinical practice in day-to-day basis, and based on these problems then you find out the solutions through your research. So we as clinicians know the clinical complexities which are involved in the diagnosis and management of oral pre-cancer and cancer. And therefore, I think we are at the most advantageous position of getting path-breaking ideas to resolve these problems. It is rightly said that clinicians are working in the greatest laboratory of clinical research because they are constantly exposed to patients and their illnesses. What I would like to convey is that clinicians can be the best researchers, in fact, and because through their research, we can change the way we practice. And therefore, clinical practice and research can be said to be the two coins of this, two sides of the same coin. So, in regards to oral precancer and cancer in our clinical practice, what problems we actually face? The first problem is that clinical dilemmas while diagnosing and giving a confirmative diagnosis, and therefore that creates dilemmas regarding the treatment of these oral potentially malignant disorders and sometimes oral cancer as well. We are not actually having a technique which can give us a more molecular diagnosis, in the sense uh, we have histopath, definitely the gold standard for diagnosis of oral precancer and cancer, but histopath also has got certain limitations. That is, there is less patient compliance because the procedure is more invasive. It is more objective also, in the sense because when we give diagnosis on histopath, that is if we give label a patient as having mild dysplasia or moderate dysplasia, we are again in a gray area that what kind of treatment should be given to the patient, whether we should wait or we should go with a treatment, and which also whether we could go with an aggressive modality or we can be more conservative about it. So the problems which we thought in the area of oral potentially malignant disorders and oral cancer is that we thought that why we can't come up with a more molecular diagnosis, in the sense like we have for breast cancer. You all must have been known that the breast cancer report is actually not complete without being labeled whether patient is having ER/PR positivity on immunohistochemistry. So in other fields we are having more molecular diagnosis, so why can't we have a more molecular approach towards the diagnosis of oral precancer and cancer? That was our first objective or first problematic area. Secondly, uh, also in certain other cases like for cervical cancer and all, we still have certain serum biomarkers like EMA and all, but for oral cancer and precancer we don't have a more uh, 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 minimally invasive or less invasive method of diagnosing oral precancer and cancer. Third thing, the objectivity which is involved with the assessment of cancer risk. In the sense, like if a patient of oral potentially malignant disorder comes to you, and in your clinical practice, you feel that the patient should undergo biopsy so that we can decide a particular treatment for the patient. We take a biopsy and then the report comes as dysplasia. But dysplasia has got so much of subjectivity. It's not very objective. That is, we cannot tell on the basis of dysplasia that this patient will definitely develop oral cancer. So there is a lot of inter-observer variability, which we call it as, and there is a lot of subjectivity which is involved in the diagnosis of oral potentially malignant disorder, and therefore we cannot predict the prognosis of the precancer, that particular precancer patient, or even for oral cancer patient. We are not able to give a proper prognostic approach to the diagnosis. So another area of research or of a dilemma was patients with habits but without lesion. That is, uh, so many patients, they come to you with adverse habits like tobacco, alcohol and all, but we cannot tell the patient that yes, you have a 90% probability or 100% probability of developing oral cancer. And if we have that kind of approach, we may be able to convince that patient better to leave the habit. So these were the problem areas which we thought that why can't we come up with solutions to these? Why can't we have a more molecular diagnosis? Why can't we have a less invasive method of diagnosing oral precancer and cancer? Why can't we have a more objective technique for diagnosing these disorders? So we try to explore then certain molecular methods which we are using for other cancers. And what we came across is a optical diagnostic tool, what we call it as Raman's microspectroscopy or Raman spectroscopy. Now, why we thought of Raman spectroscopy is because it gives you a wealth of biochemical information, including those of different constituents of the cells or the
சார் வணக்கம் சார்.
or the tissues.
சட்டல்ட
Like that
செல்வி சார்,
of
செல்வியே யாரோ ஒரு செல்வின்னு நினைக்கிறேன். நேத்து அவங்க நர்ஸுங்க கிட்ட கேளுங்க. வாங்கிட்டு சொல்லுங்க. அவ்வளவுதான் சார். ஓகேங்களா? சரி. செல்வியில வள்ளின்னு நினைக்கிறேன். வள்ளின்னு நினைக்கிறேன். வள்ளி வள்ளி வள்ளி.
unmuted.
ஓகேங்களா? ஓகே சார். ஓகே, ஆரம்பிச்சிட்டீங்களா?
Yeah. So why we thought of this technique, that is Raman microspectroscopy or Raman spectroscopy, because it gives you a more structural detailed information about the lipids, proteins, nucleic acid content of the tissue, and therefore it actually in turn reflects the presence and the degree of cellular alterations. What is the meaning of this? That is, in certain cases, patients are having habits, but they are not reflected in the clinical findings. They are not on histopath. You cannot have any change. You do not have any changes. But at cellular level, these carcinogens have acted and they have brought in certain cellular alterations. So if we have a technique which can detect these cellular alterations, we can utilize it in the area of oral precancer and cancer. And Raman spectroscopy, it actually gives you this biochemical information about the tissues, even if it's not come to a tissue level, even if it has not reflected in the clinical examination. Another advantage of Raman spectroscopy is that we could be more, we could have a less invasive way of diagnosing oral precancer and cancer. That is, we thought that we could use serum or saliva with Raman spectroscopy as a diagnostic tool in oral precancer and cancer. So these are all the advantages why we thought of Raman spectroscopy, because it can give you a more molecular information about the tissues. The technique is rapid, it is more objective, it is associated with less inter-observer variability, and it gives you very accurate, it can give you accurate diagnosis because it incorporates computer software diagnostic information. Which can be re-evaluated, which can be reproducible in a very short frame of time. So looking at all these advantages of the technique, we thought that we should work on this technique and we could utilize it in the diagnosis of oral lesions. So before moving on to the research, what is Raman spectroscopy? Raman spectroscopy is actually a non-destructive chemical analysis which is based on the interaction of light with the chemical bonds within a material. In Raman spectroscopy also there are different approaches, that is in vitro approach, in vivo approach, and we actually thought of working on serum and saliva with micro Raman spectroscopic approach. That is, you can collect the serum and saliva from the patient and then you subject it for Raman microspectroscopic analysis. So what were the objectives on which we worked to prove that spectroscopy can be a better diagnostic tool? So our first objective was, because this is new tool in the area of diagnosis of oral precancer and cancer, we actually first wanted that Raman spectroscopy should be able to differentiate different group of patients. In the sense, it should be able to differentiate healthy controls from patients with oral potentially malignant disorders from oral cancer. Also, we thought that in oral potentially malignant disorders also, it should be able to differentiate between OSMF, between leukoplakia and certain other oral potentially malignant disorders. Like on histopath, we get a very confirmative diagnosis. So so whether Raman would give us a very confirmative diagnosis in respect to different oral potentially malignant disorder, that was the second objective which we tried to work on. The third objective, what we thought, as I told you, that we on histopath or on clinical examination, we cannot tell that yes, you have got 100% chances of developing oral cancer. So whether Raman spectroscopy can give us that information, that is whether it can assess the cancer risk in patients who are having habits or in patients who are having oral precancerous lesions and conditions. So when we set in our objectives, we tried to work on these objectives. We selected four group of individuals, like our group one constituted of healthy individuals, group two constituted of individuals with adverse habits, but who have not developed any lesions, in the sense who have not developed any oral precancerous lesion or condition or even oral cancer. So that was the second group which we thought we should work on. Actually, there is no research on these kind of patients, that is who are having habits but not developed any. Why we need to work on this group? Because they can be sensitized at the preliminary stage before they develop oral precancer and cancer, that if we can tell them that you have got these the chances of developing oral precancer and cancer, we can be more convincing to them. The third group of patients on which we tried to work on was oral potentially malignant disorders. That is, we chose oral submucous fibrosis and leukoplakia, and we compared all these findings of these groups with those of oral cancer patients. So this was the workflow which we followed for Raman spectroscopic analysis. First, we collected the blood from these patients. We actually separated the sera. And one more advantage of Raman spectroscopy is that it actually requires very less sera. So this is the entire armamentarium. As you can see in these photographs, this is more like a microscope, and to which a software and monitor is attached. This is how the sera samples are subjected for this micro Raman spectroscopic analysis. It requires only 10 microliters of the sample. These are the different attachments. These are the different components of the equipment. As you can see here, there is a computer system with software attached to the Raman microscope. And this is how we get the data. This is how the Raman gives you the data. That is, in the sense, when we record one serum sample, it gives you a spectra. And this spectra has got different peaks. As you can notice here, there are different peaks. So these peaks are actually for the molecules which are present in the sera of the patients. So for one patient, we recorded 10 spectra, and then we averaged it to 1. So that is how we recorded the spectra for all our patients from all 4 groups. And then we went ahead with the data analysis. Now, this data analysis, it plays a major role in giving us a very accurate diagnosis and giving us a cancerous assessment in these patients. So how do we analyze the data? So data was analyzed in a patient-wise approach using unsupervised principal component analysis and supervised principal component linear discriminant analysis, and which was actually followed by an artificial intelligence-based cross-validation tool. So what we did is that we subjected the entire data to a multivariate analysis. And that is through PCA, that is principal component analysis. You actually recognize the variance which is present in the data set. So you come across a very characteristic feature which belongs to each group. So you identify those special spectral features which belong to those individual groups through PCA analysis. What is the role of LD analysis? Actually, LD analysis, once your PCA analysis is done, once you identify those special spectral features, on the basis of these spectral features, you actually try to classify the data. You give a classification to the data, and through that, then you identify that this group is having these spectral features. After that, what we do is that we use a artificial intelligence tool, which we call it as leave out cross validation tool. Now this leave out cross validation tool, it actually gives you a predictive model. That is, if you subject a SMF patient, it tells you that this patient, it belongs to this group, it has got this specific diagnosis, and these are the molecular features on the basis of which you can predict the cancer risk in these patients. So that is what is a predictive model, and it is based on an artificial intelligence tool. So what were the results? And that was about the data analysis. So what kind of results we got through our research? These were the different molecules which we studied for our sera sample: beta carotene, proteins, DNA, and amino acids. And this, on the basis of these molecules, actually we could differentiate the differences between different groups. So these are the spectra which you can appreciate for different groups of patients. From this overlay, you know that you can appreciate that there are different spectral features for each group of patients, right? So the yellow is different from green, green is different from blue. So these are the different molecular peaks which represent each group. The objective, when we go to check our first objective, that is based on Raman macrospectroscopy, whether we are able to differentiate the different groups of uh, individuals or different groups of patients. So here, as you can see, that there are different spectral features for healthy controls, and there are different spectral features for patients with a habit without lesion. So blue color of this graph represents habit without lesion, and which is different from the normal spectra. We also wanted to differentiate between leukoplakia and SMF. As you can see here, there are different spectral features for leukoplakia and for SMF. We actually wanted to test whether Raman's gives you a cancer risk assessment. And for that, what we did, actually all our serum samples, since we wanted to prove that serum can serve as a diagnostic tool, what we did is that we compared our serum analysis with the histopathological diagnosis, because till now we are just having histopath as our gold standard. So we compare our new diagnostic tool with gold standard, that is histopath. So on histopath, Dr. Pradeep, can you please mute? So on histopath dysplasia, it gives you a prediction, that is whether a patient can develop oral cancer. So what we did, we compared our serum samples with patients with dysplasia on histopath. So as you can notice here, there were different spectral features for the group of hyperkeratosis, which were different for hyperkeratosis with dysplasia. As you can see that the two groups showed you different spectral features. Similarly, dysplasia, there was difference between dysplasia and OSCC spectra, as you can notice here. So that is what we also wanted. That is whether there is difference in the group of patients which are not having dysplasia, and the group of patients which are having dysplasia, and the group of patients which are having oral squamous cell carcinoma. So we could see that Raman spectroscopy can differentiate all these groups of patients. So after this was about the PC analysis. Coming down to LD analysis, LD gives you a cluster. That is, as you can see here, there is a blue cluster, there is a red cluster. So if your clustering is good, that means your data analysis can be used in the diagnosis of the patient. So there were different clusters which was As you can see here, through LDA, we could differentiate control from habit without lesion. Also, there was good cluster of habit without lesion versus different oral potentially malignant disorders, where the accuracy was almost 85%. There was good clustering of OPMDs with dysplasia, which could be differentiated from dysplastic group. Dysplasia could be differentiated from OSCC group with almost an accuracy of 84%. Now you will question, why not 100% accuracy? Actually, when we start working on these AI models, we have to feed lots and lots of data, and then it comes up with a very accurate predictive model. So the more you feed your data, the more accurate your predictive model would be. And therefore, we are still working on this. We are feeding, we are taking, we are still continuing our research so that we can come up with a predictive model which gives you 100% accuracy. Now, once we got our serum results, we thought that why we should not work on saliva as a diagnostic tool, because it is the least invasive method of diagnosing oral precancer or cancer. So we tried to explore saliva as a diagnostic aid. Uh, but in regards to saliva, we actually face certain problems, because you know that saliva is more impure. That is, there are debris, there are epithelial exfoliated cells, and these impurities actually uh, uh, can have an hindrance in spectral acquisition, or it can mask your data. And therefore we required to standardize saliva. We required to pre-process saliva so that we get more pure salivary form, which through which we can analyze the data. So for a serum, we tested it against cystopath, and for saliva, we tested our results against serum. Now we chose here little bit of different groups to prove saliva as a diagnostic tool. So as you can notice here with serum, we could differentiate control from leukoplakia and from oral submucous fibrosis. So our question was whether we could differentiate these three groups based on our salivary analysis. So this is how the spectral features, and yes, we could had different spectral features for all three groups. Similarly, we also wanted to differentiate between SMF and leukoplakia based on our salivary analysis. Serum definitely gave us different spectral features. That is, leukoplakia could be differentiated from speckled leukoplakia or erythroplakia, which could be differentiated from pre-leukoplakia. Similarly, on saliva, we could get different spectral features for all these three groups. That means that saliva can be utilized to differentiate these different groups of oral potentially malignant disorder. Our next focus was on SMF patients. Now, as you know that in India, there is a lot of malignant transformation which is associated with oral submucous fibrosis, and therefore we thought we should work more on SMF. So in SMF, nowadays we are getting SMF patients with red component, where we think that the patient can have a cancerous transformation. Also, we are getting SMF patients with leukoplakia. A lot of hybrid cases we are getting. So we thought we should work on these patients also. And then we thought whether Raman spectroscopy salivary analysis can give you different spectral features for all these three groups. So as you can notice here, saliva could actually differentiate these three groups of patients. This was our LD analysis for serum versus saliva. Serum, when we expanded our research on serum and when we subjected more number of patients, we came across that almost serum gave us 96 to 97% of good clustering, that is accuracy. In contrast, saliva also gave us almost 88%, 87% of accuracy level. Now, regarding a prediction model based on all these analysis, all this data, so how a predictive model is developed? That is, we develop a predictive model based on whatever spectral features you have earlier, and we subject a new spectra against the previous data what you have. So whether this predictive model is able to diagnose a new case through the earlier data, that is how it is tested. So as you can see here, uh, 8 patients of leukoplakia. So how many patients were diagnosed correctly through this predictive model? So out of 8, we could diagnose 6 on serum as well as on saliva. Similarly, for SMF, out of 8 patients of SMF, we could diagnose 4 correctly. On saliva, we could diagnose 5 correctly. So this is how the predictive models we develop through an AI tool. So this is regarding a very small number of cases, but we are, as I was mentioning, that we are feeding more and more data so that we can come up with a more predictive model uh, for diagnosing oral precancer and cancer. So this is how the molecular characteristics are, and this shows you different elevations and different lows in different groups of patients. This was regarding serum. This was regarding saliva. Saliva also, we could see different molecules showing different spectral features. Like on serum, we had beta carotene amide DNA bases and phenylalanine. On saliva, we had phenylalanine, amide 3 nucleic acids. So there are different molecules, and these molecules are actually, how do you diagnose these molecules, or how do you know that these molecules are good enough to tell you the differences between different group of patients? That is through your PCA analysis and LD analysis. So coming down to certain concluding remarks. Whether serum and saliva can serve as a better diagnostic method. So we could get variation in the content of protein and nucleic acid, which tells you that significant biochemical differences you can analyze through serum. The study actually confirms the feasibility of Raman spectroscopy combined with multivariate analysis for diagnosis of different oral potentially malignant disorders. That is, SMF could be differentiated from leukoplakia, or leukoplakia could be differentiated from pre-leukoplakia, or SMF could be differentiated from hybrid lesions. So it could actually help us to stratify different group of patients. Also, it could tell us the differences between dysplasia versus non-dysplastic cases. So it can actually gives you information about the cancer risk in those group of patients. Also, as you know, that serum could be less invasive. What about saliva? Yes, saliva also could differentiate different group of patients. That is, healthy could be differentiated from different OPMDs. And also, we could differentiate dysplasia from non-dysplastic lesions. So we thought, as I have mentioned, that we have to prove whether saliva is better or serum is better, and that will be through our expansion of the research. Every research has got its limitation, and that is how you have to work on these limitations so that you can be more accurate in your findings. So this also has got certain limitations. That is, in the sense, there were certain individual spectral diversity which we could observe, but it could be overcome through adapting machine learning method, which actually gives us a very accurate classifying spectral features. And that is what we did. Like initially, we just stopped ourselves to PC analysis, but then we knew that we have to have a good accurate model, and that is how we started using deep machine learning methods and different AI tools. Also, as I have told you, that AI requires lots and lots of data, and therefore we have to work on more and more number of patients so that we can come up with more accurate uh, diagnosis. So through our research, whether we could solve our problems in clinics, to a certain extent, yes, because we wanted a more molecular diagnosis in regards to OPMDs and oral cancer. So Raman microspectroscopy could give us a more molecular diagnosis because it gives you a more biochemical information. Another objective, whether it could assess cancer risk, yes, because we found that there were differences in dysplasia and non-dysplastic cases through serum and saliva. We could differentiate these two group of patients. Another and the most important objective was, that is, whether we can have a minimally invasive technique of diagnosing oral precancer and cancer. So yes, serum and saliva can be utilized in this regard. So this research has got its implications in diagnosing these group of disorders. It has got its implication in predicting the progression of the disease on the basis of the molecular information. We are thinking about its future scope. That is, we wanted to explore more saliva. We want to monitor more and more cases of OPMDs so that whether the Raman spectroscopy helps us in predicting the survival and the prognosis of these patients. We also want to work more on patients who are not having disease yet, that is, who are having adverse habit but has not developed the disease. Also, we want to have a very specific molecular biomarkers. So through Raman spectroscopy, we are sure that we will come up with these biomarkers. No research is possible without having a multidisciplinary team. And therefore, we collaborated with Tata Institute of Medical Sciences, their research wing, that is what we call it, Tata ACTRAC. And this is our entire team. We did our research at Dr. Shilkapati sir's lab. So I definitely want to acknowledge sir and his team for giving us that support, because without their support, we could not have ventured into it. What we came I mean, definitely we could solve our certain dilemmas. Also, we could came with certain good publications, and we could actually gain certain grants which could fund our research. So these are certain publications which we generated through our research, also certain grants through which we can fund our research. So to the young dentists and researchers, I actually wanted to give this message, that is, we have to identify our role as a clinician. That is, what is my role in controlling or preventing oral diseases, and why we? Because you know that you are best at it. You have been chosen. This is the area which you are expert, or this is your territory. So definitely you need to start at an individual level, and of course you have to collaborate with your colleagues. You have to make your network so that you can be a best researcher, you can be a best clinician. So collaborate with research institutes, collaborate with your colleagues, collaborate with your different academicians, with the industry as well, so that you can come up with good solution to your clinical problems, and you can be the best clinician. So thank you all for patient listening, and I would like to take up your questions if you have any.
Thank you, ma'am. Thank you so much for your informative session. If any of the participants is having any questions, the floor is open for you.
Madam, journal name, madam. Hello.
Yeah.
Yes, madam. Paper
Yeah, Dr.
publication. Yes, madam. Journal name, madam.
Journal name, these are more biochemical based journal, because Raman microspectroscopy, I mean, there are number of publications, sir. In head and neck cancer journal also we have publication. We have publication in head and neck pathology also. And as I've mentioned, that biochemistry journal.
Thank you.
So is there any questions? I guess there are no other questions, ma'am.
Thank you, ma'am. Thank you for giving me the opportunity. And
We are so thankful for your time. Before we move into our technical sessions, I request every participant to turn on their cameras for the gallery image. I repeat myself, I request all the participants to turn on the cameras for the gallery image. Shikal ma'am, you can stop sharing the screen. I repeat myself, I request all the participants to turn on the cameras for the gallery image. I guess this is a wonderful morning. I guess every participant could smile a bit more. One more snip, please. At least say cheese, my dear lovely presenters. At least. I hope everyone are from the dental sciences and all. So I want to see your teeth, please. Thank you. So I request every participant to join their respective halls as per the agenda. As you could see, if everyone are joining from the PCs or laptops or computers, at the down bottom, you could see a breakout rooms icon. Tap on it and join the respective hall. The main hall participants kindly stay here. Rest hall 1 and hall 2 participants tap on hall 1 and hall 2 on the breakout rooms and join the respective hall. If any one of you facing the issue, kindly let us know. I repeat myself, all the participants kindly join the respective halls as per the agenda. The participants who belongs to the main hall stay here. Rest of the participants join hall 1 or hall 2 respectively as per the agenda. For joining the breakout rooms, you could see a breakout room icon at the down bottom. Tap on the breakout room, join hall 1 or hall 2 respectively. The main hall participants kindly stay in this hall. If any of the participants facing issue regarding it, kindly let us know. I request every participant to be ready with your presentation, PPTs and posters, and request to stick on the time when they start presenting. And I request all the other participants kindly stay on mute while the participants are presenting. The participants who belongs to the main hall are Arshavardhini R and Asira Manmoharan, Dr. Pooja, Dr. Gayatri, Dr. Angeline Aishwarya, Shantani Priya, D. Rupasya, Dr. Hari, Dr. P. Lakshmi Prasanna, Amar Deepika, Dr. K. Saji, Dr. B. Radhika, Dr. Hemavarshini, Sri Krishna Prasad, Dr. Prakash, Dr. Syed Altaf, Madhura Shekarkar, Hinduja, Dr. Kirtivasan, Dr. Pavan, Saumya, Swarna Malika, Dr. Saranya Sivaraj, Shubhi Gupta, Sneha, Dr. Chaya Sharma, Dr. Ramapriya, Amrita. These are the people belongs to the main hall. And for hall 1, the presenters are Swati M, Dr. Sayeda, Sushmita S, Dr. Aisha, Nirmala Kumar, Dr. Santosh Kumar, Kirtana N, Arnit Purohit, Anusha, Sivapriya, Uma Maheshwari, Sharon, Harita K. Shavanya, Shanmugapriya B, Dr. Rakavi, Kanmani, Dr. Om Ninjandan Kumar, Ashwita, Nishali, Harshini. These are the people belongs to Hall 1. Coming to Hall 2, the presenters are Devi Jasanta, Dr. N. Prabhu, Hemavati, Dr. Mithila Namdev, Shruti Devi, Dr. Jaya Prakash, Kritika, Dr. Gauri, Dr. S. Ashwini, Dr. Ananya, Dr. D. Smriti, Jayapriya BM, Mohana Ganesh Murthy, Dr. S. Preeti Archana, Marliya, Dr. Abhirami, Dr. Shrikar, Purushottaman, Prem, Rajula, Velavan Krishnan, Richwana, Karla Martinson. These are the people belongs to Hall 2. I request all the participants kindly join their respective halls. For joining the respective halls, the main hall participants kindly stay in this hall. For hall 1 and hall 2, tap on the breakout rooms and join the respective halls. We will start our technical sessions in few minutes. Thank you. If any participant want to check the presentations to share, they can share and check the presentations right now. I wish no participant will make a delay once the technical sessions are started. For maintaining a good decorum for your presentation, I request every participant to have a good connection and bandwidth of internet and be ready with your PPTs and posters. Kindly check your microphone and camera while presenting. If any of the participant is facing issue regarding joining the breakout rooms, kindly let us know. I request all the participants kindly stay on mute while other participants are presenting. And every participant be ready with your presentations and posters. Dr. Wu, are we having you? Dr. Wu Nijindan, sir, are we having you? Sir, are you there? Dr. O. Dr. O, can we start our presentations by 11, sir? Is that fine? Sir, your voice is not audible. If you are speaking anything.
Yeah, good morning to all. And Madam Roshni, you can start the presentations.
Yes, sir. Thank you. First of all, I would like to welcome our session chairs of our main hall, Dr. Om Nijindan Kumar, Associate Professor, Conservative Dentistry and Endodontics, Adiparashakti Dental College and Hospital, India. Dr. Vaishnavi, Reader and Head, IC Public Health Dentistry, Tagore Dental College, India.
Thank you for the wide speech.
Thank you. Our first presenter of the day is poster presentation by Arshavardhani R and Atira. Miss Arsha, are we having you? So I guess we are not having the first participant. So shall we move on to the next presentation?
Yeah, okay. You can go to the next part. Can you hear me, madam?
Yes, sir. Yes, sir. Just give me a moment, sir.
Yeah.
So our next presentation is poster presentation by Dr. Pooja Hari Priya, MS, on a topic of review on nanoparticles used in 3D dental resins from SRM Dental College. Dr. Pooja? Dr. Pooja Priya?
Hello.
Yes, ma'am. Kindly start with
Yes,
your
ma'am.
presentation.
Can you, am I audible, ma'am?
Yes, you are audible, ma'am.
Good morning, sir and ma'am. Today my topic is on review on nanoparticle used in 3D resins. Basically, a nanoparticle is a spherical polymeric particle composed of natural and artificial polymers. These particle, which is less than 100 nanometer, is basically known as a nanoparticle. Then we move on to types of the nanoparticles. When we come on to types of nanoparticles, there are various types such as organic and inorganic nanoparticles. Organic nanoparticle involve your polymeric nanoparticle, polymerism, the dendrimer nanoparticle, nanostructure lipid carrier, solid lipid nanoparticle, liposomes, nanoemulsions. And when it comes to inorganic nanoparticles, it's the silver nanoparticle, iron oxide nanoparticles, gold nanoparticles, in quantum dots nanoparticles, calcium phosphate nanoparticle. Firstly, this nanoparticle was discovered by Nobel laureate Richard, who was the first person to discover this nanoparticle. Basically, when we have all this gold, platinum, silver kind of nanoparticles, when it is made into nano size, that is of 20 mm, basically the color of the particles changes, where gold seems to be in a wine red color, and platinum seems to be in a yellowish gray color. Silver seems to be in slightly a black color, and palladium seems to be slightly blackish dark color. Then this carbon-based nanoparticle is nothing but fluorinous and carbon nanotubes are basically used in that. These carbon nanotubes are made up of single-walled, multi-walled, or double-walled nanotubes. The ceramic nanoparticles are inorganic nanoparticles, and we also have something known as semiconductor nanoparticles. That is nothing but metals and few non-metals comes into that. Then we'll have the polymeric nanoparticle, which is a organic material. They are in the form of nanospheres or nanocapsulas. Next, we'll see about the synthesis of this nanoparticle. This synthesis of nanoparticle usually comes on to bottom up and bottom down technique. Bottom up is nothing but just like something building up of the particles, and the top down is nothing but just the process of milling it down. As we mill it for CAD/CAM materials, just like process of milling it down. This bottom up synthesis involves spinning, template support synthesis, spraying synthesis, laser pyrolysis, atomic and molecular condensation, and this bottom up technique also has biological synthesis such as using bacteria, yeast, and fungi. Also, nanoparticle can be prepared. And top down is nothing but from the top you are just trying to mill it down, something like mechanical milling, chemical etching, laser ablation, electro explosion. Next, about the characterization of the nanoparticles. Usually, each characterization of the nanoparticles can be seen under TEM, SEM microscope, or X-ray diffraction, or FTIR spectroscopy. That is, I think, the Fourier transform infrared spectroscopy. Next is UV visible spectrum, dynamic light scattering. Using all this, the characterization of a nanoparticle can be identified. Now we'll see which test can be used to identify what structural or morphological characters it has. First, we'll see about the FTIR. FTIR is the Fourier transform infrared spectroscopy. This is used to identify the functional group that is present in the nanoparticle, whereas this UV visible spectrum that is used for formation of colloidal plasmon band that is formed. Next is the transmission electron microscope. The exact size and morphology of the particle is identified. Next, we'll see about the X-ray and diffraction. Using X-ray diffraction, X-ray diffraction, the size and the crystal structure of the nanoparticle can be identified, and the scanning electron microscope is used to see the size and shape of the nanoparticle, whereas the dynamic light scattering is used to identify the size distribution of the particles. Next, atomic force microscopy is used for the morphology of the nanoparticle and biomolecular structures. Next is property. When it comes to properties, the properties of nanoparticles varies as optical, electrical, mechanical, magnetic, and chemical nano properties. When we see about the optical property, it is nothing but the light absorption and scattering that changes the size of the material with the change in size of the material. When this material is in bulk, it appears to be opaque. When material is in nanoscale, it appears to be transparent. That is, when gold is in 50 nanometer, the particles are in green color. When it is in 100 nanometer, the particles are in orange color. And when it is beyond the 100 nanometer, it becomes yellow color. Next, we'll see about the electrical property. Electrical property depends upon the electrical conductivity of the material. In ceramics and metals, when the electrical conductivity of this material increases, automatically the particle size is decreased. That is, when the particle size is decreased, the electrical conductivity of the material increases. The next, mechanical properties, that each mechanical property, that is your fractional strength, compressive strength, your hardness of the material, everything, elastic modulus, everything depends upon the nanomaterial size. When this size of the nanomaterial is increased, automatically the mechanical properties will be decreased. Next, the magnetic property is that usually a nanoparticle behaves as a super paramagnetic material. Next, we'll see on to the applications of this nanoparticles in our medical field. Usually, this nanoparticles can be used as a targeted drug delivery system, and it can act as an antibacterial component. It is used in the field of tissue engineering. It can be used for DNA molecule detection. In MRI scans, it can be used as a contrast agent. There are various other properties also for each nanoparticle varies. Some has this antimicrobial effect, some has the antioxidant effect. So each material has different kinds of applications and properties, so that in humans, they have different roles to play. Next, if in case it becomes toxic to the body, what happens is that when it is inhaled, when this nanoparticle is inhaled and toxicity is created, it can affect the lung as asthma, bronchitis, more amount of nanoparticles. It can also lead to cancer. And next is that in circulatory system, it goes as thrombosis. In heart, it can cause arrhythmias and death. In lymphatic system, it can affect as Kaposi sarcoma. Basically, for skin, it can lead to dermatitis. And in gastrointestinal system, it can lead to colon cancer. And when it is given in orthopedic implant, where it can cause some dermatitis or urticaria, basically, these nanoparticles nowadays have become more advanced, and it has been recently in use, and they offer many beneficial effects for the patients and as well as the operators. Thank you.
Any questions, sir?
Is the presentation over?
Yes, sir. Yes, sir.
Your presentation was very nice and informative.
Thank you.
Can you say about the future directions of this nanoparticles related to the 3D resins?
Yes, sir. There are many zirconia nanoparticles can be used in the crown and crown material, sir, and
Yeah.
other zinc oxide, various other titanium oxide can be used for spraying on the implant surface. And even for 3D denture based resins or 3D temporary crown resins, these can be incorporated in the 3D material. But when we are incorporating into the 3D material is usually in a liquid form. So when we are incorporating this powder form of nanoparticle into the liquid form of the resin, we need to do some magnetic steering. Steering has to be done frequently so that the nanoparticle and the liquid resin we obtain a homogeneous mixture, sir, so that the printing of the denture base or whether it's crown or even surgical guides can be prepared using this. So we get better reinforced material. And the drawbacks of the 3D resin material is that they lack in strength, even compared to our conventional denture-based resins. So once these nanoparticles are added to them, they can reinforce the strength of the material, sir. Mechanical properties of the material can be improved using this 3D nanoparticles, sir.
Thank you very much for the lovely presentation.
Thank you, sir.
Thank you, Ms. Pooja. The next presentation is poster presentation by Dr. Gayatri K on a topic of efficacy of folic
I think
acid.
Dr. Gayatri paper presentation.
Yes, sir. I am presenting a paper, sir.
Yeah.
Okay. Shall I start presenting, sir?
Yeah, please.
Morning, sir, ma'am, and everyone. Today, my paper presentation topic is on evaluation of folic acid and chlorhexidine mouthwash as an adjunct to scaling and.
We cannot see the presentation.
Just a minute. It shows me that I'm sharing the screen, sir.
But you can see only the folders icons.
Okay,
So
sir. I'll just reshare it, sir. Just a minute. Sorry, sir.
No problem. Yeah, now we can see.
Yeah.
Can you start with the first stage?
Yes. My topic of presentation today is on evaluation of folic acid and chlorhexidine mouthwash as an adjunct to scaling and root cleaning in management of periodontitis patients. Coming to introduction, periodontal disease is an immunoinflammatory response against microorganism, and the host-mediated inflammation is the major causative factor. Hence, any treatment mechanism should involve the control of host-associated mediators, and this is the potential target. The traditional treatment is scaling and root planing that remains the gold standard for the non-surgical management of periodontitis. The gold standard agent used along with scaling and root planing as a chemical plaque control is chlorhexidine. So our conventional treatment starts with mechanical debridement followed by usage of chemical plaque control agents, which enhances the outcomes of mechanical debridement. However, now the target is towards discovering newer agents, and they are being researched upon, though that they can also be used as adjuncts similar to chlorhexidine. And previous studies have been done on folic acid supplementation and its effect on periodontal tissues. There are few of the studies which I have highlighted. They have focused on folic acid as a systemic supplementation and also as local usage for enhanced healing of periodontal tissue. And there was a significant reduction achieved in gingival inflammation and overgrowth with folic acid supplementation, which was proven in Neva et al. Study, which was published in 2003, and also a study by Pack et al. 1984. And nutritional examination survey data linked folic acid inadequacy to periodontal disease severity and suggested its use to reduce disease severity. And there have been various topical folic acid studies also being conducted. One thing is the folate mouthwash and its effect on periodontal patients, and also a folic acid gel, a newer study which is formulated in case of desquamative gingivitis. However, there are no studies that evaluated folic acid mouthwash as an adjunct to SRP in periodontal therapy. Hence, the aim of the present study is to assess the effectiveness of commercially available folic acid mouthwash as an adjunct to scaling and root planing in patients with periodontitis. Objectives of the study to evaluate the changes in the clinical parameters between baseline and after SRP. We have taken plaque index, gingival index, probing pocket depth, and healing index. Materials and methods. Patients visiting the Department of Periodontics in SRM Katamkuttu Dental College who are satisfying the inclusion and exclusion criteria. Written informed consents are obtained and clinical parameters are recorded. These are my inclusion and exclusion criteria. Patients of inclusion criteria, patients of age 18 to 50 years, systemically healthy patients, patients with generalized chronic periodontitis exhibiting a pocket depth of more than 5 mm, with CAL of more than or equal to 3 mm, and exclusion criteria, patient who has undergone periodontal treatment in the past 6 months, patient who were on antibiotics, smokers, alcoholics, pregnant and lactating women, and medically compromised patients. Now, coming to the methodology, total of 32 patients were included in the study, with the folic acid group containing 16 patients and chlorhexidine group containing 16 patients. Baseline clinical parameters were recorded, and then scaling and root planing was performed in both the groups. In group 1, we gave folic acid mouth rinse as an adjunct to the mechanical debridement. And in group 2, chlorhexidine was given, and the patient was reevaluated at the end of 4 weeks for the same parameters that included plaque index, gingival index, healing index, and probing pocket. Coming to the results, and we included healing index in this study because usually we include only PIGI and probing depth. We included healing index because folic acid has been shown to improve tissue healing in certain studies, especially in gingival overgrowth and all. They have used folic acid as a topical application, and they have established that there is an enhanced healing of tissues with application of folic acid, because they increase the turnover rate of the gingival epithelium, at the same time increase the keratinization of the epithelium. And coming to the results, following non-surgical periodontal therapy, clinical measures like plaque index, gingival index showed statistically significant reduction, and there was an improvement in the healing index in both the groups. The mean probing depth of chlorhexidine and folic acid mouthwash group were 5.05 mm and 4.87 mm respectively, and both groups showed a reduction in the probing depth, though it was not statistically significant with relevance to probing depth. And intra-group comparison showed a significant reduction of all the parameters from baseline to post-operative. Coming to the discussion, as it's clear from the study finding, there are no discriminable difference between the two mouthwash at the baseline. Both chlorhexidine and folic acid show significant reduction in plaque index, gingival index, and healing index after 4 weeks, similar to the study done by Iseki et al. But here they used folic acid as a systemic supplementation. And in the current study, with the same group of periodontitis patient, with similar group of periodontitis patient, we have performed a topical application in the form of mouth rinse. Both groups displayed comparable baseline probing depth also, and after 4 weeks, there was reduction in the probing depth. The above findings are also in accordance with Varad et al. Study. However, they also compared serum folic acid and periodontal status. So, we don't have an established study with a similar population. However, there are studies with folic acid mouthwash in gingival overgrowths and other gingivitis patients also, but not exactly in comparison with chlorhexidine and periodontitis patients. Conclusion, mouthwash containing combination of various agents like folic acid has been a promising potential for wound healing, anti-inflammatory and plaque inhibitory properties. However, this plaque inhibitory property aspect should be confirmed with the future studies which may evaluate the microbiological aspect of the disease also. And studies with washout period crossover design and as I said, the microbiological evaluation would be more authenticating. Furthermore, systemic folic acid supplementation was also been proven to be beneficial in smokers. However, in this study, we excluded the smokers. So hence, future studies can be done using the folic acid mouth rinse in smoking patients also, because they have a compromised healing potential. Maybe this kind of mouth rinse can be beneficial in such population. And also further studies with biochemical and also microbiological evaluation will provide a valuable information on the efficacy of this mouth rinse as an adjuvant to periodontal therapy. Can I stop sharing, sir? Or...
Yeah, your presentation was very nice, and it is a moreover an in-vivo study. I'm so happy to see.
Okay,
and regarding to the folic acid,
sir, I'm not able to hear you, sir.
Can you know the mouthwash? Can you hear now?
Sir? Yes, sir.
Yeah, your presentation was very nice. The in vivo study was
Thank you,
very
sir.
good.
Okay,
And
sir.
my question is regarding the dilution factor of the folic acid as a mouthwash.
Okay,
Because
sir.
many of the mouthwash which can cause staining of the tooth,
Yes, sir.
and
Yes.
many things to be seen before
Yes.
coming
Yes.
to the market. So
Yes, sir.
basically, we know chlorhexidine also is having some potent factor of
Staining.
making the staining characteristics.
Yes, sir.
So
Yes,
folic acid is moreover iron characteristics needed.
yes, sir. Yes,
So
sir.
it can cause more amount of staining parameters in the tooth.
Sir, yes, sir. We had a doubt on this. That's why we didn't customize the folic acid mouth rinse, sir. It is a commercially available mouth rinse that we have used in the study, and it is this folic acid is present in the mouth rinse as a combination. Along with other agents, it is present, and it's a commercially available product, and they've proven it to be in the market. That's why we used it. But certainly we had this doubt also. Maybe a longer period of follow-up study should also be conducted in this regard, sir.
Can
We
I
also
know the time frame, or how much time frame this was used,
this
and how
was
many
this
times it was?
this we have advised this for 2 weeks, but we evaluated the parameters after 4 weeks only, sir. Then only we can establish somewhat the post-operative effect. So in between, maybe at a 2-week follow-up, we should have evaluated for the staining properties, as you said, sir.
So
That could
staining
have
can
been
be
done.
characteristics with what equipments? Any equipments, special equipments needed to know the staining characteristics?
No, sir. Just a visit after 2 weeks to know the difference. Maybe we can compare with photographs. If there are any
Yes.
changes in the shade of the tooth like that, any particular equipment is not available, but we re-evaluated the patient only after 4 weeks, sir. Maybe a shorter follow-up and a longer follow-up should be there to evaluate the patient in a staged manner to understand if the folic acid is causing any staining, as you said, sir. Maybe we should have done that. That is also a drawback in the
that is
study.
the only
Yes,
thing I'm having a doubt,
yes,
because
sir. Okay,
other
sir.
things are fine from your presentation. Thank
Okay,
you.
sir. Thank you, sir. Thank you so much.
You can go to the next presentation.
Yes, sir. Our next presentation is presentation by Dr. Angeline Aishwarya B. on a topic of Unwrap a Smile.
Yeah, doctor, we can present. Is there any issue with the presentation?
Yes, sir. I'm unable to share it. I'm trying to share now. Give me a minute.
Yeah.
Good morning, everyone. Am I audible?
Yeah, can you little more louder?
Yes, sir.
Yeah, it's fine.
Audible? Yeah.
Yeah.
My poster seen?
Doctor, you can start. Can hear
Yes.
you.
Okay, sir. Good morning, everyone. I'm Dr. Angel and Aishwarya from Savita Dental College, here to present a poster on Unwrap a Smile. And I'm here to present a case report of Ellie's class 2 fractures restored using direct nano composites and indirect ceramic veneers. There are two case reports. So I would like to say that Ellie's class 2 fracture is a fracture involving enamel and dentin. I'm here to say how aesthetics play a major role in restoring the lost enamel and dentin using direct nano composite and indirect ceramic veneers. So here, the first case report is a patient reported to the dental clinic with a chief complaint of fracture in the front teeth, followed by a trauma before 2-3 days, and she wanted immediate treatment. And on clinical examination, the substrate was good to bond, and she didn't have any symptom. She was completely asymptomatic. So I took an impression and gave it for a mock-up, and I thought the tooth build-up was sufficient. And I thought of proceeding with composite restoration. Hence, the pre-op pictures were taken, and then shade matching was done using button technique. And then the composite restoration was proceeded using putty index, palatal shell was made, followed by all the protocols like under rubber dam. As you see in the picture, etching was done using 37% phosphoric acid for 15 seconds and then rinse for 1 minute. And this was applied, nicely scrubbed, and then thinned and then cured. And then layering was started as a palatal shell was formed using transparent tea shade first, and then layering was done as dentin shade and enamel shade, and then contoured using composite brushes and then opera and on top of the enamel layer, another achromatic enamel layer was applied, and then the finishing was done using a slow speed hand piece and then super snap polishing kit. And the final polishing was done using Eve Diacom and Eve Diapro. And as you all can see, that's the outcome of my direct nano composite restoration. And that's how I unwrap the smile of this patient using direct nano composite. And another patient reported to the dental clinic with a chief complaint of fracture in the front teeth, followed by a trauma. But he had restorations before, and he complained of repetitive fracture of those restorations also, and he wanted a permanent solution for it. And hence, I explained him about the indirect ceramic veneering technique, and he was okay with proceeding it. And I thought of doing trans-elimination test because I could find remaining composites like the previous restorative material there. And on the trans-elimination test, I could see minor cracks on the adjacent tooth also. So I thought of proceeding with 2-unit, like 2 central incisor veneers, and he was okay with it. And then the old composite restoration was removed. And then the tooth was prepared for veneer. I thought of proceeding with incisal bud preparation and adjacent tooth, and the fracture tooth was gone for incisal bevel. And as you all can see, the retraction cord was placed to isolate the finish line, and then digital impression was taken and sent to lab for the fabrication of veneers. Till then, the temporary crown was given using Protem. and he was all fine. And on the day of bonding, he was happy with the outcome when I gave him the try-in. Then under rubber dam isolation, the tooth was etched, and then bonding was applied, and then air thinned, and the veneers were surface treated on the veneer box. Like 4.6% hydrofluoric acid was applied and then etched for 20 seconds, and then rinsed for 1 minute, followed by application of saline coupling agent, and then air thinned, and then it was luted using light cure resin cement. And the curing unit used was blue phase, and that's the outcome of the 2-unit like central incisor veneer restoration. So that's how I unwrapped the smile of another patient using indirect ceramic veneers. So that's how I conclude by saying that Elise class 2 fractures can be restored aesthetically using direct nanocomposites and also indirect ceramic veneers. But the treatment plan can be modified based on the substrate to be bonded, durability and biocompatibility of the tissues and the material used. Thank you.
Yeah, that was a very good case presentations,
Thank
and
you so much.
and you unwrapped our smiles also.
Thank you so much, sir. Thank you. Means a lot.
And what the thing is, these materials are very technique sensitive. Am I right?
Yes, sir.
So you are not you are not saying that point alone, because we can make everything possible with composites. But only problem with veneers is I feel there's a loss of less amount of two structure loss go, but there's a more types of chipping also can be happening because of it. What you say about it?
When there's no contact with the lower anteriors and the MIP like in the centric, I feel it is there's less chance of chipping, sir. When there's
But
no contact.
in your second case, the photograph shows that he's having some deep bite.
Because I have just put the lower smile, it was not deep bite.
Okay.
I could have added a MIP picture. I'm sorry. Yeah.
Because the photograph shows that it's looking like a deep bite. I feel like this is like a deep bite.
Okay.
And the first case, I can see some amount of eccentric location of the teeth. Can you able to see the second picture where the occlusion is not up to the aspects?
Okay, sir. Okay.
I feel like that because the photo shows like that, but I don't know whether it is correct or not. And the recording of the cases are very fine. What is the stick which we are using to?
Optostick, sir.
So what is that? We all know that Optostick, and what is the material is used to carry it? Some glue-like materials there, no?
No, sir. It comes as the stick has the glue. The tip has the glue in it.
That's what I'm asking. What is that glue? Is there going to any type of interaction within when you're going to do the hydrofluoric acid treatment? Can you use that same tip for it to avoid the overexposure of the hydrofluoric acid etching?
No, sir. We use veneer box for it. The veneer box has a glue on it. Like it has a marking for each tooth on that box, and next the whole box has glue on top of it. So we just have to place the veneer on the glazed surface on the gum, on the glued aspects. And so it's very easy. We have a net cover also on top of it to cover it, so that we apply hydrofluoric acid, put the net cover on it, and then nicely airspray it so that the veneer will not flew.
What about the gingival retraction cord?
We do using brinkers we place, and then we place 2 cords, 00 and 000.
Yeah. That's good, and thank you for your explanation, and thank you.
Yes, sir. Thank you so much.
Thank you, ma'am.
Thank you.
Our next presentation is poster presentation by Ms. D. Rupasya on a topic of augmented reality in treatment planning. I'm sorry, sir. In between, there is a participant, Shantini Priya.
Okay.
The topic is on influence of social media in orthodontic practice, a questionnaire study, which is a oral presentation.
Good morning, sir. Is my screen visible and I'm audible?
Yeah, can a little more audible?
Yes, sir. Is it fine now?
Yeah, yes, now.
Yes, sir. Thank you, sir. Good morning, everyone. I'm Dr. Shantini Priya from Department of Orthodontics, Tagore Dental College. And I'll be explaining about my study, the influence of social media in orthodontic practice. It's basically a questionnaire study. So moving on to the introduction part, the social media use of social media has been increased in a greater amount. After the COVID situation, the amount of social media usage by the teenagers as well as the middle age group individuals has shown to be increased into a wider extent. So orthodontists also use the social media platform to market their own clinics as well as their skills. So they basically use the pre and the post treatment photographs of their patient and share the educational video. Social media platform being a low cost marketing strategy, which reaches the hundreds of viewers, gives a new patient to the clinic. So this is the ideology of current situation. So the online and the social media are developing as a crucial and effective reliability management tool. Recently, Instagram has become the most used platform for digital marketing in the field of aesthetic medicine. And recent days, aligner treatment has been popularized by the social media. And the direct-to-consumer aligners have been getting popular since from the COVID days. So there are various actions taken by the different countries' dental association, warning the general public about the deleterious effect of the direct-to-consumer aligners. But there is still lack in the awareness about the ill effects of the direct-to-consumer aligners. But the number of patients opting and inquiring about these aligners have been markedly increased. So this study aimed to evaluate the influence of the digital marketing in orthodontic practice and opinion about the direct-to-consumer aligners among the patient as well as the orthodontists. So aims and objectives include to evaluate the influence of the social media on the patient seeking orthodontic treatment in different age groups, to evaluate the usage of the social media platform as an awareness media by the orthodontists of different age groups, to evaluate the knowledge about do-it-yourself aligners or at-home aligners among the patients seeking orthodontic treatment, and to evaluate the attitude of the orthodontist about do-it-yourself aligners or the aligners delivered at home. And moving on to the materials methods, the ethical approval was obtained from the institutional review group. The study consisted of two groups. First group of questionnaire for orthodontists, and second group is the patients. The questionnaires were validated by the peer orthodontist, and the questionnaire were prepared using the online platform, that is the Google Forms. A self-administrated structured multiple choice questionnaire was distributed to the concerning participant through the online data collection platform. The study population consists of orthodontists of India and the patient seeking orthodontic treatment. So the questionnaire was given to the orthodontist by the WhatsApp various orthodontic study groups which have been present in India, that is Madras Orthodontic Society, for example, and Bangalore Orthodontic Society. And the questionnaire was given for patients seeking orthodontic treatment between age group of 16 to 55 for a period of about 2 years. And the questionnaire for the patient consisted of the details about the age and the gender, and the preferences for the social media platform, which platform they use, and do they feel if they have any alignment problem, and the knowledge about the orthodontic treatment, and the preferences of the orthodontist based on their post or videos in the social media platform, and their idea about the direct-to-consumer aligners or aligners which are delivered at home, and knowledge about the prerequisites required before the aligner treatment planning. And for the orthodontist, the questionnaire composed of age, gender, years of experience, preferences of their social media platform, usages of the social media platform as an awareness purpose, patient contact through the social media platform, and if there is any increase in the percentage of patient walk-ins to the clinic because of their advertisement in the social media platform, patient inquiry about the type of treatment, orthodontist perspective about the in-house or the at-home delivered aligners. So these were the questions which were being given to the orthodontist and the patient. And the descriptive statistics were performed by calculating the total account and the percentage of qualitative variables, the mean and standard deviation of the numerical variables. Pearson chi-square test was performed to compare the dependent variables between different age groups, and significance level of 0.05 was considered to be statistically significant. So moving to the descriptive data, we had around from 15 to 20 years of age. We didn't select any patients. The inclusion criteria was only patients from 15 to 55 years, above 55 years of age, 55 years of age. So we had divided the age group into 15 to 20 years of age, 21 to 25 years of age, 26 to 30 years of age, and above 30 years of age. And we had almost about normal distribution of the data. And it invariably, majority of the population uses this social media platform. And when we asked about their knowledge about their teeth alignment, majority of the patients feel that they have some problem related to the teeth. And when we inquired if they've researched about it, the p-value shows significant, showing that the younger population and the population between 26 to 30 years have researched more about that. And we have even inquired if they have seen any posts or videos regarding the orthodontic braces. We got a positive result saying yes, that they have already researched before coming to the clinic. And we asked what was the post or the video was related. Majority was about the advertisement of the clinic, and awareness only about the type of braces. The management of the braces and pain related issues were relatively low. And does that post and video motivated them to undergo an orthodontic treatment? We had a 100% result that all the age group thought it showed that it really motivated them to undergo orthodontic treatment. And we asked, will they choose or select the orthodontist based on the post or the videos in the social media platforms? They gave interesting results that between 15 to 20 years of age, they will basically select their orthodontist based on their post and video. And as the age progresses, we got the answer as no. And based on what post they will choose their orthodontist was our next question. And the younger age told us that they'll select based on their before and after treatment photographs, and followed by the comments in the post and the videos. And finally, the orthodontist profile. But the orthodontist profile was considerably lower in all the age groups. So when we asked about the types of braces and the knowledge about the braces availability, majority of population below the age of 30 told that they are aware of it. And what type of braces will they prefer? Mostly the younger population went for an aesthetic option such as ceramic braces. The older population also that is above 30 years preferred aesthetic appliance, that is the aligners. So when we asked who can plan your treatment plan for your aligner purpose, we got the answer as orthodontist for the younger age group, and for the older age group, it was about the dentist who will plan their treatment plan. And we asked about if they have come across the aligners which is being delivered at home. They were well aware about it. And do you feel, and we had a statistically significant value for that too. And we asked them if they know if it's safe or not. They were saying that they are aware that it is not safe and it's been delivered to home without a proper medical care. And we asked that what are the procedures involved? Were they aware that there were procedures involved before going for an aligner treatment, which includes X-ray, history taking, X-ray analysis, etc. Majority of population said no, and they were not sure about it. And we asked, are you aware that do-it-yourself aligners can harm your gums and teeth? And we had a mixed reviews, like they were not sure and as well as not sure and no, they were not aware. Moving on to the questionnaire for the orthodontist, we asked, do they use social media platform? Yes, we got a positive response. Like they used all the age group uses social media platform. Do you use the social media platform for creating awareness for the orthodontic treatment? Majority of the population below the 55 years of age told that they are using the social media platform for the awareness purpose, but above 55 years, we had a negative response that they don't use it. Does patient contact through you or to you through social media platform? We got the answer as yes. They do message them through the social media platform, and we asked if they had any increase in the number of patients flow in the clinic because after usage of social media awareness messages and etc. And we had a positive response that there was an increase except for the higher population, which is due to the usage of the social media platform for the awareness purpose. When we asked by how many percentage, we had the majority of answer as just 0 to 25%, not greater than 25%. And does the patient demand the type of bracket to be used? That was invariably yes from all the age group. And we asked, do you think there is certain posts and videos in the social media which is misleading the patient about giving a wrong information to the patient? And about 90% for all the age groups of orthodontists said it is yes. Have you come across any post or video about at-home aligners? And it was also an yes answer, giving a majority of it. And do you feel the patients are unaware about the deleterious effects? All the orthodontists invariably accept that patients are still not aware about deleterious effects of the unmonitored aligners. And have you heard about, have you had any retreatment cases of at-home aligners? It has been shown that it's been increasing drastically, and number of retreatment cases following aligners have also been increased. So what we asked, what do you think is the main cause for the patients to opt for at-home aligners? And we had a mixed answer that it can be due to lesser cost and lack of time to visit orthodontist. And majority of the feel that is because of all the reasons, which includes lesser cost, attract offers, lack of awareness, lack of time to visit orthodontist, and all of them. So moving on to the discussion part, the study was in accordance with the previous study, which showed that digital marketing plays an important role in orthodontic practice. Based on the results obtained from the previous R study, Instagram is most commonly used digital platform by the orthodontist as well as the patient. And previous study has also shown that Instagram is being most commonly used by the patient as well as the orthodontist. And according to the orthodontist, the number of patients has increased following their post in the digital platform. The majority of the orthodontists feel that the increase is very lesser in number. The study by Papidometry also showed the same. According to the orthodontist, the patients are unaware about the deleterious effect of direct-to-consumer aligner. There's a previous study in AGO also showed that the patients are really unaware about the deleterious effects of the unmonitored aligners, and the number of patients seeking orthodontic treatment after the at-home aligner treatment has also markedly increased, which is being shown in few studies which has been published recently. Based on the current study, digital marketing plays an important role in orthodontic practice. This was in concordance with the previous study. So I would like to conclude by saying that the patient in the age group of 24 to 34 years of age research a lot before coming to the orthodontic appointment. Patients select the orthodontist based on their posts and videos in the social media platform, showed a statistically significant results. Majority of patients are unaware about the importance of records taken before the commencement of the orthodontic treatment. Young orthodontists use the social media platform for the awareness purpose. Instagram is the most commonly used social media platform. Patient contact the orthodontist through the social media platform, but the patient turnover has not increased more than 25%. Based on the orthodontist's perspective, patients are unaware about all the ill effects of the aligners delivered at home. The number of free treatment cases following the aligners delivered at home has markedly increased with orthodontics with higher years of experience. And these are my references. Thank you.
That's a very good eye opener for all the persons who are living in India, especially about the orthodontist or endodontist idea. Regarding to your presentation, I can say some ethically needed stuff should be there for everyone. Because many people are doing unethically orthodontist, not only orthodontist. Orthodontist should perform orthodontist work, am I right?
Yes, sir, yes.
But non-orthodontist, endodontist doing orthodontic work, a surgeon is doing orthodontic work. Why that why that question is not raised in this forum?
Basically, this ideology is about the direct to consumer aligners.
Yeah, that's
We can-
correct. But I can see many clinics. Still, there is a more persons who are not educated for orthodontics, but basic orthodontics they know because of BDS curriculum, and they will do some fellowships and other things, and they can rule the world. They are thinking, but yeah. So you are saying only for the digital platform, you can increase the marketing strategy, and we can get all the types of aligners and other things. But still, our own persons are doing such type of mistakes. Once the orthodontist is studying for this last 3 years and he is doing some work is fine. But other persons who are not justify the thing and they're doing the aligners product is not a good thing, I'm thinking. And
Yes, sir.
I think that part should be included in the study. That will be a wise point in the study, I think so. Because it's mainly
Yes.
related to the digital and marketing strategy, I think so. Am I right?
Yes, sir. Yes.
Yeah. What is your comment regarding that?
Regarding the direct consumer aligners or the other specialty
Yeah,
practice
yeah,
in
yeah.
orthodontics, sir? Direct to consumer
Specialty
aligners.
specialty persons should be doing this aligners or orthodontic works. I'm so guaranteed for it. But
Yes, sir.
specialty not invented. That means the person who's an endodontist. I'm an endodontist. Okay. So if
Yes.
I'm going to do a aligner treatment for a patient, if it's not going to be a good type, okay, that is also a problem. I think.
Yes, sir. It's ethically not correct.
Yeah, the technically is
And
not correct, and you should not, and it's not into that questionnaire. That questionnaire is not having that point. Because
okay,
I can see more the 60% of the dentists are doing all the jobs.
that's true, sir. But
Hmm.
but
I
how is
can
it?
see
The trend is going is that
the
now the
trend should be
companies are
no, no,
taking
that
over
trend.
the dentist as well. That's the problem right now.
That's what yesterday's you seen some news flashing that medical reps should not give any types of prices or incentives or any flight tickets to the doctors. From the central government, they announced a thing. Day before yesterday, I think so. Am I right?
I'm
You're
not
not?
aware, sir. Okay, I'm not aware of it.
Yeah, that they should bring that norms to the all the dentists to dentist, BDS doctor should perform this one. MDS fellow should do this one. This is the making conspiracy. This is the way to transparency. Illama, we are making all the jobs, all the aligner, new types of Colgate. Always, all persons will come into the market, and there will be a zero revenue for the persons who are coming to a orthodontist or endodontist like that. Am I right?
Yes, sir. I am just very happy that you're supporting this aspect of it.
Yeah, I'm very happy to see such type of survey output, and I want to add this point in the future studies also because this is a more culprit thing which is happening nowadays. You are educating to get the best of the thing, but you're not educating to get the worst of the thing. So some things which is not coming to the point is all dentists perform work. I can understand, but you should leave the specialty wise things to the specialty owners, not to the other specialty owners. That's my point.
Yes, sir. Maybe your future studies will just concentrate.
Yeah. Thank you. Thank you very much.
Thank you, sir.
Thank you, ma'am. Our next presentation is poster presentation by Dr. Rupasya on a topic of augmented reality in treatment planning. Ms. Rupasya?
Yeah, I'm sharing my slide.
Okay, thank you. Is there any issue with sharing?
Can you just give me 2 minutes?
Yeah, sure. So she's having presentation with sharing. Sorry, she's having trouble with sharing. Can we move to the next presentation, sir, so that we can take her after that?
Yes, madam. You can proceed.
Yes, sir. Thank you. So our next presentation is poster presentation by Dr. Hariharasudan J on a topic of bridging the gap, human and computer intelligence in cleft care. I guess we are not having the participants, sir. We will be moving to our next presentation. It is poster presentation by Dr. P. Lakshmi Prasanna on a topic of microbiologically induced corrosion of orthodontic stainless steel alloys, a cross-sectional study.
You can proceed.
So, Dr. Lakshmi Prasanna. Final call for Dr. Lakshmi Prasanna. Dr. Lakshmi Prasanna, kindly share your screen and start presenting, please.
She's there in the meeting, but can't hear. I think so.
Yes.
Am I audible now?
Yes,
Yeah.
you're audible.
Okay. So just give me a second, sir. It is not opening. There are some issues here.
No problem. Take your time.
Is it visible, sir?
I can see the end of the slide.
Now?
Yeah. Can you put in the slideshow?
Is it,
Yes.
sir, it is in slideshow only.
Yeah, it's fine now.
Okay. Yes, sir, I'll start. Good afternoon, respected panel. My poster is on microbiologically induced corrosion of orthodontic stainless steel alloys, a cross-sectional study. Moving on to the introduction, we know that one of the most common used alloys in orthodontics is stainless steel alloys, both in removable appliances and fixed appliances in the form of wires, brackets, and various auxiliaries. These stainless steel alloys, they're of austenitic type, which are composed of 18% chromium and 8% nickel. The chromium here, it forms a passivating oxide layer over the metals and owes to the corrosion resistance of the metals. But when the same stainless steel alloys, when it comes to orthodontic patients who undergo a treatment for approximately 1.5 to 2 years, they are subjected to a diverse environment, say the oral environment, in the form of various biofilms, variations in the pH differences, temperature, bacteria, enzymes, and other metabolites. They are subjected to a kind of destruction, which is nothing but corrosion, an electrochemical process where there is interaction between the metal and the surrounding environment, resulting in alteration in physical and chemical properties of these materials or metals. This corrosion can be of many types, like uniform attack or pitting, intergranular or crevice corrosion, or even an MIC, nothing but microbiologically induced corrosion or biocorrosion, when caused by bacteria, algae, or fungi. The most common bacteria that are implicated in this corrosion process is acid producing bacteria, iron oxidizing, manganese oxidizing bacteria, and sulfate reducing bacteria. When this bacteria, they cause corrosion, it results not only in the destruction of the metal and thereby having effect on the orthodontic treatment, but because of leaching of the ions into the oral cavity and into the systemic environment, there are also biological effects too. This property of biocorrosion, or this mechanism of biocorrosion, was very well studied in marine environments and nuclear power plants, etc., which resulted in greater loss to the functioning of the plants as well as an economic loss. But it was very least studied in orthodontics and its effect on orthodontic patients too. Hence, my study was to determine if there are any variations in the quantity and quality of bacteria involved in this process biocorrosion in plaque samples of patients treated with fixed orthodontic appliances with that of untreated healthy individuals, and to evaluate if these bacteria could cause corrosion of stainless steel orthodontic alloys in vitro in artificial salivary media. So the methodology was, now we have discussed the types of bacteria that are involved in the biocorrosion. Hence, to support their culture, we have the culture media blood agar, mutans sanguineus agar for Streptococcus mutans, McConkey agar for lactobacillus, manganese agar for manganese oxidizing bacteria, and API broth for sulfate reducing bacteria. So the sample was study sample 20 debonded patients who were initially bonded with a fixed orthodontic appliance of stainless steel type with age group of 15 to 25 years, and control sample was 20 untreated healthy individuals who were periodontally healthy, and individuals with systemic infections or any oral cavity infections, or those who were on antibiotics or any other medications or that can influence a study, were excluded from the current study. And the statistical analysis used to interpret the results were independent sample t-test to study the variations of bacteria among all groups, and chi-square test to study the variations of sulfate reducing bacteria between the two groups. So the study was conducted in two parts. The first part being a microbiological study, where supragingival plaque samples from the study sample and control sample were collected from the buccal surface of maxillary premolar, right-handed control for right-handed patients and left-handed control for left-handed patients. And these samples were inoculated into a thioglycolate broth of 2 ml, which is a transport medium. And from this, the sample was subjected into various culture media plates using streaking methods, and they were inoculated, incubated at respective or related manufacturers' guidelines. Now, when The cultures were identified between the study sample and the control sample. It was found that the total colony count, that is overall bacteria, the Streptococcus mutans colony count, Lactobacillus colony count, manganese oxidizing bacteria, and sulfate reducing bacteria, which were identified with the help of the culture characteristics, were found to be statistically significantly higher in the study group when compared to the control sample group. So the first part of the study showed that these bacteria were higher in the orthodontically treated patients. Now, using the culture characteristics, few bacteria were specifically identified and they're isolated. They are S. mutans, beta hemolytic streptococcus, enterococcus, lactobacillus species, bacillus species, pseudomonas, and sulfate reducing bacteria. S. mutans, they were identified with the help of frosted glass appearance on the culture plates, lactobacillus with the help of lactose fermenting colonies, and sulfate reducing bacteria, they were identified based on their ability to convert the API broth into black color when the sulfate was reduced to sulfide by these bacteria. Now, these isolated bacteria, they were inoculated into a cuvette containing artificial saliva with a stainless steel orthodontic bracket in order to study the corrosion property of these bacteria on the metal. They were incubated at 37 degrees Celsius for 30 days. A control bracket was also used, but without the inoculation of the bacteria into it. So the second part of the study was FESEM study, scanning electron microscope study, with a similar magnification of 2500 times and 3 kV, where the center of the bracket slot, where we see the interaction of the bracket with the wire, was studied for any destruction that happened or that caused by the bacteria. When visualized, you can see on the right-handed corner, we have, just a second. We have pitted appearance that was caused by Streptococcus mutans, beta hemolytic Streptococcus, and Enterococcus species, with a deeper and larger bits in case of Enterococcus. Lactobacillus was found to cause ridged pattern. Pseudomonas was found to cause a deeper patterns of discrete manner. Fringe pattern was observed with the help of by means of bacillus, and the sulfate-reducing bacteria at the end was found to cause a deeper cracks and the narrow cracks. So this study helped in identifying that the bacteria which were implicated in corrosion were very highly present in orthodontically treated patients, and the identified bacteria were also proved of causing destruction in a significant way on orthodontic stainless steel alloys. So in the light of microbiologically induced corrosion, which is very least studied in the orthodontics, this study serves as a foundation for the future research to implement strategies on minimizing the biofilm in the oral cavity or improving the corrosion resistance of orthodontic metals, as well as stresses the importance of maintaining good oral hygiene by the patients and educating them on that, and the sterilization parts as well. And these are the important references related to the study. Thank you.
Yeah, that was a very good presentation. And regarding to your treatment protocol for this type of conditions, what is your treatment protocol?
So I didn't get to treatment protocol.
For this type of condition, if it is going to be having orthodontic stainless steel corrosion, what you are going to say?
So this is one particular phenomenon, like which is how much ever you try to prevent it, it is unavoidable to maximum extent. Only thing we can do is we can minimize it, because we can never eliminate bacteria from the oral cavity in total. So when we try to, if we see from minimizing this happening, we can do it from two aspects. We can educate the patients to maintain good oral hygiene regarding the brushing techniques and giving them antimicrobial mouthwashes, and asking them to come for regular appointments where we can do scaling procedures. And the second aspect is we can develop the metals which we use commonly into more corrosion resistant type by coating the wires with the help of antimicrobial materials, etc.
So any other mouthwashes you are prescribing for this type of patients to reduce the surface that bacteria which is present on the wires? As mainly sulfate reducing bacteria will be causative agent, I know. What are the mouthwash we can recommend for this type of patients?
Sir, again, as explained here, all the bacteria which are present in the oral cavity, in maximum, they can cause corrosion.
Any type of mouthwash which can reduce the SRB level.
Only SRB you're saying, sir?
Yes.
Okay, I'm not sure about only SRB because when we prescribe a mouthwash, it has to be like it has to act on all the kinds of bacteria. So here we are prescribing chlorhexidine alone as of now, which is easily available.
What's the basic disadvantage of a chlorhexidine mouthwash if it is used directly?
Okay, sir.
If you use the chlorhexidine mouthwash directly, what is the disadvantage we can see?
We can see staining of the teeth, or it can also cause
That's why I'm
irritation.
asking, what is the other variety of mouthwashes we can't given to the patients to avoid this type of corrosions? And any mechanical debridement options can be done to reduce this SRB level, like root planing, scaling.
Yes, sir, definitely. That is why, like, when the patient comes for, that is why stressed for regular appointments for the patients. So when they come, we can assess the periodontal status too, and we can subject them for scaling and root planing to remove the local debris that is present over there. And that is the major cause for this corrosion process.
Okay.
Yeah.
Thank you.
Okay, sir. Thank you.
So can we take Ms. Rupasya's presentation now?
Yes, madam, you can proceed.
Yes.
Good morning, ma'am. Good morning, sir. Am I audible?
Ms. Rupasya, you can start with your presentation, please.
Good morning. The topic I'm going to speak about today is augmented reality in treatment planning. AI has emerged as a game changer in healthcare. Imagine a surgeon being able to see layers of tissue during a surgery, or a medical student practicing complex procedures in a risk-free virtual environment. The scenarios that were once confined to realms of imagination have become everyday realities. And for that, thanks to AI. My session will explore the fundamentals of AI and its vast applications in the medical field. First and foremost, let us look into what is augmented reality. Augmented reality Augmented reality allows us to experience the real life environment around us with a digital augmentation overlaid on it. AR works by integrating the digital information or content into the user's environment in the real time. The objects that reside in the real world are enhanced using computer generated capabilities. Now, let us look into the differences between virtual reality and augmented reality. The virtual reality completely immerses its user in a fully computer generated environment, isolating them from the real world. Whereas augmented reality is the integration of digital information with the user's environment in the real time. Moving on to what are the elements in AR. AR includes graphics, effects, sounds, text, and touch feedback that improves user experience. In this technology, the user interacts with virtual objects placed in real world. Let us now look into the challenges faced during treatment planning. The traditional methods can lack proper visualization, and there were also difficulties in explaining effectively conveying the treatment plan to the patient. There were also chances of inaccuracy in traditional methods. Like, how does AR help in overcoming these challenges? The groundbreaking AR trends in healthcare is a boon to dentistry actually. Augmented reality helps in improving the clinical practice in field of dentistry, as well as to both the dentist and the patient. The clinical information that is generated can be directly visualized from the real world with the digital world. Augmented reality improves like it improves the clinical practice in the field as well as the clinical information. From looking from a clinical perspective, maxillofacial, orthodontic, oral, and implant surgeries can be aided by augmented reality in the coming years. When coming to endodontics, procedures, video tools, and optimized, they are being used for accessing our root canals. It also helps when it is to orthodontics, it helps patient in dentists in placing their brackets through a three-dimensional image-based tooth tracking. From the preclinical perspective, the ability of augmented reality is to enhance our spatial visual perception that will go a long way in preclinical practice. Like, it helps students design their treatment plans, like design cavities. It helps them in understanding the human body anatomy. Like, even a complex surgical procedure can be
practiced in a risk-free environment. What are the benefits of augmented reality in dentistry? Augmented reality helps through enhanced visualization. Like it helps us in providing proper visualization, then precise measurements. Measurements made will be accurate, improve patient communication, and efficient workflow. Like it has its own limitations on the other hand. It includes the method is technique sensitive and it requires expertise, expensive, bulky, and intrusive the field of view is limited and causing retina issues. Like when virtually we go on digitally using, we get retinal issues. Then augmented reality operates using electromagnetic frequencies and exposure on high levels can cause health hazards. However, adoption of augmented reality in dentistry is increasing with each passing year, like almost 65% in 2020. Um, to conclude, augmented reality provides enhanced precision, improved patient communication, streamlined workflow, and customized treatment plans, thus making it the future of dentistry. Augmented reality is no joke or a scientific theory. It is emerging as a vital tool not just for surgical precision but also for enhancing patient care and rehabilitation. It has opened doors in diagnosis, treatment planning, patient engagement, and the patient care journey. Thank you.
Yeah, it's very good presentation. Thank you.
Thank you. Thank you, Rupasya. So our next presentation is oral presentation by Ms. Amardeepika J on a topic of estimating the prevalence and various types of bifid mandibular canal using OPG.
Am I audible, ma'am?
Yes.
Can I
Yes,
start the
doctor, you can
presentation?
proceed.
Thank you, sir. Can I start my presentation, sir?
Yes.
Good morning. I'm Amara Deepika. My article topic is about estimation of.
Hello.
Hello, 1 minute, sir. My article topic is about estimating the prevalence of various types of bifid mandibular canal using digital orthopantomograph for a retrospective study. Bifid mandibular canal is an anatomical variation within the field of dentistry and maxillofacial radiology. It is not only fascinating for its clinical implication, but also underscores the importance of personalized patient care in dental practice. Mandibular canal is a vital anatomical structure within the lower jaw housing in alveolar nerve and vessels. Usually, it is a single canal that runs from the mandibular foramen to mental foramen. However, some variation occurs, and one such variation is the bifid mandibular canal. In particular, the identification of this potential variation of the mandibular canal will allow the clinician to modify the surgical technique. The aim of the study is to detect the prevalence of bifid mandibular canal in adult patients who underwent OPG investigation at Tagore Dental College. Methods and materials, 1,000 digital orthopantomographs were studied in this study. Inclusion criteria, any digital OPGs, both pathological and diagnostic were included. Age ranges from 18 to 80 years. Exclusion criteria is OPGs from hemimandibulectomy were excluded and blurred images where mandibular canal couldn't be identified were excluded. According to the RPL, that is Reorganization of Prior Learning Categorization, bifid mandibular canal have been classified into 4 types. Type 1, bilateral or unilateral bifid mandibular canal extending to third molar to the immediate surrounding area. and type 2 bilateral or unilateral bifid mandibular canal which extend along the course of main canal and rejoin it within the ramus or body of the mandible. Type 3 is combination of type 1 and 2, and type 4 two separate mandibular foramen and two separate canals will join to form a single large canal. Results: out of 1000 OPGs, only 73 OPGs were identified to have bifid mandibular canal, and in that, female patients have higher prevalence when compared to that of the male. And among the types of bifid mandibular canal, type 1 is more common in more common in both male and female, and type 2 it is more in a male than female. Bifid mandibular canal was observed more commonly in the left side, that is 75.3%, which is unilateral, and among the types, type 1 is more common. Females have higher prevalence when compared to that of the male. And these are the variables. They are considered 4 variables: age, gender, and whether it is right or left, unilateral or bilateral, and type of bifid mandibular canal. Age criteria: bifid mandibular canal is more prevalent in the younger age group, that is 20 to 30 years of age. Gender: female have higher prevalence when compared to male. Right side is more prominent and that is unilateral. And among the types, type 1 is more common when compared to the other types of bifid mandibular canal, that is bilateral or unilateral bifid mandibular canal extending to third molar or immediate surrounding area. And distribution of bifid mandibular canal, it is more common in the female when compared to male, that too in the right side. Type 1 is more common, and age, it is more common in the 20 to 30 years of age group. Clinical significance: bifid mandibular canal has been identified as a challenge while administering inferior alveolar nerve anesthesia, and that it is more complicated in the type 4 patients, that the two separate mandibular foramen which joins to form a single large canal. And presence of bifid mandibular canal has additional clinical complication in mandibular surgeries, which include impacted third molar extraction, dental implant, fracture osteosynthesis, and sagittal with ramus osteotomy. If we fail to identify this bifid mandibular canal, we may damage the inferior alveolar nerve, which may cause paresthesia and traumatic neuroma. If we damage the vessels, it will cause bleeding during surgery. And patients with this anatomical variation, care should be taken while designing the prosthesis, because the branches reaching the retromolar pad, the patient with mandibular prosthesis and loss of alveolar bone close to retromolar pad may experience pain due to the pressure on the neurovascular bundle. So the prosthetic design should be considered. Limited study is that OPGs or 2D image of a 3D object. Thus, we may miss out the canal's medial or lateral bifurcation. So, if we suspect a bifid mandibular canal, advanced technology like CBCT should be prescribed for better treatment planning. These are my references. Thank you, sir. Hello.
Just a minute, please.
Am I audible?
Yes, you are audible. Just give us a moment, please. Like sir got disconnected.
Okay, okay.
Prasanji, be prepared with your presentation, please.
Yeah, ma'am, sure, ma'am. 1 second. Ma'am, I cannot share screen while other participants are sharing, ma'am.
Yes, I just told you to be ready. That's it. Like, sir has to join. So once the questionnaire is done, you can share your screen.
Ah, yeah, ma'am. Okay, ma'am.
Sorry for the inconvenience. Just let us wait for 2 more minutes. There's a connectivity issue from the server side. So please be patient enough.
Yeah, doctor. Hello.
Yes, sir.
Yeah, sorry for the trouble. Actually, I got switched off. My power got switched off, and I saw the studies till the result part, and it's very good. And very meticulous efforts were done for the study I seen in this post paper. And what is the incidence of geographical conditions of this bifid?
So no studies or evidences for the exact region for bifurcations.
Okay. And one more thing, what about the local anesthesia which you are going to give for this day patient? Any things to be checked before doing this bifid?
Usually we will go for OPG, sir. If we suspect like
No, no, most of the patients they won't see for OPG directly. They are coming for a extraction or going for root canal treatment for a lower molar. In that case, they will be taking one IOP only. In that IOP, they can able to visualize what is a bifid, what is a single way or like that. So, what is the thing that I'm asking is whether the tooth which is having a bifid type of communication, the LA location or LA loading or LA delivery will be changed or not.
we can use GOW gates, sir, for the for bifid mandibular canal. We can suspect such type of canal when patient after anesthesia, soft tissue will be anesthetized, like lips and chin will be anesthetized, but the teeth will not be anesthetized. So in the time we can suspect for bifid mandibular canal, and GOW gates is the technique for such type of canal.
Okay, doctor. Thank you very much. Very good.
Thank you, sir. Thank you so much.
Thank you. So our next presentation is poster presentation by Dr. K. Saji on a topic of analysis of apical third root canal, morphology of the palatal root of maxillary first molar and its proximity to maxillary sinus, a cone beam computed tomographic study.
Yes, ma'am. Good morning, ma'am. Good morning, sir. Today my topic is on analysis of apical third. Can you all see my poster, sir?
Yes, please go ahead.
Yeah. Okay. Okay, ma'am. So the aim of my study was to assess the angulation of the apical axis from the radiographic apex of the palatal root of maxillary first molar to measure the distance between the apex and the apical axis of the root and the distance between the apical axis and the maxillary sinus. So let me first tell you, like maxillary first molar is very prone to caries as it is the first tooth to erupt in the permanent dentition of the maxillary arch, which leads to longer functional time. So the palatal root of the maxillary first molar is in close proximity to the sinus floor. So it may be protruding into the sinus or maybe like seen due to overlapping of the anatomical structures on the digital radiograph or its root end lying to the contact with the floor of the sinus. So hence it is prone to any foreign material being extruded into the maxillary sinus due to ultrasonic errors such as apical debris extrusion during root canal treatment and in extensive surgical procedures. So it has proven that CBCT accurately determines the root morphology and canal configuration over conventional digital and film radiography. So what is CBCT is that it is a variation on traditional computed tomography that is on the rise. So it is like it has an X-ray tube and detector panel which rotate around the patient, capturing data with a cone-shaped X-ray beam, as you can see here in the picture. So instead of the slices like CT scanners are typically known for. So what are the advantages of CBCT it is the quality of the imaging. It provides more views and angles of the 3D images to evaluate more complex structures like bones and soft tissue. So when we come to the materials and methods, so here the figure A and B, the angulation A and B refers to the angulation between the radiographic apex and the apical axis of the palatal root of the maxillary first molar, and CD here represents the distance between the radiographic apex and the apical exit of the palatal root, and EF here shows the relation to the sinus. So what exactly the radiographic apex means is that the highest point or the tip of the root as seen on the X-ray. So what is anatomic apex is that the point where the neurovascular bundle enters the root apex. So that is what is the difference between the radiographic and anatomic apex. So mainly the average distance between the anatomic apex and the major foramen opening in those teeth will be approximately like 0.59 mm. So coming to the picture here, the maxillary first molar, it has have type like 1, 2, 3. So the type 0, it has the floor is located above the root tip, where in type 1 the root apex touches the sinus floor, whereas in type 2 the floor is interposed between the roots, and in type 3 the apical protrusion is observed over the floor. It's like it is coming between the roots. And what are the signs of maxillary first molar is that it will be like above or behind the floor, or it will be intruding the sinus, or it is touching the tip of the sinus floor. So what is the discussion is that first angulation between the apex and the exist is like from when you angulate from 0, it is the percentage of 66%, and distance is 0, and here I've given the tabular column of the values. So this indicates the percentage distribution, like angles between the radiographic apex and the exist, and here is the distance and between the apex and the exist. And the last one simplifies the floor and the radiographic apex. So what is the result is that the radiographic apex and the apical exit does not coincide in large number of samples. So the palatal root of the maxillary first molar was found to be in direct contact with the floor of the maxillary sinus in maximum number of samples. So that is what in the numerical value I have given here. So what I'm concluding is that the apical foramina does not always coincide with the radiographic apex. And it is in direct contact with the floor in like 75% of cases. So the distance between the radiographic apex and the foramina ranges from like 0 to 1.43. So what I'm concluding is that the CBCT gives a three-dimensional representation in three different spatial planes, and it helps to achieve the accurate results in gaining knowledge about the anatomy of the root and canals, as well other anatomical structures to the proximity of the overlying maxillary sinus floor. Thank you, ma'am.
Done with your presentation?
Yeah, ma'am. That's all.
Okay, just give me a moment, please.
Yeah, ma'am.
Yeah, that was a good presentation. And regarding to your poster, can you say about the prevalence of this distal root?
Distal root, like it will be like close approximating to the floor only, so maxillary sinus floor.
You are saying that the percentage of distribution parameters based on CBCT. How many patient records were taken into consideration for this analysis?
sir, like 118 related, sir. Well-developed maxillary molars only were selected, sir.
Yeah, how many sample?
Like 100, I think so.
It's a research article, or you did the study?
No, sir, research article.
Okay. You didn't do the study.
No, sir, no, sir. It's a research article.
Okay, doctor. Thank you.
Yes, sir. Thank you, sir.
Thank you, Ms. Saji. So our next
Thank you.
presentation. Okay. So our next presentation is poster presentation by Dr. B. Radhika on a topic of association between sublingual candida colonization and chronic periodontitis severity in type 2 diabetes and non-diabetic patients. Dr. Radhika, are we having you?
Yes, ma'am, I'm sharing my screen.
Okay, thank you.
So whether I'm audible?
You are audible, doctor.
Okay, sir. Thank you, sir. So good afternoon. I'm Dr. Radhika, Senior Lecturer at Chettinad Dental College and Research Institute from the Department of Periodontics. Today I'm going to present my poster on the topic Association between Subgingival Candida Colonization in Chronic Periodontitis Patient in Diabetic and Non-Diabetic Patient, a case control study. As we all know, periodontitis is an infectious disease caused by the interaction between the microorganisms, their products, and the exacerbated host immune response, resulting in irreversible destruction of the tooth supporting tissues. Changes in the cellular and humoral response may allow different species such as Candida species and various viruses to colonize the subgingival environment. The development of diabetes, a metabolic disease, can impair the function of polymorphonuclear leukocytes, predisposing patient to a greater risk of developing opportunistic diseases and susceptibility of periodontitis too. So moving on, now we will focus how diabetes mellitus is interlinked with both periodontitis as well as Candida infection. So as we all know, diabetes mellitus and periodontitis share a two-way relationship. As we all know, diabetes mellitus is an unequivocally major risk factor for periodontitis, and the risk of periodontitis is increased threefold in diabetic patient compared to non-diabetic patient. So, exacerbated and dysregulated inflammatory response is the key factor for the two-way relationship between diabetes and periodontitis. So, the various pathway for the two-way relationship between diabetes mellitus and periodontitis are impair apoptosis, impair PMNS function, impair age-range interaction, and alter upregulated of cytokines and upregulated activity of adipokines. So these are the various mechanisms through which there is a bidirectional linkage between diabetes and periodontitis. Now moving on to the linkage between diabetes mellitus and Candida. So various mechanisms are attributed for the predisposition of Candida in diabetes mellitus, such as increased glucose salivary activity, decreased glucose flow, impair candidicidal activity of PMNS, and degeneration, microvascular degeneration, and Candida has its own adhesion property to adhere to the oral epithelium. So these are the various mechanisms through which the diabetes mellitus is interlinked with Candida. So all these factors influence the balance between host and yeast that favors the transition of normal commensal Candida into a pathogen Candida and causing Candida infections. So moving on to aim of my study to analyze the association between subgingival Candida colonization in chronic periodontitis with diabetic and non-diabetic case control study. So, so in methodology, after the clearance from the Institute Human Ethical Committee, this case control study comprised of 500 participants, and they were divided into 3 groups. Group 1 consists of 100 healthy participants with only alone gingivitis. Group 2 comprised 200 participants with stage 2 periodontitis. They were further subdivided into 2 groups, 2A and 2B. 2A comprised 100 participants with stage 2 periodontitis without diabetes, and 2B is 100 participants with stage 2 periodontitis with diabetes. Group 3 comprised 200 participants with stage 3 periodontitis. Again, they were subdivided into 2 groups. 3A and 3B. 3A comprise 100 participants with stage 3 periodontitis without diabetes, and 3B comprise of 100 participants with stage 3 periodontitis with diabetes. So after once the getting approval from the patient concerned, the subgingival plaque were collected from the periodontal pocket, and they were cultured in the subudar dextrose agar for the growth of Candida. So once the positive samples were further analyzed for further Candida's positivity, such as direct microscopy or through germ tube test or through agar chrome culturing or carbureted fermentation test and carbureted assimilation test. These are the various tests which show positivity for the growth of Candida. So the statistical analysis utilizing SPS 21, employing ANOVA and chi-square tests among the to detect the various parameters among the group. So the test results shows among the various species of Candida albicans frequency is high in this study, and the Candida species is more prevalent in the diabetic patient compared to non-diabetic patient, and the Candida albicans prevalence is high in stage 3 periodontitis patient compared to stage 2 periodontitis and normal gingivitis patients. So to conclude, the influence of diabetes and periodontitis can affect the severity of Candida and increase the prevalence rate of Candida. So further research should be undertaken to establish the exact pathogenic mechanism of fungus in periodontal disease, and also confirm the result using long-term follow by evaluating the effect of periodontal treatment on this opportunistic fungus. I acknowledge the Department of Periodontics for all their support and guidance. Thank you.
Thank you for your presentation. Just give us a moment.
Pardon, ma'am?
Just give us a moment, please.
Okay, ma'am. Okay, ma'am.
Okay. I would like to invite Dr. Vaishnavi, Reader and Head, IC Public Health Dentistry, Tagore Dental College, India. Ma'am, are you there?
Okay. Am I audible?
Yes, ma'am. Do you have any questions for the participant, ma'am?
No.
Okay, thank you, ma'am. Thank you, Dr. Radhika.
Thank you, ma'am.
Thank you. So our next presentation is a poster presentation by Dr. Hemavarshini on a topic of the elusive smile, art in darkness. Dr. Hemavarshini. Dr. Hemavarshini, are we having you?
Can you hear me, ma'am?
Yes, please.
Yeah. Ma'am, is it visible?
Yes, your poster is visible. Kindly be a bit loud.
Okay. Can you hear me now, ma'am? Is it fine now?
Yes, yes.
Yeah. Good morning, all. Today we are going to see on a case report which is called Elusive Smile, Smile in Darkness. And now, what is elusive? Elusive is nothing but which appear and it suddenly disappear. In olden days, elusive smile, which is compared with the Mona Lisa smile, from which the golden proportion came into play. Now, how we correlate this elusive smile with this report is, The patient, who was 32 years old, he just came into our clinic with a chief complaint of generalized spacing in his maxillary anterior teeth, and he just wanted to fix his tooth with a minimal invasive thing. He doesn't want to grind as much as the thing which we always do, but he doesn't want to do any invasive procedure. He just wanted to do in a very minimal thing. So we thought he will go with an Emax veneer in 6 to 6. So we thought of doing Emax veneer, which which made up of a lithium disilicate, which is very much technique sensitive. So first we started with a pre-op photographs of centric, of lateral, and also MIP, and we took the photograph of every aspect of the patient: pre-op smile, lateral, lateral, left lateral, and area of concern, and we just put it into the software called DTP 3D for a digital smile designing, and we found we need to do some zenith correction following on the tooth of 1, 2, and 1, 3. So we first forwarded with the pink aesthetic part. You can see in the poster. So we just did the zenith laser correction of 1, 2, and 1, 3. Later we followed up the patient on the same appointment. So we just moved forward with the white aesthetic management, and there we did a depth cut of 303 bar, and also we did a labial preparation, which is a very minimal invasive thing. Labial preparation, not even 0.3 mm was reduced, and we just did a incisive back preparation. And for this patient, we were little concerned because it was seen to be little deep-eyed, so we didn't cut that much. We just did a overlap preparation on the canine, and central and lateral we were carried out with just bud preparation, and later on we just packed the cart and we just did a digital scanning, and we did the proton. And proton, before the proton, we just given after taking the impression, before patient just came by and we just did a diagnostic impression, and we just gave for a mock-up. With that mock-up, we just given the proton. Then after that, we just forwarded with the smile designing. For smile designing, in this DTS 3D Pro app, we will have the already pre-recognized golden proportion of all 6 tooth which we are going to manage. So we in the smile designing part, you can see the DTS Pro imaging, which we have already did the smile designing part. And for this thing, we doesn't need to align incisively or buccally. The app even does all the part. So after they are doing all such thing, we just call the patient for cementation procedure. First, there is for veneer, we have a different cementation procedure for the, we have to treat the tooth and also the veneer part. So surface treatment of the tooth is carried out. First, we have to, we just thought of doing split dam for this patient as we were continuing. We just found it's fine when we do with the blinkers, and so we did a blinkers isolation. Then we did we just did so surface treatment of tooth is carried out. For this, we have etched the tooth with orthophosphoric acid. Then we left for 30 seconds. Then we washed. Then we did the adhesive technique. The 4th generation adhesive technique was followed out. Simultaneously, the surface treatment of veneer is carried out, and we kept the veneer on the veneer box of all 6 tooth. Then we did hydrofluoric acid etching. Then same, we just washed off. Then we did a silane coupling agent, and we bonded the veneer with the silane coupling agent. And here we are not going to cure the veneer. I mean, we are not going to cure either on the tooth or the veneer. We are not going to cure the bonding agent. Then we started with so everything was done. Then we did the cementation. Well, the cementation, we just used the blue phase light cure for curing. And we did the curing from the lingual side, because when we do it from the buccal side, most of the cement will get stagnant on the labial side, and the cementation won't be that greater, and the bonding failure is more common when we do that.
Any questions
the
for
net is gone.
Dr. Hema, you're done with your presentation?
Sorry, ma'am. So they will type my question. So I concluded by saying, veneer, as we go for a veneer smile designing procedure, it will be more technique sensitive, and the bonding failure will be seen in the most consecutive days. Like if it is a failure, we will be seen in the next 2 days, and we can see the failure in the next 2 days only. If you see, the most failure comes with the bonding procedure, and it's very technique sensitive. So we have to make sure at least 60% of the tooth or the enamel is left behind, so that the bonding is taken care very good. But when we destroy the tooth and we concluded if there is no 60% of enamel left behind, when it is not a good idea, it's going to fail. So don't go for a thing. So I concluded by saying minimal invasive dentistry. We are going back to the minimal invasive dentistry with aggressive cut to no cut. So I concluded by saying Emax veneer is a very good material for a smile designing, but the only thing is we have to make sure at least 60% of the enamel is left behind for the bonding. Thank you.
What about the cost effectiveness, doctor?
Ma'am, sorry, could not hear you.
What about the cost effectiveness of Emax veneer?
Yeah, it is more, yeah, it is much, but what I say is when you go for an Emax thing, it is more costlier. Yeah, that is true. But when you go for a normal Fitzpatrick, there is saying like you can go for a Fitzpatrick or an Emax, but I say Emax is more cost effective when you compare to Fitzpatrick. If you take on smile designing as an option, Emax is the only good option. And breakage is also not as a complaint from the patient when you compared with the Fitzpatrick.
Okay, thank you.
Yeah.
Thank you, Dr. Hema. So our next presentation is oral presentation by Mr. Sri Krishna Prasad on a topic of evaluation of healing morphology of fractured condyle after closed reduction and its association with functional impairments. Dr. Sri Krishna, are we having you? I guess we are not having the participant, ma'am. We will be moving to our next presentation. So our next presentation is poster presentation by Dr. Prakash B on a topic of hollow ocular prosthesis of rhinocerebellar leukocytosis post COVID-19 rehabilitation. Dr. Prakash.
Yes, ma'am. Ma'am, can you hear me?
Yes. Kindly share your screen and start presenting.
Yes, ma'am. My poster is visible? Hello, ma'am.
Not actually.
Wait a second.
You open the Zoom app. Kindly open the post.
No, ma'am.
Yeah, now it's visible.
Is it visible, ma'am?
Yes,
Yeah,
yes,
okay.
it's visible.
So good morning. Yeah, good afternoon, everyone. So I'm going to present one of my case report, hollow-ocular processes for rhinocerebral mucormycosis. So mucormycosis itself is a rare opportunistic fungal infection before COVID-19. So after COVID-19 is more prevalent among patients.
Actually, your poster is not clear.
In this, rhinocerebral mucormycosis is a rare kind. Okay, ma'am. Is it visible, ma'am? Hello, ma'am. Hello, ma'am.
Yeah, present, but it's not clear. But anyway, you can proceed.
Okay. Okay. So, rhinocerebral mucormycosis is a kind. So, it is because of immune modulation steroids, blood supply antibiotic, and pneumonia, and because of pre-systematic infections conditions such as diabetes. So, this kind of rhinocerebral mucormycosis originates from sinusoidal mucosa. It disseminated into orbit and into brain. So, the most common invasion from ethmoidal sinuses through lamina papyrus is a common. So the most common the causes is vascular thrombosis and tissue necrosis.
Oh, I guess there is a connectivity issue, ma'am. Shall we take the next presentation?
Yeah, sure.
So our next, just give me. I guess Dr. Prakash is joining again. Shall we wait, ma'am, or shall we take the next presentation?
We'll wait, no problem.
Okay, ma'am. Thank you. I guess there is a connectivity issue from his side. So we'll go for the next presentation, ma'am. Once he joins, we can take that presentation. So our next presentation is first presentation by Dr. Syed Altaf on a topic of impact of oral health on the oral health related quality of life among individuals with intellectual disabilities in Chennai. Dr. Syed
Yes, I'm
Altaf?
audible.
Yes, yeah.
The screen is visible. Hello, is the screen is visible?
You can't see it fully, like only partially.
afternoon. Is the screen is visible?
And now it's visible.
Good morning to one and all. A happy smile is a healthy smile, which is a sign of an healthy person. Is happy smile available for all the people around the world? The answer is no. Because of the poor health, oral health, most of the people are not getting happy smile, which is remarkably affecting dignity, self-esteem, and quality of life. The condition is worse in case of people with disabilities, either be physical or intellectual disabilities. Several studies have shown that people with intellectual disabilities experience poor health in general and their oral health needs in much related to underlying congenital or developmental anomalies, as well as inability to receive adequate personal and professional care to maintain oral health. Oral health related quality of life is relatively new but but growing phenomena which have emerged over the past 2 decades. Considering oral health related quality of life can differentiate need and help prioritize care of vulnerable population like individuals with special needs. The measurement of oral health quality of life must be from individual perception or the child and the individual with special needs. It can be shown from their guardians or caretakers' perception. Extensive literature search suggests that the small scale evidence regarding assessment of oral health related quality of life among intellectual disabled people which are impact in their own condition and their lifeline in India. In this study, the parental caregivers perception questionnaires is an instrument to assess parents and caretakers perception regarding the impact of children oral health status on quality of life. Parents and caretakers are often the main decision makers regarding a child's health and their perception over the major influence of treatment. Materials and methods. It was a cross-sectional school-based field study, which is conducted over a period of 2 months. Convenience sampling method is used to select the population in the age group of 12 to 15, and the estimated sample size is 122. All the included population classified mild, moderate, severe, profound. People with the single or multiple disabilities. Let's move on to the result. Parental caregivers perception questionnaires, the highest mean is recorded with the oral symptoms, which is bad breath, with 2.98, and the lowest mean is recorded emotional well-being, shy or embarrassed. Whereas in the family impact scale evaluates the impact of a child's oral condition on the family life. The bleeding is assessed by probing gently around the walls of the soft tissue in the gingival sulcus. The scores of the 4 areas of the tooth can be submerged and divided by 4 to given the gingival index for the tooth. The gingival index of the individual can be obtained by adding the values of each tooth and dividing by the number of tooth examined. The gingival index may be scored by all the surface of the selected tooth or for the selected area of all or selected teeth. The gingival index may be used for the assessment of prevalence and severity of the gingivitis in population groups and individuals. Moving on to the family index scale, the highest mean recorded are parental activities. That is, children require more attention from parents, whereas the lowest mean were family conflict, child condition caused to disagreement or conflict in family. Then moving on to the graph, which the mean modified gingival index, where the mild, moderate, severe, profound are found, whereas the mild with mean value of 0.82 followed by the severe 0.65 and followed by profound 0.73. On discussion, the finding of present study showed there exists positive correlation of oral symptoms and social well-being with the dentition status, oral hygiene index status, and gingival index, with the stronger association was noted between the oral systems with oral hygiene index simplex. The present study shows that there were a significant contribution of the oral health on oral health related qualities of life with the regards of parental caregivers questionnaires. Highest mean was recorded on the bad breath, had a hard time paying attention in the school, and having anxiety and fearful of the lowest mean was recorded to be the acting shy or embarrassed. With regard of the family index scale, most of the caregivers have reported that the child needs to more attention from their parents, which might be because of the nature of disability and ensure feeling among themselves. Let me conclude this. Dental checkups on regular basis are mandatory to achieve as well as also maintain the appropriate standard of oral health. Among patients with disabilities, oral health problems may occur due to the poor oral hygiene, which might lead to dental caries and gingivitis. Further research is needed to identify the barriers in providing prevention and curative services for the better of the oral health among the people with intellectual disabilities, which might be helpful in developing effective education or training modules for dental health professionals, which helps in improving their oral health. Thank you.
Have you faced any difficulties while conducting the study?
Ma'am?
Have
Hello?
you faced, yeah, am I audible?
Yes, ma'am.
Have you faced any difficulties while conducting the study?
Yes, ma'am.
What all difficulties you faced?
Ma'am, it is conducted on the based on their children at the age group of 12 to 15.
Okay. Okay, we'll go to the next presentation. Thank you.
Thank you. Thank you, Dr. Sayed. Ma'am, can we take the previous presenter, ma'am, or shall we move to the next?
If he is ready, okay, no problem.
Okay. Dr. Prakash? Okay, ma'am, there was another participant before that. Dr. Sri Krishna Prasad.
Yes, ma'am, I'm available, ma'am. Allow me to share my slides.
Yes, please, you can share it now.
1 minute, ma'am.
Yes, please. Are you facing any difficulties, Dr. Prasad?
1 minute, ma'am. 1 minute. Just one. Hello.
Yes, Dr. Krishna.
Ma'am, some technical issue. You proceed with next presentation. I will come back.
Okay, thank you.
Thank you.
So our next presentation is oral presentation by Madhura on a topic of assessment of angiogenic potential of mesenchymal stem cells derived conditioned medium from various oral sources. Dr. Madhura. Dr. Madhura Shekatkar, are we having you? Dr. Madhura Shekatkar, are we having you? Final call for Dr. Madhura. Okay, ma'am. I guess we are having the issue with the participant. So our next presentation is a poster presentation by Dr. Hinduja Magendran on a topic of lesion sterilization and tissue repair. Dr. Hinduja.
Yes, ma'am.
Yes, kindly share your screen and start your presentation.
Is my screen visible, ma'am?
Yes, it's visible.
Oh. Good afternoon, all. I'm here to speak on the topic rescue tooth with lesion sterilization and tissue repair. Lesion sterilization and tissue repair is an endodontic treatment procedure which involves non-instrumentation or minimal instrumentation followed by placement of antibiotic mixture in a propylene glycol vehicle to disinfect the root canal system and periapical lesions. The Cardiology Research Unit of Niigata University School of Dentistry has developed LSTR therapy by Hoshino in 1990 and was popularized by Takushige. So when a deciduous tooth is affected by dental caries, pulp tissues with subsequent periradicular pathologies, it makes the conventional endodontic procedures a dilemma. And it may lead to premature loss of primary teeth, which can cause ectopic eruption, alterations in eruption sequences, space loss, development of deleterious habits, functional and speech impairments. So the main theory behind LSTR is repair of damaged tissues might occur if lesions are disinfected. So this technique is also referred to as non-instrumentation endodontic treatments. So we use a triple antibiotic paste in the procedure. So how this triple antibiotic paste is prepared is according to Ashino et al. In 1990, he used a combination of metronidazole 500 grams, ciprofloxacin 200 grams, minocycline 100 grams in 1:1:1 ratio. And Takushi et al. Modified this composition with the same medications in 1:3:3 ratio. So this has maximum effect when the powder is to solvent ratio is 7:1. So this is used in revitalization regeneration procedures. The outer layer of the tablet is removed and the tablets are powdered in a clean mortar and pestle. So the wetting of powder is avoided. The powder is stored in a tight container and in dark place to avoid moisture contamination and exposure to light. So the action of metronidazole is it acts against the gram-positive and gram-negative anaerobes. Ciprofloxacin acts by inhibition of DNA guidase and facilitates destruction of gram-negative organisms. Minocycline acts by inhibiting protein synthesis, collagenases, and matrix metalloproteins. So this is the procedure. So what we do is we give LA to the patient and rubber dam isolation is done. Access cavity is prepared with the help of round burr and the necrotic tissues are removed. Irrigation is done with saline and sodium hypochlorite. Sodium hypochlorite helps to control hemorrhage. So walls of the access cavity is cleaned by EDTA, that is the ethylene diamine tetraacetic acid, which allows deeper penetration of antibiotics. 2 mm deep and 1 mm wide medication cavity is prepared in the canal orifice, and the triple antibiotic paste is placed. So after proper drying of the access cavity, medication is placed. The permanent restoration is given with GIC, and the stainless steel crown is placed over the teeth after tooth preparation. And the advantages of this procedure, it is easy, simple, and painless technique. So there is no instrumentation needed other than access cavity preparation. There is no irritation of periapical tissues. Obturation is not needed, and the use of formocrosol is not needed. Bone regeneration occurs in this procedure. The main disadvantage faced in this technique is the minocycline causes discoloration of the tooth. So this is modified by using clindamycin. And the other disadvantage is radiolucency in radiograph. So this triple antibiotic paste is radiolucent in radiograph. So we add iodoform with the triple antibiotic paste to make it radio opaque. And in this primary teeth, we are unable to build post and cores. So this is another disadvantage. So this is how the teeth will look after lesion sterilization and tissue repair. The yellow color, which is marked as 3, is the antibiotic paste, and the place where it is marked 2 is GIC restoration, and above that is a superficial restoration, which is given. It can also be covered with a stainless steel crown. So this is a small study which shows tooth discoloration when we have minocycline with triple antibiotic base. Then it was modified with amoxiclav, which also showed some amount of discoloration. And when we used clindamycin, there was no or minimal discoloration. And now this modified paste has clindamycin. So a comparative study of discoloration of teeth was studied, and clindamycin shows minimal discoloration. So where all this technique is indicated is where all the teeth are indicated, the teeth which are indicated for pulpectomy can be modified with lesion sterilization and tissue repair. Any non-vital teeth, any advanced root restorations, root resorptions, severe bone loss and mobility cases, presence of abscess in the primary teeth, presence of any sinus tract, or presence of any radiolucency in furcation areas are all indications for this procedure. And when it is contraindicated is children with allergy to the medications which we use, any radiographic examination of excess internal or external resorption in the primary teeth, children with infective endocarditis, cases with perforated pulpar floors, and if the primary teeth is about for exfoliation, then this teeth is not indicated for this procedure. So newer combination of drugs are under study, like use of triple antibiotic paste with normal saline, or triple antibiotic paste with 2% chlorhexidine, or just minocycline with normal saline, or metronidazole with normal saline, ciprofloxacin with normal saline, calcium hydroxide with normal saline, or calcium hydroxide with 2% chlorhexidine. So according to a study in 2020, triple antibiotic paste was minimal toxic to dental pulp stem cells as compared to calcium hydroxide. And I conclude this speech by saying lesion sterilization and tissue repair is an alternative that eliminates the causative microorganisms from the lesion by sterilizing and helping the repair with the aid of individual's own natural immune system. And this procedure makes a natural space maintainer which guides the eruption of succedaneous permanent teeth in primary dentition. Thank you.
No questions from my side.
Okay, ma'am.
Shall we move on to the next presentation?
Yes, yes.
Okay. So the
Okay,
next
thank you, ma'am.
presenter will be Dr. Kirti Vasan and Dr. Aarti on the topic solving the challenges of compromised bone volume with Kohari bone plate technique in the aesthetic zone. Over to the presenter.
Good afternoon, ma'am.
Sir, you're audible, you can present.
So my topic of presentation is solving the challenge of compromised bone volume with Cowrey's bone plate technique in a aesthetic zone, the case report. So as we all know, tooth loss is accompanied by a series of adaptive changes leading to dimensional alterations in the alveolar process. Within 1 year after extraction, there will be 5 to 7 mm of buccopalatal bone reduction and 2.5 to 4 mm of vertical reduction in the maxilla and mandible, of which 30% of reduction takes place in 3 months. So the vertical reduction of bone is depends on the phenotype of the buccal wall. The thicker wall shows lesser resorption. If the peri-implant bone, if the bone covering the implant is less than 1 mm, then there will be faster resorption, which means 3.5 times more resorption will be occurring when compared to that of the thicker wall. So factors affecting the bone loss includes improper management of Avell's teeth, traumatic extraction procedures in the anterior region, systemic illness like diabetes, prolonged edentullism, and use of removal prosthesis without relining. All these will result in the labial cortical plate loss, which result in the horizontal defect. So this buccopalatal bone reduction of volume will result in the horizontal defect in the aesthetic zone, which pose challenge in implant industry to achieve an FP1 type of prosthesis, which is an aesthetic prosthesis. So bone augmentation is justified in 4 circumstances. 1, when an implant cannot be placed in ideal position, when the peri-implant buccal bone wall was less than 1.5 mm is expected, when the primary stability of implant is questionable, when the implant is placed in the anterior aesthetic zone. So the biomaterials used for augmentation includes autografts, allografts, xenografts, alloplast, and growth factors infused grafts. So compared to all other grafts, the autografts are considered gold standard because of its osteoconductivity, osteoinductivity, and osteogenic potential. Rest all other grafts regenerates by means of osteoconductive potential. Only exception is demineralized freeze-dried bone graft, which regenerates by means of osteoinductive potential. So the autografts are considered gold standard because of its faster incorporation due to early vascularization and functional remodeling. So this resorption of autografts releases growth factors that supports the graft consolidation. So the advantages are faster osteointegration. The graft rejection incidence is very minimal, and the disadvantage includes donor site morbidity, limited volume availability, and more resorption rate. So the intraoral sites for bone augmentation includes bone harvesting includes the symphysis, ramus, and tuberosity, of which the symphysis shows minimal complication rate compared to that of the ramus and tuberosity. So the surgical techniques for horizontal ridge augmentation includes bone block grafts, ridge splitting, and GBR. Although GBR shows more mean implant survival rate, the complication rate of GBR is more compared to that of the bone block grafts. So this flowchart shows the treatment plan for sufficient and insufficient bone volume. If an horizontal class 4 defect is present, then the common protocol which has to be followed is placing an autograft followed by particulate graft, and it is secured with a resorbable GTR membrane. So coming to Cowrey's technique, this is the modified technique which is introduced by Feud Cowrey in 2007, and this involves harvesting the corticocancellous bone graft. This involves harvesting the corticocancellous bone graft from the respective side, and the cortical part is separated by means of bone disc, and the cancellous part is mixed with other grafts. This cortical part is screwed with the micro screws onto the recipient side, and the generated gap is filled with the cancellous bone grafts mixed with the other grafts in the ratio of 1:1. And the donor side has to be properly managed. Otherwise, it will result in the prolonged defect. So this method is a very predictable method for three-dimensional reconstruction of maxilla and mandible. So in this case report, compromised bone volume and horizontal defect has been a challenge. So coming to case report, a 59-year-old patient, male patient with a chief complaint of missing tooth in the left upper jaw front tooth region for past 2 years, and he wants replacement of fixed type solution for the same. So regarding medical history, no relevant medical history was evident. So patient had an history of trauma and avulsion due to road traffic accident 2 years before in the upper jaw front tooth region. The coming to intraoral examination, the missing tooth in relation to 2-1 and 2-2. The 2-1 was supra-erupted, and it is 2 mm below the occlusal plane, and it has labioversion, and generalized attrition is evident. Increased overbite, reverse curvature of the lower incisal plane, lip line and smile line was low, and the edentulous span length was 18 mm and restorative space height was 9 mm. So coming to blood profile, all these values were nominal. So coming to CBCT tracing, we can very well appreciate the horizontal bone defect in the mid-level region, and this implies placing a 3.3 mm implant itself will result in the thread exposure in the mid-level region. So the treatment plan suggested to the patient was Cowrey's bone plate technique in the 2-1 and 2-2 region, which is followed by staged implant placement in 2-1 and 2-2 after 3 months of bone augmentation. So pre-op CBCT, patient is advised to take mandibular CBCT for assessment of sufficient bone volume in the chin area, and it also gives an idea of how much amount of bone is present for safe bone graft harvesting. So patient preparation, patient was advised to take amoxicillin 500 milligrams and corticosteroids 8 milligrams 1 hour prior to surgery as a part of antibiotic prophylaxis, and patient is advised to take antibiotics for after the procedure for 7 to 10 days. As a part of pain control protocol, Zerodol was advised for post-operative pain management. So these are the armamentarium. So coming to procedure, local regional anesthesia was given with the 2% lignocaine, and in this case, bilateral mental nerve blocks was given, and buccal and lingual infiltrations were given. Vestibular incision is carried out with which is to be 0.5 mm from the mucogingival junction, and after the a full thickness mucoperiostral flap is elevated. After the flap elevation, the extent of the graft has to be marked with a carbon marker. With the use of 701 burr, we have to make perforations along the entire length of the graft, so that which facilitates ease for removal. And these markings are connected with the use of saw drill. So the guidelines are the superior osteotomy cut should be 5 mm below the root apices, and the inferior osteotomy cut should be 3 mm to 5 mm above the inferior border of mandible. These horizontal incisions are connected by the vertical incisions. So in this case, 2 graft sections were harvested from the left and right parasymphysis region, leaving the mid symphysis intact. So that after the bone graft harvesting, the donor site management is very, very mandatory, and it is closed with bone graft, and the collagen membrane is used for graft consolidation. So coming to the recipient side, the corticocancellous bone graft is sectioned with a diamond disc, and the cortical part is screwed to the recipient side with the use of 1.5 mm 1.5 cross 13 mm screws. This cancellous bone graft is crushed with bone meal, and it is mixed with the other grafts in the ratio of 1:1, and it is and these cancellous bone grafts are used to cover the generated gap, after which a collagen membrane is placed over it. And coming to sutures, in the mandible, two-layer closure is done with the use of 30 vicryl and 40 ethylene. The maxilla, simple interrupted suture is placed. So 3 months after augmentation, the fixation screws are removed, and this is the post-op CBCT. So we can very well appreciate the the autograft incorporation. So surgical guide is fabricated. With the use of surgical guide, implants are placed. So 3 months after implant placement, open tray implant level final impression is made. The cast is poured, a diagnostic wax up is done, and a putty index is made, and the abutments are connected to the cast. The angulations are corrected. With the use of putty index, a screw retained temporary is given. And after 2 weeks of temporary, we can appreciate the unwanted soft tissue overhanging. So on evaluation, the patient had a low frenal attachment, and the low frenal attachment is had very severe influence on the marginal gingiva. So frenotomy was suggested, and with the use of laser frenotomy is done. After 2 weeks of frenotomy, gingivectomy is done, and after 1 week of gingivectomy, the expected emergence profile was achieved. This is the soft tissue profile which was gained after temporary. So this was replicated by means of indirect method, and the impression posts are customized, and the open tray implant level impression is made. This was the final prosthesis. And in this picture, the reverse curvature of the lower incisal plane is corrected by means of enameloplasty. And since the patient has low lip line and low smile line, the prosthesis suggested was FP2 type of prosthesis. And this is the final emergence profile of the prosthesis. So this is the pre-op and post-op CBCT and clinical pictures. So to be concluded, the donor site management has to be done in a proper manner. Otherwise, there will be permanent defect in the mandible. There are few case reports which show negative feedback because of the increased resorption rate of the autografts. So as an alternative to this, alloplast bone plate can also be tried, but this also shows a similar success rates. So these are my references. Thank you.
What about the success rate reported in other articles, doctor?
Ma'am, can you please, ma'am?
What about the success rate reported by other authors?
Ma'am, success rate is, ma'am, when we use the bone block graft, the success rate is about 95%, ma'am. But the autograft has more resorption rate, ma'am. So since the autograft has more resorption rate, within 3 to 4 months or within 4 to 5 months, the resorption will be more, ma'am. So this was the disadvantage which was mentioned by other authors, ma'am.
Okay, thank you.
Thank you.
And moderator, let me know if the presenter exits the given timing. Yeah, sure.
Okay. So the next presenter will be Sri Krishna Prasad on the topic evaluation of healing morphology of fractured condyle after closed reduction and its association with functional impairments. Over to the presenter.
Yes, ma'am. Allow me to start. Ma'am, it's visible?
Yeah, it's visible. You can
Okay.
present.
I'm
And just
starting
stick
my
on to your time
presentation.
limit. Yes.
Ma'am?
Just stick on to your time limit, sir. Thank
Yeah,
you.
ma'am. Okay. I'm starting with my presentation. It's evaluation of healing morphology of fractured condyle after close reduction and its association with the functional impairment. Myself, Dr. Prashant, Assistant Professor in SRM Dental College. So coming to the need for the study, the treatment of condylar fracture has generated more discussion and controversy in the recent years. There is a criteria known as Zaid and Kent criteria, which is given by them. When the condyle is fractured, if it is displaced to the middle cranial fossa, displaced in medially, or if it is the patient is completely edentulous, in that condition we can go for a fixation of condyle. In remaining condition, we can leave the condyle by heal by itself. When there is a unilateral condyle, we no need to touch the condyle; it will heal by itself. The main objective of the study was to evaluate the healing morphology of fractured condyle fracture fragment and its association with functional impairments such as pain, amount of deviation, amount of mouth opening, and occlusion. Coming to the material and the methodology, It is a prospective study. It was a prospective study conducted in 15 patients. 3D CT scan were taken pre-treatment and 6 months after the post-treatment. Inclusion criteria were the patient who had unilateral condylar fracture in the past 1 week in the age group of 20 to 60 years were included in the study. As exclusion criteria, patient with bronchial asthma, head injury, and epilepsy were not included for study. Methodology: in those patients, we did a close reduction with the intermaxillary fixation and elastic approximately for 21 days and followed the active mode opening exercise. Functional impairment such as pain was assessed using visual analog scale. Amount of deviation by checking midline shift. Amount of mouth opening by measuring the maximum inter-incisal distance. Occlusion by taking pre-treatment and post-treatment photographs were assessed after 1 month, 3rd month, and 6 months respectively. A 3D CT scan was taken before the treatment to assess the fracture site and 6 months after the treatment to assess how it's healed after 6 months. There are 4 patterns were assessed in this. There is a healing without any change in the morphology. As a L-shaped morphology arise and spherical shaped it healed. Detached pattern of healing. The pattern, the healing not happen and it's completely detached from the condylar portion. From what we got the result is out of 15 patients, 8 patients had L-shaped pattern, 2 patients had spherical shaped pattern of healing, 5 patients had unchanged pattern of healing. None of the patient had detached pattern of healing. The patient was assessed using visual analog scale. Patient were asked to score between 0 to 10, where 0 was considered as no pain, 1 to 3 as a mild pain, 4 to 6 as moderate pain, 7 to 10 as a severe pain. Patient was found only after the first month post-treatment in all the 3 types of patient. Amount of jaw deviation was assessed by checking the midline shift. It was found only the patient with L-shaped and spherical shaped healing pattern. 28% of patient with L-shaped and 100% of patient with spherical shaped healing pattern had jaw deviation of 5 mm after 1 month of follow-up. The jaw deviation of both patient with L-shaped and spherical shaped healing pattern was reduced over the period of 3rd month and it was reduced to normal over the period of 6 months. The maximum intrinsic distance of 35 mm and above was considered as normal. All patients with the unchanged healing pattern had normal mouth opening. Patient with L-shaped healing pattern had normal mouth opening, whereas a patient with a spherical shaped healing pattern had minimum mouth opening less than 35 mm and it is subsequently came to normal within 6 months. Occlusion was normal in all the patients of healing except one patient with L-shaped healing pattern who had anterior open bite after 3rd and 6th month post-treatment. So from this, I'm concluding that we no need to open the condylar fracture for all the patients. In the case of unilateral condylar fracture, we can leave it up. No need to correct the patient and giving unnecessary bone to the patient. By doing the IMF and the active physiotherapy to the patient, we can make the patient to provide the functional, address the functional problem also, cosmetic problem also, and normal mouth opening also we can achieve in the normal within 21 days. Thank you.
You mentioned only 15 patients. So
Yes, ma'am.
based
It's
on
a recent study. So we did 15 patients.
have you estimated the sample size or based on your T article, how you took that 15?
Yes, ma'am. We actually went to a statistician and we asked for the stats value also. I mentioned those. We did in 15 patients. Here you can see we assessed in 1st month, 3rd month, and 6th month. Pain, amount of jaw deviation, mouth opening, and occlusion, all we assessed over a period of time and we got significantly positive results.
Okay, doctor.
Okay, thank you so much.
Okay, so thank you. So the next presenter will be Mathura Schechter on the topic assessment of angiogenic potential of mesenchymal stem cells derived from conditioned medium from various oral sources. Over to the presenter.
Thank you, ma'am. I'll be presenting on assessment of angiogenic potential of conditioned media of mesenchymal stem cells derived from different oral tissues. So, angiogenesis or neovascularization is a crucial process in various biological life processes from embryonic development of the fetus in utero, and it continues throughout life in a healthy and disease state. Abnormal angiogenesis can hinder blood vessel proliferation, which is essential for successful endodontic therapies, wound healing, and tissue regeneration post-surgical treatment. There are certain regulatory factors and enzymes like angiopoietins or vascular endothelial growth factor or fibroblast growth factor, etc., which play a role in this pathway of angiogenesis. And each factor has a different story to build during the induction, initiation, amplification of cells, migration, cell stabilization, inflammatory response, and also suppressing the angiogenesis. Currently, the method to enhance angiogenesis is administering angiogenic growth factors, but this method faces drawbacks like leaky vasculature and due to the lack of spatial temporal control over the release of the factors. Stem cell-based therapeutic applications are exploring potential targets for deranged angiogenesis. Mesenchymal stem cells are pluripotent heterogeneous cellular groups that can differentiate into various cell types. They have been isolated from adult oral cavity tissues, including dental pulp, gingiva, periodontal membrane, apical papilla, and buccal fan pad. These stem cells have immunomodulatory and anti-inflammatory properties and are essential for tissue regeneration and healing. They exhibit therapeutic effects through paracrine mechanisms by secreting growth factors and cytokines in the culture medium. This unique property has led to the creation of a novel byproduct, the conditioned medium or secretopes, which are helpful in various therapeutic applications. The secretopes contain secret factors that promote angiogenesis and healing procedures through potent paracrine signaling. Oral tissues derived from ectomesenchymal components and neural crest cells make them ideal candidates for isolation, culture, and application in preclinical studies. So the study compares the angiogenic growth factors in conditioned media, which is derived from the stem cells of different oral sources, and using the cheek yolk sac membrane assay, the best source for the mesenchymal stem cells for augmenting angiogenesis is concluded. So the objectives of the study was to isolate and characterize the MSCs from different oral sources and obtain the conditioned media, to evaluate the presence of growth factors for angiogenesis. Then in vitro analysis of the media was done using the scratch wound healing assay, and in the in ovo yolk sac membrane assay was performed. So this is my methodology. So four sources were taken into consideration, that the DPSCs are dental pulp stem cells, shared as the pulp stem cells from exfoliated deciduous tooth, the gingival stem cells, and the buccal fat stem cells. They were cultured in the medium without the serum at passage 4. They were incubated, and after 48 hours, the conditioned media was obtained. The isolated MSCs from all four sources showed spindle-shaped morphology under the microscope. Then immunophenotypic characteristics were assessed to express a particular cluster of differentiation markers using flow cytometry. The MSCs derived showed net positivity for CD90, CD105, and CD73, and negative results for CD34, 45, and HLA-DR. MSCs derived from all sources were characterized for their stemness through tri-lineage differentiation potential. After staining with alizarin red, the MSCs which differentiated into osteocytes projected bright orange red color with extracellular calcium deposits. Those undifferentiated cells were slightly reddish without the calcium deposits. The MSCs which differentiated into chondrocytes were evidenced by blue color deposition, revealing extracellular matrix proteoglycan staining. To ensure adipogenic differentiation, the intracellular deposition of lipid droplets was examined after oil redo staining. Flow cytometry was used to analyze the 8 angiogenic growth factors to compare expression in each of the 4 oral sources of the MSC's conditioned medium. Culture medium without preconditioning with MSCs was kept in control. Each source was compared with the control group for a relative increase or decrease in the desired growth factor expression. An intra-group comparison was made between the gingival, the shed, the DPSC, and the buccal fat MSCs. Dental pulp stem cells derived conditioned media showed significantly higher expression of FGF and HGF, the fibroblast and the hepatocyte growth factor, than other condition medium groups. The highest expression of the hepatocyte growth factor was found in the condition media derived from the dental, with p-value less than 0.01, followed by the stem cells from exfoliated deciduous tooth, buccal fat, and gingival. Other factors like the VEGF, the transforming growth factor alpha, and the platelet-derived growth factor and angiopoietin were also expressed in significant amounts by the condition media from dental pulp. VEGF and the colony stimulating factor were slightly higher in the shed, and the platelet-derived growth factor and angiopoietin did not show any significant increase in the intra-group comparison. In vitro analysis of angiogenesis was performed using the scratch wound healing assay, which showed that dental pulp condition medium showed maximum decrease in the area pixel, and width compared to the other sources of oral cavity MSC. Followed by the analysis of growth factors in condition medium obtained, we investigated the proangiogenic potential in yolk sac membrane assay. Our results clearly showed that the dental pulp condition media enhances blood vessel formation compared to the gingival, then shed, and the buccal fat. A quantitative assessment of angiogenesis revealed that dental pulp condition media significantly enhanced the total vessel length, vessel network length, the vessel density, and the total segments. Although the gingival, shed, and buccal fat could enhance angiogenesis, the observed proangiogenic effect was higher in the dental pulp condition media. So the study focuses on growth factors essential for angiogenesis, particularly those derived from the oral cavity sources. The MSCs have gained attention in regenerative medicine as potential alternatives to cell-based therapies due to the paracrine signaling capacity. And my study highlights the use of conditioned media, which is a source of cell-less cultured medium with excellent clinical and translational value. The study compares the quantitative expression of levels of different angiogenic growth factors in 4 sources of oral cavity MSCs. There is limited literature on the gingival and the buccal fat condition media, and my study was the first to use the condition media from buccal fat MSCs to see the angiogenic potential. This study focuses on the role of vascular endothelial growth factor, fibroblast growth factor, hepatocyte growth factor, and angiogenesis. The dental pulp condition media is the most crucial source for angiogenic potential with high presence of the factors. Shed condition media, gingival MSCs, and buccal fat also contribute to the angiogenesis, but they lack factor for vessel maturation. A new source of condition media derived from buccal fat showed significant quantities of the vascular endothelial, the HGF, and PDGF, which enhances angiogenesis at the desired site. The study concludes that condition medium derived from the oral cavity mesenchymal stem cell plays a dynamic and influential role in angiogenesis and can be used alone or in combination with other graft materials to achieve the desired angiogenesis process. The use of conditioned media alone or in conjunction with graft material may improve the hard and soft tissue regeneration during wound healing, and the recovery period can be reduced. In cases of implant or prosthesis placement, the conditioned media could play a vital role by ensuring a predictable result. Due to its negligible immune response, it can be used in immunocompromised hosts. Using stem cell conditioned medium might be a viable alternative to stem cell transplantation, which is often hampered by low grafting efficacy and potential tumorigenesis. These are my references. Thank you.
Thank you, doctor. No questions from my side.
Okay, ma'am. Thank you. So, shall we move on to the next presentation, ma'am? Okay, so the next presenter will be Dr. Pavan Ravindra Shinde on the topic, a comparison of stress distribution in mandibular implant supported overdenture with three-dimensional attachment systems of various heights, a three-dimensional finite element analysis. Over to the presenter. Dr. Pawan. So Dr. Pawan is not available, so we'll move on to the other presenter. Dr. Soumya T on the topic computer aided bar computer aided design in pediatric dentistry. Dr. Soumya, can you present?
Yeah. Is my screen visible, ma'am?
Yes, doctor, you can present.
Good afternoon to one and all present here. I'm Soumya, here to present on CAD-CAM in pediatric dentistry. What is CAD-CAM? CAD stands for Computer Aided Design and CAM stands for Computer Aided Manufacturing, both of which are used to make things. CAD-CAM software is used to design and manufacture prototypes and finished products. As we all know, pediatric dentistry is concerned about providing utmost care to the child's oral health. And we are also aware that space maintenance is very important as it aids in proper eruption of succedaneous teeth in place to carry out normal physiologic functions without any development of malocclusion. And it also aids in aesthetics. I'm here to present about CAD-CAM, the usage of CAD-CAM in the manufacturing of zirconia crowns and space maintainers. First, we'll see how the CAD-CAM workflow is. In a clinical setup, intraoral scanners are used to scan the oral cavity. The scanned document is sent to CAD labs, whereas another option is making physical impressions and pouring a cast, and the cast is sent to lab scanner where the cast is scanned. These documents are 3D printed and milled, and the desired product is manufactured. Let's move on to the advantages and disadvantages of CAD-CAM. The advantages are the number of appointments are reduced. There is less chair side time, improved patient compliance and comfort, customization of abutment tooth, and zirconia crown provide acceptable tooth color, and it has good accuracy. The disadvantages are the CAD-CAM setup is very expensive. Digital dentistry requires a large financial investment that not every dentist could afford. And the CAD-CAM setup requires more space to accommodate the equipments, and detailed programs need to be learned. So here I am to present 3 case reports from 2 different articles which use CAD-CAM to provide zirconia crowns to endodontically treated teeth and to fabricate space maintenance. Case report 1. In this case report, it illustrates the fabrication of CAD-CAM crown from a decayed primary molar in an 8-year-old boy. Due to multi-surface restoration needed due to the extensive caries, the treatment plan suggested a crown. But the parents refused stainless steel crowns, and also they requested to avoid extraction due to past negative experience. As per the parents' request, caries were removed and core buildup was done using resin as there was extensive tooth loss. Then the crown preparation for the tooth is done and intraoral scans are made. The editing time of the restoration had a duration of 2 minutes. The milling time took 9 minutes, while the total chairside time was 15 minutes. It was a single visit procedure. And moving on to the case report 2, here a 5-year-old child came with a complaint of pain in right lower back tooth region. On examination, the tooth was grossly decayed. There was no scope of saving the tooth due to poor prognosis. Therefore, extraction was carried out. In this case report, next generation intraoral scanners were used that can even scan in presence of blood and saliva. They have inbuilt AI-driven soft tissues elimination technology. As there was less space available, space maintenance was planned, and in this case, the patient was non-cooperative. So, digital impression was faster and more comfortable. Desired arch impression was made.
within 30 seconds, resulting file transfer to dental laboratory for 3D model printing. 3D printed model was received. Normal protocol was followed to fabricate the cast metal band in loop space maintenance on the cast. After 5 days, the appliance was tried in, placement was confirmed, cementation with resin modified GIC was done. The intraoral photos given here. And then moving on to the case report 3, a 4.5-year-old patient again came with a chief complaint of pain in right upper back tooth region. On examination, grossly decayed maxillary primary second molar was seen. OPG reveals radiolucency in relation to primary maxillary second molar. So looking at the poor prognosis, extraction is planned with placement of village appliance or distal shoe space maintainer. Distal shoe space maintainer helps in prevention of mesial migration of erupting permanent first molar. The treatment was explained to the parents and scanning was done before extraction on first appointment. Recalled to the patient after 5 days, where we already received the space maintainer from the lab. After extraction, immediately distal shoe space maintainer was tried and cemented using GIC. Intra-alveolar projection of the appliance was also placed into the socket. This is the post-operative radiograph. So I hereby conclude saying that CAD-CAM can be used as an alternative option for zirconia crown for primary molars with extensive caries instead of stainless steel crowns, having the advantage of limiting chair side time and customized procedure. And in same manner, conventional space maintainer like band and loop has disadvantages like increased lab time. So it is easy, precise, and acceptable due to elimination of fabrication stages. By using this technology, dental restorations and fabrications are made in a single session. Thank you.
Any questions?
How to overcome those disadvantages?
Ma'am, many researchers are going on to find cheaper materials other than zirconia crowns, ma'am. And ma'am, am I audible?
Yeah, you're audible. So you have given the answer, right?
Yes, ma'am.
Anything you want to add on?
No, thank you, doctor. We'll go to the next.
No.
So the next presenter will be Swarna Malika on the topic perception of dental practitioners towards oral health education apps, a cross-sectional survey in Chennai. Dr. Swarna Malika, you can share the screen.
Yeah, okay. Am I audible?
Yes, you are.
Yeah, okay. A very good afternoon to one and all present here. I am here today to present the findings from the research study titled Perception of Dental Practitioners Towards Oral Health Education Applications, a cross-sectional survey. In recent years, technological advancements have revolutionized various aspects of healthcare delivery, including oral health promotion. With proliferation of mobile applications, the potential of patient-focused oral health applications to augment traditional dental care practice has become increasingly apparent. Today, I am excited to share with you the insights garnered from the study, which help to understand the perceptions of dental practitioners towards oral health applications. Moving on to the introduction, oral health education helps people learn more about how to take care of their teeth and gums, which can prevent common oral health issues like cavities and gum disease. Technology, especially mobile devices, has become important for teaching and learning. We are using our phones and tablets not just for everyday stuff, but also for work and school. Using apps on our phones or tablets gives us easy access to lots of helpful information right when we need it. These mobile health apps can help us take better care of ourselves, stay healthy, and find useful tips for living well. So the purpose of this cross-sectional questionnaire study was to objectively investigate dental practitioners' perception on usage of oral health education apps to educate their patients. The results of the study will be helpful in providing an insight to effectively use various oral health education apps on oral health education aids. So the aim of the study is to assess the perception on oral health education apps among the dental practitioners. The objectives of the study are to assess the correlation between clinical experience and perception on oral health education apps among the dental practitioners, and to assess the correlation between the affiliation to dental college and perception on oral health education among the dental practitioners. The need of the study is that it investigates about the dental practitioners' views on patient-centered oral health apps, exploring their potential as innovative solutions in dental care. Understanding practitioners' perceptions can inform the development of effective, user-friendly apps for improving oral health outcomes and patient engagement, advancing dental care practices. Moving on to the materials and methods. This is an online cross-sectional questionnaire survey designed using the snowball sampling technique. A link was sent to the participants, including a brief introduction on the background, the objectives of the study, voluntary nature of participation, declarations of confidentiality, and instructions for filling in the questionnaire. Time given to fill the questionnaire was 2 weeks. The questionnaire of the survey was developed by the authors after reviewing the relevant published literature and the most recent available information on oral health education apps available in smartphones. The questionnaire was validated with Cronbach's alpha coefficient value of 0.84. So this questionnaire comprises of two components numbered as part 1 and part 2. The first part of the questionnaire comprises questions designed to collect the information related to demographic parameters of the study group, such as gender, clinical experience, whether affiliated to any institution. And the part 2 comprises questions pertaining to dental practitioners' perceptions related to dental apps usage and any threats related to it. A 5-point Likert scale was being used for scoring purpose for each question in the questionnaire demographic detail. So the estimated sample size was 388 using G-power analysis, and all the dentists working in private clinics, medical centers, or hospitals with or without affiliation to dental colleges and willing to participate in the survey were included, and the excluded participants were who did not respond to the questionnaire form till 2 weeks and who are affiliated only to the dental institutions and are not practicing. Then dental students who are pursuing their studies, participants who are not using smartphones. These are the persons who are excluded from the study. So for statistical analysis, chi-square test was used and Pearson correlation was performed to assess the correlation, and the level of statistical significance of all tests was p-value less than 0.05. So this slide represents the visually compelling infographic which depict the distribution of subjects among various categorical data related to this study to provide a clear view of the demographic characteristics of the participants, such as age, gender, designation, clinical experience, and affiliation with the dental college. Out of 388 participants, gender in percentage denotes that 60.8% were female and 39.2% of them were male. And the age in years, this bar infographic represents that 47.4% of the participants were came under the age group of 31 to 40 years, followed by 33.8% of people were under the age group greater than 40 years, and 18.8% of people came under the age group 20 to 30 years. So coming on to the clinical experience, 54.9% of the participants were having clinical experience between 1 to 5 years, followed by 43.5% people were having clinical experience greater than 5 years, and 1.6% is less than 1 year of clinical experience. So moving on to the designation, 57.7% of the participants were MDS graduated, followed by 42.3% were BDS graduated, and 67.5% of the participants were working in clinics as well as have the affiliation with dental colleges, and 32.5% were only working in the clinics and not affiliated with the dental college. So this slide also includes the bar infographics representing key data related to the questions about sufficient knowledge about the oral health education apps that are available for mobile phones. So this bar infographic represents that 84% of the participants were strongly disagreeing about the knowledge they have about the oral health certification apps that are available for mobile phones. This slide shows the tabulated data showing the level of statistical significance and correlation between the responses and participants' clinical experience and affiliation with dental college. This helps in understanding how these factors may influence perception and attitude towards oral health applications. Question on sufficient knowledge about oral health education applications that are available for mobile phones is statistically significant with p-value equal to 0.01. So questions like acceptance of oral health education by patients, reduction in frequency of visiting dentists if the patients get used to mobile health applications, mobile oral health apps are user-friendly and patients get precise and useful dental care instructions through smartphones to stay away from worsening conditions are positively correlated with regard to affiliation with dental college. And coming to the correlation of clinical experience with perception of oral health education application, questions like apps will be useful and convenient to you while providing oral health education to their patients. Then patients will accept oral health education apps if recommended by them. Frequency of visiting dentists might get reduced, and education apps can promote self-directed learning among patients. Then it is mandated to train the dental students among oral health education apps. Then patients can get precise and useful dental care instructions through a smartphone and can stay away from worsening conditions. And health education apps could act as an effective aid. These are the questions that were positively clinical experience. Moving on to the discussion part, oral disease affects billions of people worldwide and mobile phone use is rapidly expanding around the world.
Doctor, you are exceeding the time limit. So kindly conclude. You are exceeding the time limit, doctor.
Yeah, okay.
Kindly conclude.
So coming on to the conclusion, the findings from the study shows positive perception of dentists towards oral health education applications that can be used by patients and also reflected academic and technological platforms for using handheld devices in clinical, medical, and dental settings. So the study concluded that participants of the study having clinical experience of 1 to 5 years have positive correlation with the questions, and participants affiliated with dental colleges have more acceptance in using mobile health apps. So the limitations were this is a cross-sectional study. Further studies with larger sample size to be conducted for generalizing the results. So coming on to the recommendation, most of the apps are only in English languages, so there is a need to develop apps in regional languages. Then dentists should be encouraged to develop and use applications from promoting oral health of their patients. So in the end, I would like to emphasize that the title of my presentation is deeply rooted with the theme of this conference. Of the study has been how dental practitioners view oral health education. By doing so, we are aiming to how oral health is taught and learned worldwide. This is how my work aligns perfectly with the conference theme of exploring innovation in dentistry. So these are my references.
Can you name some apps that can be helpful in promoting the oral health of our patients?
Sorry, ma'am, it's not audible.
Can you name some apps that can be used for promoting oral health of our patients?
Few apps are there. My Smile app, My Dental Care, and already app for both Android and iOS phones, and Moment of Truth for only Android phones.
Okay, thank you.
Thank you, ma'am.
The next presenter will be Dr. Pavan Ravindra Shinde on the topic, a comparison of stress distribution in a mandibular implant supported overdenture with 3 different attachment systems of various heights, a 3-dimensional finite element analysis. Dr. Pavan Shinde, you can please take over.
Okay, thank you, ma'am. I'm sharing my screen. I hope screen is clear for all. Am I audible, ma'am?
Yes, sir, you're audible and the screen is clear.
Okay. Thank you, ma'am. My topic is a comparison of the stress distribution in mandibular implant supported overdenture with using the 3 different attachment systems of various height. And we are using the 3-dimensional finite element analysis, that is in vitro method. Okay. In the last 20 years, finite element analysis has grown in importance as a tool for predicting how stress will affect an implant and the bone around it. In this study, we are going to find the stress distribution in the cancellous bone and cortical bone in which we are placing the implants of the overdenture. So, in this method, there is no need of actual patient it is a in vitro study. And this study has been proved very successful and very important during the COVID era, and especially its importance increases during the COVID and after COVID era. So mastication produces vertical and transverse loads that causes the axial forces, bending moment and stress gradient, stress in the peri-implant region and in the components of implant supported restoration has been studied. We also studied the stress distribution in the implant and in abutment and also in attachment systems. Finite element is numerical stress analysis. In this method, we use the element and we make the node attachments and then we create the mesh formation, as there are diagrams also included further. So this is a 3-dimensional model of the finite element analysis. And in finite element analysis, this is the mesh model. We are able to see this mesh system that each single point is a node and every element combines to form the node. And we calculate the force or distribution of the force at each node. And by using the software, we calculate combined force distribution of the complete structure. Our study hypothesis is that there is an influence of different attachment systems of various height on stress distribution in mandibular implant supported overdenture. Our aim of the study is to study the influence of different attachment systems on stress distribution in mandibular implant supported overdenture. In this modeling, we use a 3D finite element model of mandibular section. We consider the D2 type of the bone. We use the Ostem TS3 type implant, conical implant of 4 millimeter diameter and 11.5 millimeter height, as these are the common sizes we used in our clinic. Attachments, there are various attachments are available, but in this study, we take 3 attachments: ball attachment, locator attachment, and magnet attachment. We apply 100 Newton force in the masticatory region, as it is an average of the masticatory force in all the surface area inside the tooth, inside the oral cavity. And we use the force of 100 Newton at 30 degree to the longitudinal axis of the implant in the buccolingual direction is applied. In implant, we place the implant in the both canine region and we apply the 100 Newton force. We can see that ball attachment, locator attachment, and magnet attachment are used. And for each attachment, we consider various heights also. It means there are 2 variations in this study. First is different attachment system, and second variation is different heights of each attachment system. We consider 1 mm, 2 mm, 3 mm, and 5 mm. And after that, we compare these stress analysis using the finite element software. So this is the ball attachment. This is locator attachment. Ball attachment is more commonly used during the overdentures, as it is easy to use by the patients also. This is the locator attachment, and this is housing. This is magnetic structure and magnetic attachment. So when we compare this force distribution or stress distribution in the finite element analysis study, we can observe that there is a cortical bone and cancellous bone. Force distribution here, clear cut graph is there. Ball attachment, locator attachment, and magnet attachment. We can conclude that here, as the height increases of the attachment, stress distribution decreases. So we can conclude that more the height, lesser will be the stress distribution. Also, we can conclude that there are low value for the ball attachment system, and locator attachment system and magnet attachment system shows higher values for cortical distribution. And we can observe the similar findings in this cancellous bone. ball attachment, locator attachment. Ball attachment contain the lower values, and locator and magnet attachment contain the higher values or bear the higher stress distribution in the implant supported overdenture. So few study also proves that locator attachment is better, but this study actual perform under the software, and we can reprove that the ball attachments are more useful, especially more height of the ball attachment is more useful. And considering the oblique loading also, cortical stress and cancellous stress distribution, cancellous bone stress distribution, we have findings that uh, ball attachment shows the lower values of the stress in the cortical bone, and here the ball attachment also shows lower values in the cancellous bones also when we apply the load obliquely. So we also conclude that after application of the oblique loading, the five ball attachment are more better choice during the clinical implants, and more the height, lesser will be the stress distribution, and better will be the implant results. So we can conclude that we conclude both the things, that is there influence or not. Yes, we have proved already, and we studied that there is a stress influence of various attachment systems of various heights on stress distribution. Plus, we also conclude that which attachment type is better in comparison with these three attachment systems. So aim of the present study was to evaluate influence of the different attachment systems of various heights on stress distribution in implant supported overdenture. The result of the study showed that magnet attachment system showed higher von Mises stresses value. So during this study, we consider the von Mises stresses value of all the materials like implant and bone also, and attachment systems also. We use the locator attachment, we use ball attachment, we also use the housing of the locator attachment. So we consider the von Mises stresses value of the housing also, and by considering all the von Mises stresses value, and ball attachment system showed lowest von Mises stresses value. So ball attachment system, we can say that it is a better system in comparison with the magnet and locator attachment. The results also showed that the height of the attachment system increases up to certain limit. Yes, there is a limit to increase the height. We cannot increase the height about 7 and 10 also. So there is a limit, certain limits. We can increase the height up to 1, 2, 3, or 5 max to max. So the von Mises stresses also decreases. As height increases, von Mises stresses decreases. So within the limitation of this finite element analysis, yes, obviously there are limitations of this finite element analysis, because this finite element analysis is the in vitro study. It is not considered that these 100% values are there in the clinical studies also, or when we use these conditions in the clinical patients, that values cannot be matched 100%. But yes, approximately or near about clinical values, these values also match. Within limitation of finite element analysis, it can be concluded that different attachment system do significantly influence the stress distribution in mandibular implant supported overdenture. And second, different heights of the attachment system also do significant influence the stress distribution in mandibular implant supported overdenture. So these are my references. Thank you so much.
Thank you, doctor. No questions from my side.
Okay, ma'am, thank you. So the next presenter will be Shubhi Gupta on the topic, the assessment of dietary patterns and estimation of serum protein levels in patients with or without habit of tobacco consumption in an in Indian subpopulation, a case control study and a survey-based assessment. Doctor, please share the screen. Dr. Shubhi Gupta.
Can you hear me?
Yes, I'm able to hear you. Kindly share the screen.
Just a minute. Ma'am, can you hear me now?
I'm able to
Can you
hear
see my
you, but You're not visible. The skin is not visible. Just a minute. It is visible. Kindly put it in slideshow.
Yeah.
Ma'am, it's maybe your internet connection is poor. Are you there, ma'am? Should be Gupta, ma'am. Just a minute. I'll just call the next passenger. Just a minute. So the next presenter will be Sneha Madhyalagan on the topic resorbable mini plates versus conventional plates, ease of usage. Dr. Shubhi Gupta, ma'am, you can present in the next slot. Kindly restore your internet connection and join us. Sneha Madhyalagan, ma'am, you can just share your screen. Are you there, ma'am? Sneha Madhyalagan, ma'am.
Hello, ma'am, this is Neha Madhyalagan.
Yeah, ma'am, kindly share the screen.
Yes, ma'am. Just a second.
Ma'am, will it take time? Sneha, ma'am, will it take time? Sneha, ma'am, are you there? Sneha, ma'am? Okay. So, Sneha, ma'am, kindly get ready with your presentation. Maybe you can present next. I'll just move on to the next presenter as it's getting delayed. Dr. Ramapriya, ma'am, will be presenting next on the topic gleaming grids. Ramapriya, ma'am, kindly share your screen.
Ma'am, can you hear me?
Ma'am, can you just wait? I'll just ask Ramapriya ma'am to present. After that, you can join us on presentation.
Okay, ma'am. Sorry, I had some network issues. Yeah, I'll
Okay,
present.
no problem. After Ramapriya ma'am, you can present.
Yeah, ma'am. Okay, okay.
Wait just a second. Yes, ma'am. Thank you.
Yeah.
Is it audible?
Yeah, you're audible and your screen is visible. Kindly present, ma'am.
Yeah, ma'am. Yeah, ma'am. Good afternoon to all of you. So myself, Dr. Rampriya from Savita Dental College. My case is bleeding rings, which is a case report. Mostly, a 27-year-old female reported to our department with a chief complaint of yellowish teeth in her upper and lower tooth region. So her main concern is to change the color of the tooth from yellow to white. No history of similar condition in her family. So the patient was healthy and with no systemic conditions. So she desired the permanent treatment for the same. The case report, we have taken all the pre-operative evolution photographs and the pre-op model was taken. So we are taking the OPG also. In the OPG, we are finalized it is amelogenesis imperfecta. So there are majorly four types of amelogenesis imperfecta, which is we all know that hypoplastic, hypomaturation, hypocalcified, and hypomaturation and hypoplastic with taurodontism. If we all can see in this OPG, we can conclude that it is a hypomaturation type. How I'm saying this is considering a radio opacity, which is more or less equal to the dentine. So we cannot differentiate between the enamel and dentine, like dentine differentiation. It is more of hypomaturation type. In hypoplastic type, we can differentiate it. The same is also the hypocalcified type. So we have taken all the photographs. We can figure out in figure 1. This is the actual when the patient came to our department. So we have taken all the photographs and we decided to do the treatment plan for the patient. We have decided to do first composite veneering for the patient, but the patient wants permanent treatment for the same. So we have decided to do the ceramic veneers for the patient. We explained all these treatment costs and treatment plan to the patient. Then finally, we started prepping for the anteriors and premolars. We were doing first premolar to first premolar in upper arch and lower arch also respectively. So we started doing minimal preparation because in hypomaturation type, the normal enamel shape and the hardness will be there. So we decided minimal preparation for the enamel. We did the minimal preparation respectively. Then we took the 3D scan and sent it to the lab. Finally, we bonded the restoration with enamel, indirect ceramic veneers. Bonding protocols were same as we used the H&Rins protocol because we started the treatment for upper arch a year back. After following it up for 1 year, we started doing the lower arch also because the outcome was satisfactory. We decided to go with the lower arch also. So we were taking the lower arch procedure after following up the upper arch. The bonding protocols are the same. We bonded the ceramic veneer with the Variolin aesthetic LC cement. We use the same in the upper arch also. So results are satisfactory. Can you tell me? Hello?
Yes, ma'am.
Is it audible now?
Yeah.
So we followed it after 2 months follow-up also. The results are satisfactory. The patient has no other difficulties with the biting and the occlusal problems. Patients like functional and aesthetic outcomes are also good. So for the conclusion, every aesthetic cases can be complex, but the rewarding when a patient's smile is created. So the two are in their distinctive way for each patient. For this patient, she is happy with the final outcome. Yeah, this is the final case report of this patient.
Okay, ma'am. Thank you. Ma'am, any questions?
No question.
Okay. Thank you.
Thank you.
Dr. Sneha Madhyalagan, ma'am, you can start to screen your presentation.
Yes, ma'am. Yes, ma'am. Ma'am, I'm not able to share my screen since there's other presenters sharing the screen.
Ramapriya ma'am, kindly stop sharing your screen. Ramapriya ma'am, are you there? Ma'am, are you there? Rampriya ma'am, are you there? Kindly stop sharing your screen.
Yeah, ma'am. I will stop. Done, ma'am.
Yes, ma'am. Sneha Madhyalagan ma'am, you can.
Yes, I'll do. Ma'am, can you see my screen?
I'm not. Yeah. Kindly place it in the slideshow mode and start presenting it.
Yes, ma'am. Can you hear me clearly, ma'am?
Yeah.
Good afternoon to everyone who are present here. Today I'm just doing presenting a short observational study that we did on the topic resorbable mini plates versus conventional mini plates on ease of usage. I'm Sneha Madhyalagan from Tagore Dental College. So mini plates were introduced in the oral surgery in the late 1970s, and since then they've been used for fixation in open reduction of fracture and facial reconstruction. Conventionally, stainless steel mini plates and screws, which is made up of ferrous, chromium, nickel, and molybdenum, were used. And these mini plates have a very rigid property. Even though they've been very commonly used, they have some limitations like corrosive degradations and wear products such as metal ions or particles, which may give rise to biological changes in the tissue adjacent to the implant. And it may even cause mild fibrosis and infection to necrosis of bone. Recent advancement in mini plates are these bioresorbable mini plates. These mini plates can be used in place of conventional plates. However, they are not commonly used because they are much less rigid than the conventional stainless steel and titanium plates. But they do have an advantage of bioresorbable property, which gives us the advantage of not using a second surgery to remove the mini plates. In previous study, they have compared between the conventional mini plates and resorbable mini plates based on their advantages, their properties, biocompatibility, strength. But in this short observational study, we have compared the ease of usage of the material between the conventional plate and the bioresorbable plate. The aim of the study is to compare the ease of usage among resorbable plating system and conventional stainless steel plating system. The objective of the study is to estimate the time taken for the fixation of conventional plate and resorbable plate using a stopwatch. Materials used were stopwatch. Since this is an observational study, teachers use a stopwatch to calculate the time the surgery was
Your
performed by
slide
the.
is not moving.
Ma'am, which
Still
slide is it in, ma'am?
still you are in the first slide.
Ma'am, kindly put it in the slideshow format, ma'am.
It is in the slideshow format only, ma'am.
But you're not able to see the other screens, these other slides. It's just in the introductions, the first slide.
Okay, ma'am, I think there is some network issues. Let me try again. Is it visible now, ma'am?
No, ma'am. Yeah.
Let me try again. Is it visible now?
Yes, it is. Maybe in a slideshow.
Let me put it in slideshow. Is it visible now, ma'am, if I put it in the slideshow?
Can you just change the slide? Just change and
Now?
see. No, it's just stuck in the material slide. Just change to the 5th slide.
Yes, ma'am, I'm changing, ma'am.
But it's not getting changed here, doctor.
But maybe if I don't put it in the slideshow, can you able to see it?
Okay, now change.
Now?
Yeah.
Can I present it as such without putting it in the slideshow?
Yes, doctor. We are running short of time, so yeah.
Okay. So the materials that were used were a stopwatch because I was just doing an observational study. In this study, we included parasymphysis fracture, which required open reduction and internal fixation. The exclusion criteria were people who are contradicted to general anesthesia, communicative fracture, metabolic bone disorder, and pathological fractures. The study was conducted in the Department of Oral and Maxillofacial Surgery in Tagore Dental College for the past 6 months, and the sampling method was simple random sampling, and it was an observational study. The procedure that we did was we selected 6 patients with parasymphysis fracture, and they were randomly categorized into 2 groups irrespective of age and sex. First group, 3 patients, they had surgery done with conventional mini plate system, and in the group 2, 3 patients were done with a fracture fixation with resorbable mini plates, and the time taken for the fixation was calculated using a stopwatch. The time duration was calculating from the beginning of the fixation process to end of the plating. And the result we obtained was in group 1, first patient had 3.25 minutes, second patient was 2.55 minutes, and the third patient was 3.40 minutes. And in group 2, the first patient was 5.3 minutes, the second patient was 5.4 minutes, and the third patient was 6.10 minutes. So the mean time duration for stainless steel plate were 3.6 minutes, and in the mean time duration for the resorbable plates was 5.63 minutes, which was high compared to the stainless steel. So the mean time duration taken for the fixation of conventional steel was much lesser. There may be a learning curve for the surgeons who are accustomed to working with metal implants, as technique for placement and fixation for the resorbable plates can differ. Placing a resorbable plate can be challenging due to their unique properties and characteristics compared to the traditional metal plates. These resorbable mini plates are often very less rigid than the metal plates, which make them more difficult to and time consuming to manipulate and position them in the proper place. So there may have different handling characteristics compared to metal, which may requires the surgeon to adjust their technique and instruments accordingly. And metal plates are rigid and they provide immediate stability upon fixation, making them easier and less time consuming to manipulate and position during surgery. Although resorbable mini plates pose numerous advantages like resorption within few months, and there is no requirement for second surgical process, they are still in terms of time consumption, they are still more time consuming than conventional stainless steel plates. And conventional mini plates are still preferred by most surgeons due to the rigidity, familiarity in technique, durability, versatility in shapes, and consistent outcome of the surgery. Thank you.
Ma'am, any questions?
No, you can proceed.
Okay, ma'am, thank you. The next presenter will be Shubhi Gupta, ma'am. Dr. Shubhi Gupta, ma'am, kindly share your screen.
Yes, ma'am. Yes, ma'am. Ma'am, is it visible?
Yeah, ma'am, it is visible. Just put it in the slideshow mode.
Yeah, ma'am. Is it visible now?
Yes, it is visible and you're audible too. Kindly
Yes.
present.
Greeting esteemed judges and fellow participants. I'm honored to present my research for consideration in this competition, the topic for which is assessment of dietary patterns and estimation of serum protein levels in individuals with and without habit of tobacco consumption and with and without tobacco related lesions in Indian subpopulation, a case control study and a survey based assessment. This is an overview where we'll go about the introduction, research questions, objectives, methodology, findings, and conclusion. So, cancer has been most emerging problem all over the world. We can see that according to Indian Cancer Society, the incidence of oral squamous cell carcinoma is 3% in the United States, and in India records more than 1 lakh cases of oral cavity cancers every year. It has highest prevalence of oral cancer across the world. Introduction. The projected incidence cases for tobacco-related cancer by 2025 would be more than 4,27,000 by ICMR. Prolonged exposure to tobacco to the oral mucosa leads to carcinogenic alterations, elevating the risk of lesions like leukoplakia, tobacco pouch keratosis, smoker's palate. Although biopsy stands as a gold standard in assessing the oral cancer and precancerous condition, but the need of the hour is to come up with the fast and less invasive techniques for earlier detection of oral cancer and precancerous conditions. Molecular markers undoubtedly play a crucial role in detection of cancer. The role of molecular marker in tobacco-related lesion is limited and thus needs a further investigation. Protein oxidation plays a vital role in oral cancer pathogenesis, with hypoproteinemia, termed as cachexia, commonly observed in oral malignancy. Dietary nutrients exhibit specific mechanism, either protecting against or increasing the cancer risk. For instance, fruits and vegetables reduce oral cancer risk, while pro-inflammatory diet rich with red meat and fried food increases it. This will be a pioneer study to assess the dietary pattern and determine the serum protein levels. So our research in question was, is serum protein altered in individuals with tobacco habits and related products with oral potentially malignant disorder and individuals with tobacco habits and related products without lesion? And is there any association between dietary patterns, altered metabolism, and risk of oral cancer in an Indian subpopulation? Our objectives for the same were to evaluate and compare the levels of serum protein and dietary patterns in individuals with the habit of tobacco and related products with OPMD, with habit of tobacco and without oral mucosal lesion and healthy controls, and to find an association between dietary patterns and level of protein in the serum of the individuals of the same groups. In methodology, research design was a questionnaire and a case control study. Research instruments used were validated and pre-tested questionnaire and kit for analysis of total protein and albumin. Participants were Group 1 individuals with habit of tobacco and related products with oral potential malignant disorder. Group 2 individuals with habit of tobacco and related products but no mucosal lesion. Group 3 were healthy controls. Study setting was in the Department of Oral Pathology and Microbiology of a reputed MUHS recognized dental college. Method of selection. So in inclusion criteria, we included individuals aged 20 to 60 years of age requiring routine hematological examination for dental procedures like extractions and minor surgeries, tobacco users, or without associated lesion. Exclusion criteria were patients having hypertension and diabetes or were having any systemic treatment for oral potential malignant disorders, pregnant individuals, and those with any systemic illness such as thyroidism and hepatitis. The data collection was done. Prior informed consent was obtained before the dietary survey entry by dietary survey entry, and blood collection and ethical clearance for the same was obtained. Sample size was obtained statistically. The following samples were analyzed: 19 individuals from group 1, 7 from group 2, 17 from group 3, out of which dietary survey was filled by 20 patients and rest did not consent or cooperate to fill the questionnaire. Data analysis, intergroup comparison was done using one-way ANOVA, followed by a pairwise comparison using post-hoc test. Comparison of frequency of categories of variables with groups was done using chi-square test. So in findings, we found out that serum total protein of group 1, that is habit with OPMD, had low total protein as compared to group 2 and group 3, though the results were not statistically significant. Serum albumin, however, in group 2 showed altered albumin as compared to group 1 and group 3. Since it was a pilot study, we could not get much of the sample size, and we were piloting, so data could not be statistically significant. Dietary patterns, we found out in the dietary patterns that the group 2 patients were found to be having protein-rich diet in meat, seafood, paneer, pulses, and group 1 patients were found to be having junky food with more frequency than group 2 and group 3. Concluding that metabolic alteration is seen wherein serum total protein is low in group 1 patients, that is habit with OPMDs. Diet thus play a crucial role in risk of cancer. Protein-rich diet has shown to reduce the risk of incidence of OPMD. We are further investigating to explore other aspects in cancer protection, such as we are also expanding our research in evaluating serum cholesterol, serum triglyceride, and some antioxidant enzymes. In discussion, to just say that in healthy humans, a state of equilibrium is maintained by oxidants and antioxidants. Nevertheless, in a typical state, an overabundance of oxidizing agent is generated, leading to inhibition of antioxidant defenses. Early detection offers the opportunity for timely intervention, potentially preventing the progress of cancerous lesion. Dietary nutrients exhibit specific mechanism, either protecting against or increasing cancer risk. In conclusion, and despite the research limitations, the beneficial effects of diet rich in vegetable and fruits are attributed to different micronutrients that are also found in fish and animal products. These compounds show antioxidant, anti-inflammatory, anti-angiogenic, anti-proliferatory properties that have prevented growth in development of oral and other types of cancer. These are my references. Thank you so much.
What's the reason for selecting 20 to 60 years?
What, ma'am?
What's the reason for selecting 20 to 60 years population?
20 to 60, ma'am, because above 60, there are chances of metabolic alteration. There are comorbidities associated with more 60 plus individuals, and below 20, we do not find patients having tobacco, and because in young age individuals below 20, it's a rare finding to find patients with a habit of tobacco. So,
okay, thank you.
Thank you, ma'am. The next presenter will be Dr. Saranya Sivraj on the topic missed anatomy. Hunt it out. Saranya, ma'am, kindly share the screen.
Yeah, I'm sharing them. Just one second.
14 participants.
1 second. Just 2 minutes. There is some error in my screen. 1 second.
Then I'll do one thing. I'll go to the next presenter and come back to you again. Is that fine?
Sure. Yeah, sure. Thank you.
The next presenter will be Amrita R. She'll be presenting on the topic use of dental laces among teaching faculty of private dental colleges in Chennai, a questionnaire-based cross-sectional study. Amrita ma'am, kindly share your screen.
Yes. Is my screen visible, ma'am?
Yes, kindly put it in the slideshow mode. Thank you, ma'am. And you're audible also, kindly present.
Okay. So, good afternoon, everyone. My topic for today's presentation is knowledge, attitude, and practice of dental laser among teaching faculties in private dental colleges in Chennai, a cross-sectional survey. Introduction. So, laser. Laser stands for light amplification by the stimulated emission of radiation. Lasers are being widely used in medical as well as in dental field for the past 60 years and has recently risen in the popularity. So laser creates light energy in a very narrow and focused beam. So one of the ways to minimize the spread of infections is the use of lasers. The uses of lasers are treating hypersensitivity and in hard tissue applications such as cavity preparation, removal of restoration, etc. And in soft tissue applications, it also aids in wound healing and removal of hyperplastic tissue. And it also is used in whitening of teeth and disinfection of canals. So the aim of the study is to assess the educational level and knowledge of lasers in dentistry among teaching faculties of private dental colleges in Chennai. And the objectives of the study is to assess overall knowledge on the uses of lasers in dentistry and knowledge on specific uses of lasers in different branches of dentistry, level of knowledge in laser protection, and attitude and interest towards laser practice among dental faculties in Chennai. Materials and methods. After getting approval from the Institute Ethics Committee, a cross-sectional survey was conducted, and the self-administered validated questionnaire consisted of questions regarding the dental lasers were designed and answered by 385 teaching faculties. The inclusion criteria for this study was to include all the dental teaching faculties who are willing to participate in the study. The questionnaire pertained to include demographic data like age, sex, years of experience, and knowledge, attitude, and practice of healthcare professionals with regards to lasers among various private dental colleges in Chennai. So the results of the study, based on years of experience, the study sample was 385. So among 385 dental teaching faculties, 30 of them had experience which was less than 1 year of experience, and 150 of them had experience within 1 to 5 years, and 151 of them had teaching experience between 5 to 10 years, and 54 of them had greater than 10 years of experience. Composition of study sample based on gender. 49% of the study sample were female, and 51% of the study sample consisted of. Am I audible? Yeah. So awareness about lasers among dentists. Out of 385 dental faculties, 383 of them had heard about laser treatment in dentistry, and 381 of them wish to learn more about laser usage in dentistry, and 213 of them has seen laser being used in the field of dentistry. While comparing with the years of when a question was asked about their knowledge on lasers, 151 of them felt that they don't have sufficient knowledge on lasers, and 275 of them were aware about the expansion of laser, and 324 of them felt that laser should be a part of undergraduate curriculum. When we compare the years of experience and then and their knowledge about lasers, out of 234, 18 of them felt that they have knowledge about lasers with less than 1 year of experience, and in 1 to 5 years experience group, 97 of them had sufficient knowledge on lasers, and 5 to 10 years of experience, 89 of them, followed by 30 of them from greater than 10 years of experience. When question was asked about the usage of laser in fields of dentistry, 372 of them, that is most of them, felt that lasers were used mainly in the endodontics and operative dentistry department, followed by oral surgery, and least commonly in oral medicine. When the effects of lasers are reduced, it reduces pain, reduces edema and accelerates wound healing, reduces herb simplex blisters, and reduces sinusitis. When this question was asked, 96% of the faculties felt that it reduces pain, followed by 74% of them stating that it reduces edema and accelerates wound healing, and 68% of them stated reduces herb simplex blisters, followed by 33% of them stating reduces sinusitis. So when the question was asked on what will be the efficient methods to gain knowledge about laser, 121 of them suggested that hands-on course is the major efficient method to gain knowledge about lasers, followed by course modulus for few months. And some of them felt that postgraduate studies will be helpful to gain knowledge about lasers. And 58 of them suggested that CDE programs will be an efficient method to gain knowledge about laser. So drawbacks in using laser, 157 of them, most of the faculties felt that cost factor was the major drawback in using laser, followed by insufficient knowledge, and 62 of them felt that patients' poor acceptability is a major drawback, and poor results was also a drawback. Discussion. So in this study, 70% of the dentists thought that they have sufficient knowledge about laser being used in dentistry, and 30 of them felt that they don't have sufficient knowledge on lasers. In a similar study conducted by Bagheri A in Ardabal City 2015, 94% of the dentists have knowledge about use of laser in dentistry. And in another study by Tosan et al. 2012 Turkey, in contrast to this study, in that study, the results were dentists with higher levels of education tend to have more information about the use of lasers in dentistry. So the conclusion of the study was overall dental teaching faculties who have greater than 1 to 10 years of experience have better knowledge than faculties with less than 1 year and greater than 10 years of experience. There were certain limitations to the study, which was categorization in terms of experience was not equal, and they have did this study only in the private dental colleges, and government dental college teaching faculties were not involved in the study. So that being the limitations of the study. Some of the recommendations will be including the usage of dental laser to the curriculum with use of correct wavelength, laser safety glasses, proper face masks and face shield, and use of high-speed evacuation equipment will modify traditional methods to new technologies. So the theme for this conference, 6th International Conference on Dentistry and Oral Health, is exploring global health innovations in dentistry from research to practice. So to conclude the presentation, the lasers with their precision, versatility, and minimal invasive nature have already become invaluable tools for various procedures, including cavity preparation, soft tissue surgeries, and periodontal treatments. As research and development continue to push the boundaries of laser technology, we can anticipate even greater integration of lasers into routine dental practice. Future advancements may include enhanced wavelengths for specific applications, improved ergonomic designs for easier use, and innovations in automation and robotics to further streamline procedures. With each new development, lasers are poised to continue transforming dental health care, providing patients with safer, more comfortable, and more effective treatments while empowering dental professionals to achieve unprecedented levels of precision and efficiency. As we look ahead, it's clear that lasers will remain at the forefront of innovation in the dental field, shaping the future of oral healthcare for years to come. These are my references, and thank you for illuminating the session with your presence. Thank you.
Thank you. No questions from my side.
Uh, And any presenters who are left out and you are still in the meet, kindly inbox me. Presenters who are yet to present and you were not able to present, or anyone who has left out, kindly inbox me.
Ma'am, this is Dr. Saranya. I am at
Yes, ma'am.
I'm over here, ma'am.
Yeah, ma'am. Can you just present now? Is
Yeah,
everything
sure.
ready?
Yeah,
Yes,
yeah,
ma'am.
yeah. It's
Kindly
ready.
share the
Thank you.
screen, ma'am.
Thank you, ma'am. One second. Ma'am, is my screen visible, ma'am?
Yes, ma'am. The screen is visible as well as you're audible too. Kindly present, ma'am.
Yeah, thank you. Good afternoon, all. I'm here to present about missed canal, hunt it out. Introduction. Well begun is half done, quoted Aristotle. And this statement holds true even today in modern day endodontics. Why? Because the importance of a well executed access cavity preparation cannot be overemphasized, because the ideal access cavity needs to be prepared to provide a smooth and straight line path to the canal system and ultimately till the apex of the canal. So locating the canal orifice is a crucial and a critical step during the access cavity preparation. And also, as we speak about the endodontic failures, they are multifactorial in nature, which means that many causes might be there, like microorganisms or whatsoever. But studies have shown that statistically there has been a significant failures that have occurred in root canal treatment, mainly due to the failure to localize the canals, that is localize and as well treat all the canals. Therefore, we need to keep in mind that the importance of locating all the existing canals within the root canal system has to be done to achieve an optimal prognosis and also to lower a potential negative effect of the untreated canal. If there is an untreated canal left behind, then the result of that would be failure in that case, leading to the endodontic retreatment, which would be anxious and as well as tiring both to the clinician as well as the patient. Therefore, the risk of missing the anatomy during the root canal treatment is high because of the complexity of the root canal system. And certainly when we speak for the missed canals usually hold the irritants that are inevitably contribute to the clinical symptoms, attachment apparatus disease, and radiographic lesions of the endodontic origin. And if we see for over the past decades, there has been many technologies that have improved in our field of dentistry to improve the clinical performance of the dentist through their breakthroughs. But however, it will become meaningless if a practitioner is unable to identify a specific orifice underlying the canal or the root canal system. And overall, to see for, it means that we, as a dentist, we should have a better understanding of the tooth morphology, therefore, which will favor the search for the root canal inside the tooth. To attain all these, there are many steps, but to press for, the first and the foremost one is the modifying the access cavity. First, what we mean by access cavity is that the part of the cavity from the occlusal table to the canal orifice. That is, the orifice of each canal must be visible, and also it should be easily accessible for the instrument placement, further procedures to be continued for. And if there is any hindrance over there, we need to modify the access cavity accordingly. And also to say for, to modify the access cavity, we also can keep in mind about the diagnostic aids. Though there are many diagnostic aids starting from the examination instruments up to the recent advancement of CBCT and microscopes, starting from the conventional method, the radiographs are the preliminary one. And to speak about the radiographs, the preoperative radiographs should be carefully examined to determine the anatomy of the individual tooth. That means that must be the primary point in our mind whenever we see a radiograph. And also, when we see for, although these periapical radiographs are two-dimensional images that obtained from the three-dimensional root canal system, their interpretation is quite good enough because it reveals an external and internal anatomic details that will suggest the presence of extra canals and or the roots. It could be either the canals, either the roots, or it could be both. So we'll be able to conclude to an idea in the beginning itself when we see the periapical radiographs. And For a careful evaluation of the root canal morphology, we should at least take 2 periapical radiographs using the paralleling technique. That is using either a mesial or a distal horizontal tube shift. And after a radiograph is taken, if we see a sudden change in the radiographic density of the pulse space, usually it indicates that there is an additional canal. Otherwise, if there is a sudden narrowing or even disappearance of the root canal space, that indicates that there is a bifurcation or trifurcation, so that we can plan our treatment accordingly. And moving on to the conventional of radiograph, to the next one is a microscope. As every one of us know, now in the recent advancement, microscopes and loops are going into a marvelous change. So the use of operating microscope, dental operating microscope is there. Mainly, it will remove any guesswork that has been existed previously in many areas of endodontic treatment. And one of the biggest advantages is that it increases the possibility of locating the calcified canals and or as well the additional canals, so that it will give intimate detail of the root canal system. Thereby, we can do a thorough cleaning and then debridement can be carried out, eventually leading into the obturation. And next on to the microscope, the CBCT, that is a cone beam computed tomography. Though periapical radiographs, IOPA may provide a two-dimensional view and an excellent one in the beginning, the CBCT provides a three-dimensional view. And to list out, we can say some 2 or 3 major advantages are there. First, it will identify the root canal system anomalies, and also it will determine the root curvature. And in cases of endodontic retreatment, to locate the missed canals or the extra canals. For example, if we need to find out MB2 or a middle mesial canal, in such conditions, the CBCT would be more helpful. The third thing is it will be helpful in verifying the patency of the calcified canals. And lower, I have shown about a clinical scenario which was done by me. So the first one is a preoperative radiograph. There clearly we can see that one canal has been completely left for. The remaining 2 canals only have been obturated, whereby the lesion has prolonged, and also we can see that in the adjacent tooth also the caries has not been completely excavated and filled for. So the missed canal alone was identified, the other 2 was not disturbed. And then the post-operative radiograph, we can see that there is a complete 3-dimensional obturation till the apex, and also the puff has been formed in one of the tooth. So I would like to conclude that the elusive root canal entrenched within the confines of the pulp chamber challenges the expertise or even to the best of the endodontists. So not detecting it can lead to the failure of the treatment. And we can say that the pathways of the pulp are varied, and the responsibility actually falls on the clinician to locate them so that they can be cleaned, shaped, and filled. And a combination of a preoperative radiographs, the diagnostic tools, the clinical tips and methods can aid the endodontist in the hunt for the hidden root canals. Thank you so much. Excuse me, ma'am?
Yes, ma'am.
Yeah, thank you so much.
No question. Thank you.
Thank you.
Thank you, ma'am.
Thank you.
Are there any other presenters who are left out for presentation? Is there anyone like that? Any presenters out there who need to present? Any presenters left out? So this meeting will be adjourned. So kindly tell me if there are any presenters who are left out for the presentation. Ma'am, then fine, we'll end the meeting because no one
Yeah,
is
no one is
responding.
responding. Okay, yeah.
Yes. Yes, ma'am. Thank you, ma'am.
Okay.
Thank you for your valuable time and for your extreme cooperation and your patience, ma'am. Thank you.
Thank you.
I thank every participant for joining us today and making the conference a grand success. Hope you had a great session. Thank you is such a prayer that cannot be seen or touched. It must be felt by heart. I feel honored and privileged to get the opportunity to propose a vote of thanks on this special occasion. I would like to thank all the honorable dignitaries, committee members, and invited speakers who blessed us with their presence. I'm also thankful to all the attendees for both the days of conference. If time is money, then today you have spent million for us. Thank to all of you for making this event successful today. Thank you. Have a great evening.